BLK Pediatric प्रैक्टिस खोलो अपने फोन से, जो हमारा वेबसाइट है।
वेबसाइट है।
मैं कुछ दिखा रहा है, लाइव आ रहा है।
किसमें आएगा? यूट्यूब
का लिंक भी बना दिया वहाँ पर। मेन्यू खोलो। हाँ, ये आप खोलिएगा। इधर से स्टार्ट हो गया। इधर पे नहीं आया। चलो देखते हैं। अरे मेरा फोटो आ रहा है? ठीक। अपने म्यूट फ्लैश हो गए मीटिंग।
Good morning, Dr. Vipul. Dr. Vipul? फुल है इसका वॉल्यूम मैं फुल किया होगा
हेलो
हेलो
हाँ डॉक्टर विपुल हाय
हे
कैमरा लाइट एवरीथिंग इज ऑल फाइन माइक इज फाइन
हाँ एवरीथिंग इज फाइन मेरी आवाज क्लियर आ रही है
आपकी आवाज बहुत क्लियर है
ठीक है थैंक यू
Good morning. Good morning. Can you hear me? Good morning.
Good morning, ma'am.
Can you hear me?
Yeah, ma'am,
Hi,
I'm
Rajni.
able to
Can
hear
you hear me,
you.
Rajni?
Yes, ma'am. Good morning. I'm able to
Okay,
hear you.
thanks. Good morning. Okay, good morning. Good morning. How are you doing?
I'm doing good, ma'am. How are you?
Yeah, I'm fine. I'm good.
You look too weak, ma'am. Your health is all fine. You're doing good.
It was not fine last year. Now it is fine. Sort of. Gone through a lot. Medical issues, surgical issues and all. Now it's okay. That's okay.
Good morning, ma'am.
Good morning. Good morning, sir. रजनी रजनी मेरा स्पेलिंग में सिंगल एफ लगवाया तेरी पिटाई करूं
ये
मुझे नहीं पता यार कोई बात नहीं अभी कुछ मत करना मैं वैसे आप पुलिंग लेके
तो
कुछ नहीं करना दिस इज स्टिल डिसेंट somebody wrote me SEPHALI मैंने कहा सत्यानाश कर दिया पूरा नाम का नहीं but I was just pulling her legs up because she was there with me for long na thanks for having me over Dr. Bhasin.
Welcome. You're always a pleasure to have you around.
Good morning, sir.
Thank you.
Good morning, Dr. Dinesh.
Thank you, sir.
डॉक्टर बसीन रजनी कैसा कर रही है
हाँ क्या कह रहे हैं आप
रजनी कैसा कर रही है
क्या कर रही है
अच्छा कर रही है कि नहीं कर रही है
बहुत अच्छा कर रही है
बहुत अच्छा कर रही है आई वांट टू बी प्राउड ऑफ माय स्टूडेंट्स सो आई फील शी हैज बीन अ वेरी सिंसियर हार्ड वर्किंग पर्सन शुरू से
she is very sincere and hardworking and she gets along gels very well with the department so now
पेशेंट के साथ तो बढ़िया है पेशेंट के साथ तो बड़ी अच्छे हैं
पेशेंट के साथ तो बहुत टाइम देती है आई थिंक नंबर ऑफ patients which wait for her even during this covid period she had a lot of video consults going on like बाकी लोगों का उतना नहीं था but she was regularly on video consults
that's really very nice I feel very happy about it because
well
they have to take the legacy forward right
yeah
मैं ये मोबाइल को साइलेंट करने की देख रही हूँ मेरे को अभी पता नहीं डॉक्टर बसीन आप लोग देख रहे हो कि नहीं, हमारे पास ना बहुत भयंकर टीबी के केसेस आ रहे हैं, मतलब रियली बैड कॉम्प्लिकेशंस. अभी भी आई वाज जस्ट टॉकिंग, वी हैव हैड समबडी जिसका पूरा ओडोंटॉइड प्रोसेस हट गया है because, and you know, even yesterday we had somebody with a peritracheal abscess. मतलब it's really bad. I have a feeling that people have not been going during COVID time to, you know, seek innocuous complaints के लिए, and then, you know, ending up with the
medical
problem.
care has suffered a lot. I mean, initially because of post lockdown and later on because of the travel restrictions, उसके बाद खुद का डर, बच्चे fortunately they have been healthy, but otherwise healthcare as far as pediatrics is concerned, it is very much neglected.
I think वो vaccination भी बहुत वो रह गए होंगे ना, vaccination में lag आ गया होगा ना.
All over, हमारे private sector में भी, government sector में भी तो more than 50% lag है.
प्राइवेट में कितना lag है, मतलब lag तो होगा.
हमारा भी I think अब we have caught up किया है. Otherwise initially तो was more than 50%. Now I think 30% delay है. अंकुर इसमें silent. Airplane mode.
Ma'am, are we still enrolling SMA patients?
बेटा न्यूसिरेसिन का अगर लेस देन जो न्यूसिरेसिन नहीं, वो जो जोलजेस्मा के लिए लेस देन 2 years कोई है तो इमीडिएटली बता देना, बिकॉज दे हैव अ ग्लोबल एंड जो खत्म होने वाला है, राइट. और वन मोर पेशेंट इज गॉट सिलेक्टेड and but you know 2 had died before the medicine could come, and वो स्पिनरजा का ना अभी खुला है, so it is
डॉक्टर अग्रवाल
it's on till 7th March. वो आप देख लो, भेज देना अगर है कोई, अर्जेंटली भेज देना कोई अगर है. मैं आपको इंक्लूजन दोबारा भेज रही हूँ, एल्यूमिनाई में भी है, that you send immediately SMN2 copies के साथ, देख लो. It's open till 7th March.
Because we have an adult neurologist in our hospital. He was asking me, can we send a...
Yes. You can give him a mail. I will. They have asked, क्योंकि SMA3 वाले भी जो लेकिन जो बैठ सकते हैं, right? उनको ले रहे हैं. तो अगर कोई है
SMA2 वाला एक बच्चा था उनके पास.
3 होगा बेटा. हाँ बोलो, उसको मेल दे दो, फॉरवर्ड करें, है ना. ठीक है, वो इंक्लूजन देख लो बेटा. 7th March को अपलोड करना है, तो आपको पहले भेज दें.
आपने इंट्रोडक्शन देना है ना.
Screen is hanging.
Ma'am, there is no audio. Audio is not coming.
Hello. I think if all the panelists and chairpersons are there, we like to start.
Good morning, Dr. Agarwal.
Okay, I think we have a fairly good number. So, okay, good morning everyone, and welcome to this BLK Pediatric e-update. I know you have been sick and tired of attending webinars, but we were really reluctant about hosting this e-update instead of the regular, say, pediatric updates which we hold every year. But seeing the prevalent COVID conditions and still a lot of healthcare workers not fully vaccinated and not fully yet aware how much the vaccinated individuals can yet transfer the infection to others. So in the interest of everyone, we decided to hold this as a e-update. And thank you very much for all of you on coming so early to join and attend this pediatric update. I'm sure in the next few months, when things will be better, we'll hold a physical meeting where we can see more of each other. And it is a great feeling when you see the audience directly and see their reactions. But unfortunately, in the present circumstances, we have to continue with this phase. I welcome all of you and thank the Indian Academy of Pediatrics, Delhi, and the Indian Academy of Pediatrics Central Branch, Delhi, to have collaborated with us for hosting this event. And now, on behalf of BLK Pediatric Hospital and the Center for Child Health, we are making this a shorter version because I know staying in front of the computer without leaving your seats or without interacting, without a break, it is difficult. So we'll have about 4 hours session. We have tried to make it interesting and interactive for you. I hope you enjoy and go back and rest. We have a very excellent faculty as well as chairpersons from esteemed institutions who will come and address your concerns. If you have any, you are free to raise your questions through the chat box. And now, without any further delay, I'll hand it over to the Secretary of IAP Central Delhi, Dr. Naresh Lal, to take over the proceedings and introduce the first session. Thank you.
So, thank you, Dr. Basim. So, I welcome all the delegates and attendees and moderators and chairperson to this wonderful session. So, as Sir has already mentioned, this is our first e-update in view of the Corona times. So, we have today 6 topics, and all the topics will be chaired by esteemed guests. And I request everyone to stick to the time what has been allotted for the talk. And at the end of each talk, we'll have a question and answer session, and we can clear our doubts. So I think it's already time. So let's start with the first session. I'll just introduce the chairpersons. So the chairpersons, we have Dr. Shefali Gulati and Dr. Dinesh Goel. Dr. Shefali, as you all are aware, she's an esteemed faculty. She is the head of the neurology program in AIIMS, and she has been awarded a long list of awards. And our second chairperson is Dr. Dinesh Goel.
Secretary. Down the way that happens.
So the session will be moderated by Dr. B.B. Agarwal. He's Associate Director in BLK Center for Child Health and past President of IP Central Delhi. And our other panelists are Dr. Sanjeev Chetri. He's the consultant in NICU at BLK Hospital. And Dr. Rajni Farmania, she's a consultant pediatric neurology at BLK Super Specialty Hospital. She has also done DM from AIIMS, and she's a student of Dr. Shefali. And myself, I'm Dr. Naresh. I'm a consultant in pediatric ICU and present secretary of IP Central Delhi. So I will request Dr. B.B. Agarwal to start the session, and we'll take the questions along. Thank you. Over to you, Dr. Agarwal.
Thank you, Dr. Naresh, and good morning to the chairpersons, Dr. Shefali Gulati and Dr. Dinesh, to start the session.
Good morning, sir.
Good morning.
I would thank Dr. Bhasin and Dr. Agarwal for having me over. Having a seizure is very catastrophic for the parents, to have a child seizuring in front of them. And I think that's the most common office practice, from the neurology point of view, which all practicing pediatricians see. So I think what Rajni would be starting off with an approach to first unprovoked seizure in child is very important, because every seizure will not go into epilepsy. So we have to be clear when to start and how to do. So approaches are different. And this is very, very important for everybody as a practicing pediatrician to understand. Dr. Rajni.
Thank you, Dr. Shefali, for the introduction. Approach to a child who has experienced first unprovoked seizure. Sorry for interruption. Approach to a child who has experienced first seizure is an important endeavor in clinical pediatric neurology practice. Overall prevalence of epilepsy in India is estimated around 5%. 4 to 10% of children experience at least one seizure in first 16 years of life. Approximately 1/3 to 1/2 of the children will present following a single seizure. In 10 to 12%, first seizure will be status epilepticus. How will you define a seizure? Seizure is defined as a transient occurrence of signs and or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. In children, it is essential to differentiate seizure between two categories, provoked and unprovoked seizures. Provoked seizures is precipitated by a specific trigger, such as fever, central nervous system infection or tumor, intoxication, head injury, some metabolic problems like hypoglycemia, hypocalcemia, hypernatremia. While unprovoked seizures are not associated with any obvious precipitating cause, chances of recurrence are high, may be related to epilepsy. When the child comes in emergency or an OPG and ictal event is established, certain questions comes into the mind, whether treatment by anti-epileptic drugs should be started or not. What is the risk of having repeat seizure versus risk of giving regular anti-epileptic medicines? What should be the duration of these medicines? Like so many other questions. We need to find answer to these important considerations before we start medication. In this session, we will present few cases and we will have discussion not only on these cases, but as well as some preset questions from our esteemed panelists in order to achieve a clear-cut understanding of first unprovoked seizure. Let me start the session by asking first question to Dr. Rajni. Dr. Rajni, how many seizures defined first episode? Dr. Rajni?
Good morning, sir.
Good morning.
Dr. Ajit, the question is directed to you.
Achha, okay.
Dr. Rajni, how many seizures defined
Yes,
first
so the
episode?
question is that
You are not audible.
however, there are multiple episodes within 24 hours is also classified as first seizure according to International League Against Epilepsy. And we should make every attempt to know that whether the seizure is a real first event. At times it happens that child might have a prior episode of giddiness or sudden unresponsiveness or loss of consciousness, which the parents might not have taken real notice. And this time the child
I think some net issues. Your voice is not audible, Dr. Rajni. Okay, I will conclude. The first seizure is a seizure flurry occurring within 24 hours with the time
Hello?
to patient.
Hello?
Hello? Hanji.
Hello.
Hello? Now it is audible, Dr. Rajni.
Sir, are you able to hear me?
Now you are.
Yes.
Yes. Please continue.
Hello. Okay. So I was speaking that we should make every attempt to understand that this is a real first seizure and no prior episodes have been missed. So this is how we go. So multiple episodes in 24 hours is also classified as first seizure.
How will you define epilepsy?
In a child who has seizures, we should be able to make an attempt whether the child has a propensity of epilepsy or not. And how do we define it? This is by International League Against Epilepsy. They have given 3 defining criteria. One is if the child has 2 episodes of unprovoked seizure occurring more than 24 hours apart. This is a clear that we all know. The second criteria is if the child has only first episode of unprovoked seizure, can we still say that this is a child with epilepsy? If the child has, by the clinical or investigation criteria, increased risk of recurrence, that is at least 60%, then we can still say, even with the first episode, that the child has epilepsy. The third criteria is if even at the first go, we are able to make a diagnosis of typical epilepsy syndrome. Suppose, for example, adolescent comes with multiple episodes of, if an adolescent comes with one episode of generalized seizures, and we see that in EEG, the child has typical absence epilepsy. So even at the first go, we can say that the child has epilepsy syndrome and child has epilepsy. So these are the three typical criteria which are defined by International League Against Epilepsy to say that the child has epilepsy.
Next question is, what is the recurrence risk after unprovoked seizure?
Yeah. A child having first episode of seizure, what are the chances that the child will have another episode of seizure is 30 to 50% over next 2 to 5 years. This also implies that at least 50% of the children will not have seizures in the coming years. And if a child has had 2 episode seizures, then having a risk of third seizure will be around 60 to 70%. That is pretty high. And if a child has had third seizure, then the risk of recurrence is 70 to 80% over the coming years. And if we start treatment with the child having seizure, then it reduces the risk of recurrence to at least 0.5%. And what are the cases where the increased risk of recurrence can happen? These are the cases which have abnormal EEG, or the child has symptomatic etiology. That means the child has abnormal neurological examination or something, any abnormal structural pathology in the MRI. So these are the predictors of increased risk of recurrence.
What is the latest seizure classification? Sorry, Dr. Shefali wanted to say.
Yeah, sir, I may just add that, in increased recurrence risk, if a child is having intellectual disability, or if there's a seizure semiology like a focal seizure, or you see spike wave discharges on EEG, then the recurrence risk becomes 80 to 90%, and 75% of recurrences will occur within the first 6 months, and very few after 2 years. I mean, this I have a little bit of an idea when approaching these patients. Yeah.
Thank you for your contribution. Dr. Rajni, what is the latest seizure classification and the framework for diagnosis of epilepsy?
International League Against Epilepsy has given a recent classification in which they have given a step level of classification for seizures. The first step is to classify the seizure as focal onset, generalized onset, unknown onset, or unclassified. There are the multiple subclassifiers which go below each level. In focal onset, it can be either aware or with impaired awareness. This was previously termed like simple partial seizure and complex partial seizure. The complex partial seizure is now focal onset seizure with impaired awareness. And the green boxes show multiple subclassifications according to the motor onset and non-motor onset. This is depending upon the first prominent sign and symptom. If the child has a prominent motor movement, then we can classify as a multiple subclassifiers. If the child has non-motor movement like behavioral arrest or cognitive or emotional, we can classify in that phenomena. And in underfocal, we have to again say that the focal seizure has gone to bilateral tonic-clonic or not in a particular scenario. This was previously called as focal to secondary generalization, which has been changed, and the new term is focal to bilateral tonic-clonic seizure. This classification also gives us a provision to say that the child has unknown onset. If it is unwitnessed seizure and we do not know what is the onset, we can still classify as under motor and non-motor. And if the seizure is not classified, we can say as unclassified. So that is the advantage with this new classification. The next framework, next slide please. The framework of the epilepsy classification, it gives a step level classification. The 4 levels have been decided. First is knowing the seizure type. The next is classifying the epilepsy according to the seizure type into multiple like focal or generalized and focal and unknown. Next step is if we are able to classify under particular epilepsy syndrome, depending upon the age, the investigations and the EEG criteria, we should be doing that. The fourth thing is epilepsy with etiology. The red boxes shows multiple etiologies, which we should be able to classify into genetic or structural or metabolic, immune, infectious or unknown. If we do not know any etiology, we can put into the unknown category, which was previously called as cryptogenic category. And along with all this model framework, we should take comorbidities into account, like intellectual disability, any behavioral problems like attention deficit hyperactivity or autism spectrum disorder. So finally, with all the clinical criteria, even with the first episode seizure, and we have all the investigations, we should be trying to frame out that whether the child has epilepsy or epilepsy syndrome.
Sir, just wanted to add, if I may.
Sure.
Earlier it was that partial with secondary generalization, all that is now gone, but that is why very rightly Rajni has explained. Just wanted to mention that the most important information we get from seizure semiology. So all pediatricians should understand and ask the parents, because most of the people have now smartphones, that they should record any abnormal movements in the child. That will be very, very important. And we have to, second thing is we have to ask on direct questioning of things like West syndrome, because the infantile spasms get very commonly missed by the parents and also by the pediatricians. Many times there is a lag. And second thing I want to mention that, things like, catastrophic epilepsies and all is gone. The things like idiopathic epilepsies are gone. Most of them are genetic, the idiopathic ones. And another thing is you may have multiple etiologies for one particular patient. For example, a West syndrome child can be because of tuberous sclerosis, and that is also genetic. So that will come under genetic as well as structural. So these few things, just to keep in mind, and the adjectives of benign epilepsies, catastrophic and all have been removed from now this classification. Thank you.
Thank you, Dr. Shefali. My next question to Dr. Sanjeev. As we have seen, the neonates has certain peculiar feature as compared to older children. Dr. Sanjeev, would you like to mention what are those differences in the neonates as compared to older children?
Neonatal seizures are a class different from what it is seen in the late infancy or in the early part of the childhood, because most of the seizure types are very variable, and many times the normal newborn phenomena also mimic seizure type. So, and the other thing is that there are hardly unprovoked seizures in the newborn. Usually there may be some underlying causes, but sometimes we may see unprovoked seizures in the newborn also, which is not that uncommon also. And etiologies are variable. There are challenges in diagnosing neonatal seizure as well, because many of the seizures are not manifested clinically, and we need to have an EEG to support the diagnosis of seizure. And here lies the paradox, because doing an EEG in a newborn with seizure-like activity is a bit challenging, and there are also challenges in reporting them.
One thing is there that neonates can never have generalized tonic-clonic seizures. That's very important for the junior people, and resident level people are saying, because of the which brain is immature. So from one side, the discharge starts, it cannot be possible to have a generalized tonic-clonic ones, and that everybody should understand. And as very rightly pointed out, there are various descriptions, but you may also have subtle things like cyclical movements, and there is a definite entity when you don't see any clinically manifestation, but only the electrical seizures. So that has also to be kept in mind.
So I like to conclude what we have learned so far. First, seizure include multiple seizures in a day. Unprovoked seizure has a high chances of recurrence. Neonatal seizures are somewhat different from a bigger children, and they require EEG monitoring. After having discussed some basics, let's now proceed to the approach to a case of seizure. Dr. Rajni, would you like to tell something about the approach to a case of seizure?
Yeah. If we get a child with first episode seizures, I will discuss under 5 different headings. As a stepwise procedure. The first step is whether the seizure is a true seizure versus a seizure mimicker. We should be able to define that. The second point in the first step is the seizure really a first seizure, which I've already explained that we should take all the effort to understand that the child has had any such previous seizure episodes. When we consider that the child has true seizure versus a seizure mimicker, that we should take the age into consideration, timing into consideration, the exact semiology, and as ma'am has already pointed out, a video recording is a must if possible in that scenario. If they take a video recording, we will be able to classify as according to International League Against Epilepsy, and we can know that the child has a true seizure event versus a seizure mimicker. The next step here is to find out the probable etiology. So here goes the importance of the birth history, the development history, family, and the past history, where we can possibly find out that what is the probable etiology. And then finally the investigations, MRI and EEG, whichever and other investigation if required. And then we should be able to understand, after evaluating the whole case, what are the chances of recurrence, whether we classify the child as only first episode of seizure or the child has an increased risk of recurrence. So can we label the child as having epilepsy? The fifth point is whether treatment is required. Not all the cases with seizures or epilepsy will require treatment. We should be able to understand whether the child requires treatment. And if yes, then is it drug, or it is a vitamin, or it is a psychological counseling kind of thing, or it is any other intervention. So this is the whole flowchart which goes for approach to a case with seizures.
I wanted to add that we have to keep in mind that drug, in addition to what is very rightly and nicely said by Rajni, we should have drug intake, because sometimes drug intoxications can also lead to somebody having a seizure. And other thing is always look for comorbidities. Comorbidities are very important, and about 1/5 of the children generally have comorbidities, whether developmental delay, regression, visual hearing impairment, autism, ADHD, any kind of behavioral problems. You have to look for comorbidities in a child to complete the whole thing.
Every abnormal movement is not a seizure. So, Dr. Rajni, how will you differentiate between different type of movements?
So as I've already said, that even the first episode seizure or seizure-like event, we should be able to know whether it is a true seizure or a movement disorder or a benign paroxysmal non-epileptic movement of that age, or a parasomnia if the event occurs in sleep. So with all this event, the first thing is the clinical impression related to the history and the video. If we have a clinical video, then yes, the whole idea of having a video is to understand that whether it goes into any of these arms as I discussed. Let us have a few video examples. In the next slide, we'll see. The next slide, please. Blackish matter. And the child has first episode. In the first slide, we have to click next. Papa. So yeah, in the first, if we can play it again. In the first episode, if we see, and suddenly at the extreme of the cry, the child has blueness of the body, increase in tone, and loss of consciousness. So every time the child has these episodes, if there is a precipitating factor of crying before that, and the child has these movements, then yes, we are sure that the child will be having breath holding spells. In that case, the child's development and otherwise the development and examination should be normal. And in the second video, if we see that the child is 2.5 years old child with a hypotonia, and we can see the child is flexed with the legs extended, and she is having a kind of rocking movement. And in this, the clear video shows that the child has a self-gratification. In the third video, so I'm not able to see the video properly. In the third video, the child is an infant in which the child is otherwise developmentally normal, but has multiple episodes of shivering. We can see multiple episodes of tightening of the body with shivering. The typical video suggests that the child has shuddering in otherwise developmentally normal child. So this is how this video goes, which makes us understand that is it a true seizure or a seizure mimicker.
So you have seen the 3 videos of the breast holding spell.
Yeah, we have seen the 3 videos, and consent has been taken from all the parents before playing these videos.
So you like to summarize these abnormal movements?
Next slide, please.
Dr. Naresh, what are the important points which you like to?
These abnormal movements, it has to be categorized into either movement disorder or a seizure or a non-epileptic event or a parasomnia. As I've detailed into each of the categories, I'll not go into detail, but we should be able to understand whether it is a true seizure versus any of these categories.
Okay, now we proceed to next question. To Dr. Naresh, what are the important points which you like to ask while eliciting a detailed history of a seizure? Dr. Naresh?
So every seizure episode needs to be evaluated properly right from the patient when presenting in the emergency room. So the immediate history we need to ask is like what happened immediately before the seizure and during the seizure and after the what was the post seizure phase. So in the pre-seizure ictus phase, we asked what were the preceding events, whether it happened in the awake state or when the child was going on to sleep, and whether there were any aura symptoms before that, whether the child started crying or he had some hallucinations. So depending on the age, we have to ask this history. And during the ictal phase, we have to ask what was the duration of the seizure and how long did it last, and whether there were any movements seen during the seizure, whether there was eye deviation to one particular side, or there was any drooling of the saliva, or there were any movements of the eyeball. And in the post-ictal phase, we have to look for the time to recovery and how long the loss of consciousness was there, or there any post-ictal phenomena like vomiting or the child complaints of headache. So apart from that, the relevant history we have to ask preceding the events, like what was the birth history, the natal and the postnatal history, specifically any history of any NICU stay, the history of hypoglycemia or meningitis history. And then we have to look for the red flag signs in the developmental milestones of the child. And along with the developmental, we have to look whether it's a primary developmental disorder or whether there were any comorbidities with that. So we have to look at any autistic disorders in the child or any ADHD, or was there any physical disability which was leading to this developmental issues. Then whether the child is on any current any medications which could have provoked the seizures, and whether the child has any chronic debilitating illness like chronic lung disease, liver disease, etc. And I think family history with especially the sibling is very important in these cases, because epilepsy can run in the families, and history of occurrences is we tend to evaluate more the child when they have family history. So I think these are the important points we should consider in all the patients.
Thank you, Dr. Naresh. So I will like to conclude what we have learned so far. What is first unprovoked seizure, how to approach the case in a stepwise manner, how to differentiate true seizure from mimickers. Every time elicit a detailed history of a seizure. It is essential to delineate the seizure semiology and its classification for correct diagnosis, treatment, and prognosis. After having discussed some basics, let's now move to the case presentation. The case number 1, 5 days old baby girl brought to OPD with a history of abnormal movements during sleep. Duration of these jerky movements in the range of 30 seconds to 1 minute, and the frequency was 2 to 3 per episode. There was no history during awake state. Child was exclusively breastfed. Birth history was normal, born by normal vaginal delivery, and the full-term baby appropriate for gestational age. Perinatal period was uneventful. Neurological examination normal. Reflexes were normal. My question to Dr. Sanjeev: how will we proceed?
Yeah, with the classical history of a normal child without any previous any significant antenatal history or perinatal history, with a normal neurological examination at the time of examination, and the classical description of seizure-like activity occurring during sleep without any such activities occurring in the awake state, a diagnosis of benign sleep myoclonus should be kept in mind, because Pankaj sir has rightly pointed out that many of these seizures-like activity are often treated, but they don't often require further investigation and treatment with a classical description of sleep activities without any seizure-like activity during awake. So this is not a very uncommon diagnosis, but yes, should be kept in mind. And with this description, no further investigation or treatment will be required in such a classical case.
The possibility of sleep illness was there. Dr. Rajni, do you agree with the diagnosis? And when you will like to investigate such cases in further?
So this case was, as rightly pointed out by Dr. Sanjeev, that the child has a classical feature of myoclonus, which is in sleep when child is not waking up. Otherwise, birth and development history is normal. So in a healthy newborn child, having these episodes in sleep points towards benign sleep myoclonus. When do we want to investigate it? Suppose it happens only unilaterally. or only one part of the body, then it is a point of suspicion. If the child wakes during the episode, or this happens even during the awake episode, it is a point of suspicion. If the child has multiple other seizure types, then again we should investigate. And if the perinatal history is a stormy course, or the child has abnormal neurological examination in terms of head size or any other examination like a tonal abnormality, and then we should further investigate these children to rule out any organic pathology. And the investigation can be tailored according to the case basis. It can be either sepsis parameters or metabolic versus the MRI and EEG.
Few words about benign neonatal sleep myoclonus. In this condition, repetitive myoclonic jerks occurs during sleep. Distal limbs are more involved than the proximal, and upper limbs are more involved than the lower limbs. Occurs mainly during first week of life, and upper limit is 6 months. Most likely occurring during the quiet REM phase. Frequency is 1 to 5 Hertz. Neurological examination is essentially normal. EEG is also normal, and such babies don't require any treatment. We move to case 2.
Sir, one thing, sir. Not just an offshoot. When we are asking for an EEG for a newborn or a neonatal period or a young child, we should, in the young infant, we should ensure that we have a full sleep-wake cycle in the record. Otherwise, we are going to miss many things. So that has to be kept in mind for all these neonatal kind of seizures, that a full sleep-wake cycle should be there in the EEG record, because sometimes in a hurry, in haste, they just do 15 minutes, so raha hai to kar diya, they will not wake up the child. So that is very important. Even West syndrome and all, we miss many times if you don't have a full sleep-wake cycle.
Thank you, Dr. Shivali. Point well taken. Move to next case. 2-year-old child brought in emergency with the history of first episode of right focal seizure, upper limb. Child was stabilized in emergency by maintenance of airway, breathing, and circulation. Essential blood test investigation were taken, and the seizure was aborted by giving IV midazolam. So diagnosis of right focal status epilepticus was made. At this point, I will ask from our intensivist, Dr. Naresh, how you define status epilepticus and how will you manage such cases?
So in simplest terms, the status epilepticus was defined where the seizure was occurring continuously and was not stopping. And here the time duration was very important. So in view of that, the American Epileptic Society has given us 2 time frames, T1 and T2. As we know that status epilepticus persists beyond 5 minutes. So 5 minutes was the time when you need to intervene, when you need to give the treatment. And if you delay it to further like 30 minutes, the chances of neuronal injury were very high. So in view of that, they have defined for tonic-clonic seizures a cutoff of 5 minutes and 30 minutes. For focal epilepsy for 10 minutes and 60 minutes. So within this time frame, we need to identify and treat the child. Regarding the management, as I already said that with each passing time after 5 minutes in status epilepticus, the chances of neuronal injury increases and chances of refractoriness also increases. So our first aim is to immediately control the seizures. And within 5 minutes of patient presenting to the emergency room, we take it that the child may be having a status epilepticus, and we first of all manage the airway, breathing, and the circulation as per our PALS protocol. Give him oxygen, do suction, maintain his airway, and collect all routine samples. And give first dose of midazolam or lorazepam, which is a benzodiazepine. The dose is 0.1 mg per kg IV we need to give, and we need to see whether the seizure is controlled. If not, we can repeat a second dose of benzodiazepine. And but we need to be extra sure of the breathing and the circulatory part. So sometimes if the seizure is not controlled with these 2 medication, we proceed to the second line drugs, which are also emergency drugs. And regarding the recent guidelines in the second line drug, we don't have any particular choice. It's they probably are unit based, but we can use phenytoin, we can use levetiracetam, and we can use valproate. Probably depending upon your patient clinical case scenario, because the valproate is avoided in mitochondrial disorders or in metabolic issues, and phenytoin can have cardiac side effects. So while levetiracetam is quite generally safe, so we prefer levetiracetam as a first dose, and we can also give other 2 drugs in normal patients. A thing I'll mention here is that all these drugs have some side effects, so just need to maintain your airway breathings when you're using these drugs. So if the seizure is not controlled for next 1 hour, we generally label it as refractory seizures, and then we need to step up our therapy. We start with the midazolam infusion, and many units are also using thiopentone loading dose followed by maintenance. So this is the way we go about. I'll say like we need to have a continuous EEG monitoring whenever you are going beyond the first hour, because you need to rule out non-convulsive seizures too. So that's the way to go about in these patients.
Coming back to case, child was stabilized in emergency, and afterwards detailed history and examination was completed. On history, there was birth and development history was normal. There was no history of prior seizure or any motor weakness. Examination vitals, heart rate 120 per minute, respiratory rate 40 per minute, child was hyperventilating. Blood pressure was 122/70 at 2 years of age, and saturation was maintained with oxygen supplementation. On examination, child has port wine stain on the forehead on the distribution of ophthalmic nerve of trigeminal part, and neurological examination, child has a feature of raised ICT. Child was shifted to ICU, intubated. Seizures was refractory. They were controlled by 3 drugs, levetiracetam, phenytoin, midazolam infusion. Child was started on steroid along with medication to control raised ICP. MRI imaging was done when the child was stabilized. Dr. Rajni would like to interpret these MRI images to us.
So this was a child. The first image is a contrast image which shows the left-sided parieto-occipital area. There is an angiomatosis. In the second image, that's a flare image, which see that there is a focal lesion, and along with that, there is a perilesional edema. The third one is a SWI image, which shows the hemorrhagic foci. That is a nidus, and there is a perilesional edema around. The fourth one is a MR venography, which shows that the left transverse sinus, there is a collateral which is coming out, and which is the feeder, which is the feeder for the hemorrhage in that area, and that is the etiology. And hence we made the diagnosis of Sturge-Weber syndrome, seeing the clinical scenario, seeing the port wine stain with the child having a IC bleed.
So further progress of the case, child improved after 2 days and was extubated on 3rd day and discharged on 7th day with a device to have an ophthalmic evaluation for glaucoma. The final diagnosis was Sturge-Weber syndrome with intracranial bleed. Sturge-Weber syndrome is a problem of vascular disorder in which child has unilateral port wine stain on the forehead, on the eye, as well as abnormal blood vessels of the brain as well as eye. And association of epilepsy is very high to the extent of 75 to 95% of cases. So learning points after this case, after initial stabilization, diagnostic and therapeutic measures all go hand in hand while managing a child with acute seizures in emergency. History and medical examination is mandatory in every child, which can help us to form a syndromic diagnosis. Just as in this case of Sturge-Weber syndrome, port wine stain help us to pinch a diagnosis. Dr. Rajini.
Yeah, sir. So can I put some points for status, practice points for practitioners?
Sure, go ahead.
Any patient, any child coming to seizuring to our ER is taken as status. I mean, so that is already been talked about, but we should just understand that somebody is coming seizuring. So obviously he's beyond the 5-minute thing. And second thing is, when you're talking about the loading we are talking about with the phenytoin, valproate, levetiracetam, there is the one thing we have to remember, many of these patients are already on these medications, right? So if the child is on phenytoin, valproate or levetiracetam, we may give them a mini loading of half the loading dose at that particular time. You will not give a full loading dose. I want you also to remember that phenytoin toxicity can also cause status. We've had a child who was taking oral medications. He was taking a double dose of eptoin, and my resident in casualty also loaded with eptoin again, mini loading. And then ended up when I had to call at 2 a.m. in the night, and we realized that it was a toxicity. So just keep that in mind. And obviously you'll give a half dose of loading when the child is already on that medication. And you also see whether they have missed the medication or not. third thing, when you're coming to, we're talking about the thiopentone thing, you're talking about the super refractory part. There is also that we have noticed that with thiopentanol, you are dependent on the anesthetist. So as pediatric neurologists, we have developed our own protocol of phenobarbital coma, which we have been using in our PQ and even HDU outside the PQ, and it is working well. And there is a protocol which is published. You can take it from the net, whichever pediatric neurologist wants to. So you can go to a high dose phenobarb coma for that. And before you, I also remember that, you know, certain things like fires is febrile seizure related, you know, epilepsy syndrome, comes with super refractory status in a totally normal child. It is just like a catastrophic illness coming from bolt in the blue for the family. They're very, very refractory to treatment. And in those cases, ketogenic diet becomes very important, and they can be seen. And we have the keto which are available, the fluids which are there marketed, they can be used by NG. And another drug I want you to remember, topiramate is a very good drug for super refractory status at times, although you don't have intravenous preparations, except the child, if the child is not in hypotension and you feel the splanchnic circulation flow is there, there's no systemic problem for that, then you can give by NG topiramate, and there is a loading dose protocol for topiramate, which is already published. And when you're discharging the patient, do not forget to tell them domiciliary management of seizures with the recovery position and which intranasal midazolam. Thank you.
Thank you. Thank you, ma'am. So, question to Dr. Rajni, what are the clinical pointers which can help to clinch a diagnosis in the case of seizures?
So whenever we have a child with seizures, we should do a complete examination from head to toe, which can be any neurocutaneous marker. The first slide is showing the ash-leaf macules, then the shagreen patch, adenoma sebaceum. We have any pigmented nevi or a hyperpigmented spot, that is a cafe au lait spots. If we have excessive mongoloid spots, these all are the multiple neurocutaneous markers which you can see. And in the second, where the arrow is pointed, that's again a port wine stain. So that will help us to point out any neurocutaneous markers like this ash-leaf macule, shagreen patch, and adenoma sebaceum is a pointer for tuberous sclerosis. Excessive mongoloid spots will point towards a GM2 gangliosidosis. The Sturge-Weber syndrome. In Sturge-Weber syndrome, we can see a port wine stain. The child with a mobile is a case of Down syndrome. And in the last one, the child has a macrocephaly. So that was a child with MLC. So we should see the head size, the neurocutaneous markers, or any other neurological examination in terms of focal deficit or any hearing and vision impairment.
We quickly move to case 3. 7-year-old developmentally normal child seen in OPD. 5 days back, he has brought with a history of right focal seizure in the night around 3 a.m., which lasted for 2 minutes. Was admitted to some other hospital where MRI was done. It was normal, EEG awake, reported seizure disorder. Child was started on medication. And Dr. Rajni, I quickly like to tell how we'll proceed further.
Okay. So in this, a young child who is otherwise normal had one episode of focal onset seizure during the sleep. And that when we take a history in detail, we could note that the child has choking and drooling, some kind of guttering and gurgling sound during that time. And see, with the clinical scenario of this, we had a possibility of benign rolandic epilepsy, that is benign centrotemporal epilepsy. If we have such a suspicion, we should do a EEG, which is sleep deprived, to attain the sleep record, because awake record need not give us a clear answer. At times, the awake record is totally normal. So in this case, we planned a repeat sleep deprived EEG. This is the EEG is in awake. We can see just the occasional spike wave discharges which are arising from the centrotemporal region. But as we go further into the deep sleep, we can see multiple spike wave discharges which occurs in REM, and they have the clear characteristic EEG criteria in which there are the frontal surface positive waves. They occurs in REM and the background is normal. They have a dipole in the central part. These are the specific EEG criteria in which we can say that the child has benign rolandic epilepsy, that is benign centrotemporal epilepsy. So final diagnosis was made on the EEG, and here the family was counseled on the further risk of recurrence and domiciliary home management. And in fact, in this child, only with first episode, I advised them that we did not give any drug. It's not necessary that we prescribe medications in such a case. We can discuss with the family the risk of recurrence and stop the drug as well.
So, learning point after case 3 has already been emphasized. Detailed history is must in every case. We should advise right investigation. It is a sleep deprived EEG rather than awake EEG. And EEG reporting by a good neurologist, and especially by pediatric neurologist, makes a lot of difference in the final management. So we are left with 10 minutes with us. Dr. Rajani will have to quickly move to some of important questions.
Okay.
So I will ask first question: when should neuroimaging and EEG be asked in case of seizure?
Okay, so we have multiple indications for a neuroimaging. Not all the case will require neuroimaging. Absolute indications are if the child has focal seizure, the child has a generalized seizure which is of unknown etiology, if the child has multiple episode seizures, and if there is a abnormal history in case like a perinatal history or any other past history of CNS infections or a developmental delay. If a child has abnormal neurological examinations, these are the set criteria we should go for MRI investigation. But yes, if the first episode itself is doubtful, we are not sure this is a true seizure or a seizure mimicker, we can, if the child is otherwise safe, we can advise that we can wait for the another event and we can try to video record before confirming that this is it. And EEG might help in this case to figure out whether this is a seizure or not. MRI is not required if we have made a diagnosis of typical epilepsy syndrome, which is self-limited, like a benign centrotemporal epilepsy or absence epilepsy. We are sure on the EEG, then MRI need not be advised in such cases. And when we go towards the EEG, we should be knowing that EEG is not the criteria to classify a child as having epilepsy or not. So epilepsy is a clinical diagnosis. EEG can help us to differentiate between a non-epileptic event versus an epileptic event. It helps us to classify the seizure type and the epilepsy syndrome. It helps us to predict the recurrence. And in the child who has status epilepticus and child still has persistent coma, child is not waking up, we should do a urgent EEG to find out a non-convulsive status epilepticus. It should not be the criteria to diagnose epilepsy. And when the clear non-epileptic event, suppose the video shows the child has a breath holding spell or a shuddering, we do not advise EEG at all. So what are the timing of EEG? There is again multiple questions on this, that when should we do, within first 24 hours or later. So if we do a EEG, which is within the first 24 hours, the chances of picking up the abnormalities in terms of background abnormality or epileptiform abnormality are more frequent. But if these abnormalities need not persist for long, suppose we have given a drug and the child has a background slowing, this does not signify that the child has epilepsy. We should do a repeat EEG in that case after 2 to 4 weeks to rule out, to look for the persistence of abnormality. So at first go, increased chances of finding the abnormality, but yes, it should be persistent to say that the child has epilepsy. Next slide, please.
When we do an EEG and EEG coming normal, still the child can have epilepsy?
Yeah. So as I already said that in a child with epilepsy, the chances of picking up of an abnormality in a surface EEG, which is a short one, 15-20 minutes EEG, the chances are only picking up between 18 to 56%. So around 40% of the children having a clear episode of seizures, the EEG need not show any abnormality. 15% of them will not show any abnormality if you go on further doing repeated EEGs. On the other hand, if a normal child who has never had a seizure, we do a EEG, we can find any epileptiform abnormality, which is interictal, in about 0.5 to 6%. And if a first episode of seizure, EEG is normal, how do we increase the yield of EEG? If we do repeated EEGs, again, the chances of finding an abnormality will increase. If we do a sleep-deprived EEG and a prolonged EEG, again, the chances of finding an abnormality will increase. So that will help in diagnosis.
One important question now, whether anti-seizure medication should be started and what are the guidelines?
Whenever we have such a child, we should weigh the risk and the benefit ratio, whether the child has a risk of having a recurrence seizure or not. So if we start the medicine, what benefit will we have? As I've already discussed, when we start the medicine, it will reduce the risk of recurrence to 50%. In each individual case, if the child has a focal seizures or the child has abnormal neurologic examination or abnormal EEG, then the chances of recurrence is high. And in that case, we should start the medication. If the child has no such risk of recurrence predictors, then in that case, why to start the EEG? Because why to start a medication? Medication will have its own risk of adverse effect, the cost, the stigma, the behavioral and scholastic performance. So in each case, the risk of having a recurrence should be judged, and then the medicine should be started depending upon the risk and benefit ratio. So here, the previous studies have already shown that the risk of recurrence will reduce to 0.5%, and anti-seizure medication does not treat epilepsy. It will just treat the seizure. Epilepsy will be taken off, epilepsy will be taken care by the timing. Like if a self-limited epilepsy is there, child might outgrow of that epilepsy. So medications are only to treat seizures, not epilepsy.
In a certain condition, when you like to start treatment immediately, what are those indications?
I've already discussed that, as according to International League Against Epilepsy, there were 3 criteria which defines the child having epilepsy. That means these children have increased risk of recurrence. What were those? The child having GTCS seizures, which are more than 2 episodes. So in that case, we will start the medication. If the child has had only first episode seizure, but the risk of recurrence is high, we will start the medication. If the child has focal seizure or a prolonged status or a status epilepticus, then we can start the medication. If the child has severe parental anxiety and they do not stay nearby, then again, that's a situation. In the individualized case, the doctor can take a chance of starting a medication. And if a clear diagnosis of epilepsy syndrome is made, we will again start the medication. These are again the 3 criteria as we discussed in the definition. What are the general principles is we start with slow, we go slow, and then we hike up the dose. The minimum possible dose should be given for that particular child. And polytherapy is not advisable. Usually monotherapy is advisable, and about 70% of the patient will have prolonged remission on monotherapy itself. Appropriate dose, appropriate drug should be given to the child, and when one anti-seizure medication has been started, we should titrate it up regularly, intervals, rather than adding on another drug. And the drug which is not effective according to the age, the seizure type, or the epilepsy, we should try to withdraw that. So these are the safe principles for anti-seizure medications.
Now we're taking a decision to start the medicine. So how long the medicines to be continued in the case of seizure?
Medication should be continued for at least 2 years seizure-free period. And then after that, we can take a call depending upon the clinical scenario, whether the child has abnormal neurological syndrome or abnormal neurological finding, and what is the structural pathology in the MRI, what is the EEG. Depending upon the multiple criteria, we can decide whether to stop or not. At times, if the child has structural etiology or has abnormal EEG, then we might prolong the duration of anti-seizure medication.
As rightly pointed out by our esteemed chairperson, parental counseling is a very important and essential component in a seizure management. Dr. Naresh, you will like, in brief, you'd like to tell us?
Yes, sir. So all these parents are quite anxious when we are treating the seizures. So we have to give them a proper advice at home. We have, first of all, the main important thing, we have to tell them that they should not get panic, and they should maintain their calm. And it's very important to tell them to keep the child in the recovery position where we support the head and extend the airway so that the airway is maintained. And for patients who have been having chronic seizure, so most of these patients will have some suction machine kind of thing at the home, so they can do a suction if it is possible. And also every patient, we tell them to have midazolam spray handy at home, and they can use that midazolam spray, a dose of 0.2 mg per kg in the nose, and then again keep in the recovery position, and they can bring the child to the nearest hospital setup. And always keep the patient in also a safe environment, away from any harmful environment. And do not try to put anything in the child's mouth otherwise, or do not put water on the child, or trying some other home therapies. Get the child early to the hospital, nearby hospital, and you can have a consultation with the neurologist or your regular neurologist. Be on a call with him or her, and then you can proceed accordingly.
So in the end, I will request Dr. Rajni to summarize the approach to a child with a case of first seizure. Dr. Rajni, please.
Whenever we have the first event, we should be sure this is a true seizure versus a seizure mimicker. The next step forward is whether to know that the seizure is a focal onset seizure or a generalized onset seizure. If the child has a focal onset seizure, we do MRI brain to find out any structural pathology like a neurocystic sarcosis, tuberculoma, or any other pathology. If we are clear on MRI that the child has a pathology, and EEG need not be done, and we can start the treatment on that basis. If the child has generalized seizure, then EEG is done first to find out any epilepsy syndrome in a particular age, and then MRI can be followed if required. For example, if a child has typical childhood absence epilepsy seizure-like events, and we do a EEG, which makes the diagnosis, an MRI need not be required in such a case. And if by the clinical scenario, like having a focal seizure or underlying neurological abnormality, abnormal EEG or epilepsy syndrome, the risk of recurrence is decided at the first go. And then if there is no risk of recurrence, we can follow the child till next up to 2 years. And if yes, the risk of recurrence is there, even with the first episode, we start the anti-seizure medication. In all the cases, a detailed family counseling, which takes a pretty long time, will be required in such a case. So this is a whole summary of how we go forward.
Thank you to my all panelists. In the end, I'd like to conclude by saying few words. Trying to differentiate two seizures from mimickers. Initial stabilization, diagnostic and therapeutic measures all go hand in hand while managing a child with acute seizure. In first seizure, a policy of wait and see with close follow-up monitoring is required. Parental counseling session must be done after every seizure. Thank you. Over to the chairpersons for final remarks.
There are a few questions we can take.
Just wanted to, yeah, can
Yes,
you
ma'am,
just
please.
make one
Please
or
go
two
ahead, ma'am.
points? The EEG, what we, the EEG, what has been told, I just wanted to add that you needed full sleep-wake cycle, as I mentioned, for neonates. But even when you're suspecting electrical status epilepticus in sleep, if you're getting a wake EEG, it will be totally normal. There is a, the discharges come only in the sleep. So that you have to keep in mind before epileptic events. That has to be kept in mind, and that can use suggestion for the child to have the act in front of the us and do the suggestion during the video EEG, and then we can record that event. That will be important. The International League Against Epilepsy says that for tropical countries like ours, you need a neuroimaging before you label any, if you have to in the diagnostic algorithm. But for anybody who's coming with status, anybody who's suspecting NCC, a CECT is good enough for a NCCT. I mean, for neurocystic sarcosis, that is good enough. But obviously for posterior fossa lesions and malformations, you need an MRI. So that thing was not mentioned, so I thought I should add. And for parent, even in the domestic management of seizure, and in that the maximum ceiling dose is 20 puffs, and you have to tell them that they can repeat half the dose if the seizure doesn't get controlled in 5 minutes, but not beyond that. That has to be kept in mind, I think. And we have to give them, patient information material, videos, and we have it all on our websites, that so that they can understand and get back to them. And you should give them a seizure diary where they can monitor the seizures with the doses for the optimal. And another last thing, for dispensing medications, we are prescribing medications, rationally has been prescribed, but for dispensing, you can't use the caps or TSFs. If you see in our own homes, the teaspoons we have are very small to very big. It has to be measured. Anti-seizure medications have to be measured in syringes. And for all the liquid preparations, they have to be shaken. The dispenser has to be shaken. Otherwise, in the top, you'll get the diluted version, and later on, you'll get the concentrated. And chrono preparation should not be halved. And we should ask the parents if the child can swallow the medications when you're prescribing chrono preparations. Because wo chaba raha hai, or you're crushing and giving them, that's the whole idea is lost. So these small tips have to be kept in mind. Thank you.
I think most of the question has been answered, and Dr. Shefali further added to so many answers to the questions. I think running short of time. If they have further query directly, they can discuss with our panelists, Dr. Rajni and even Dr. Shefali, if she finds some time. And they can then go to log to the website.
Yeah, sure. So they can mail to me. I'll just put my, I'll put the mail. I'll put the mail and the website on the link. Then I'll sign off. They can mail me anytime, sir.
So nice.
Thank you so much.
Thank you.
Thanks for having me over.
Thank you very much.
Thank you, sir, and all the best for the BLK update. And still gratitude from IIP West Delhi, sir. Thank you, sir.
Thank you, Dr. Dinesh.
Let's start with the second talk. The second talk is on obstructive jaundice, and For that, the chairpersons, I would like to welcome Dr. Vyom Agarwal, Dr. Naveen Rana, and Dr. Yogesh Sarin. And, Dr. Vyom Agarwal is the current president of the Pediatric Surgical Society, and he's a consultant pediatrician, pediatric gastroenterologist at Max Hospital, Shalimar Bagh. Dr. Naveen Rana is the president of IEP North Delhi, and he's a senior consultant in pediatrics in Shri Agrawal Hospital in Rohini. And Dr. Yogesh Sarin is also the president-elect of IEP Indian Association of Pediatric Surgery, and he's trained in fellowships in London and Australia. The moderator for this session will be Dr. Prashant Jain and Dr. Deepak Goyal. So over to Dr. Prashant Jain.
Hello, Dr. Nish. Will you please request Dr. Deepak to start the presentation?
Yeah. Dr. Deepak.
Hi.
So, Dr. Deepak is the pediatric gastroenterologist at BLK Hospital, and he's going to start the presentation on obstructive jaundice medical causes. So over to Dr. Deepak.
So, is my screen visible?
Yes.
Okay. So hi, good morning, everyone. I'm Dr. Deepak. So when we started this thing, we thought of discussing obstructive jaundice only. But then we thought that it's better to discuss neonatal cholestasis, or we can say infantile cholestasis as a whole, with special emphasis to obstructive jaundice. So we have slightly changed the topic, and I will be discussing the approach to neonatal cholestasis.
Dr. Deepak, please switch on your slideshow.
Just a second. Is it okay? So I will be discussing the approach to neonatal cholestasis along with the medical management, and Dr. Prashant will be discussing the obstructive causes of neonatal cholestasis. So neonatal physiological jaundice is a common and mostly benign symptom, and it resolves typically in most of the neonates and within 2 weeks after birth. While neonatal cholestasis indicates a conjugated hyperbilirubinemia, and neonatal cholestasis or conjugated hyperbilirubinemia is never benign in a neonate or an infant, and it indicates the presence of a severe underlying condition. It can be due to neonatal cholestasis can be due to a defect in the intrahepatic production, that is the parenchymal defect, or it can be due to defect in the transmembrane transport of bile, or a mechanical obstruction preventing bile flow leads to an accumulation of bile component in the liver. Incidence of neonatal cholestasis is around 1 in 2,500 infants in the West. In India, it constitutes around 20 to 30% of all the chronic liver disease in children reporting to the tertiary care hospitals. And hepatocellular causes constitutes around 40 to 70%, while obstructive causes accounts for around 20 to 50% of all the cases of neonatal cholestasis. So we can divide the etiology on the basis of obstructive, which can be due to biliary atresia, which is an extrahepatic obstruction in the flow of bile, which is the most common etiology of neonatal cholestasis. It can be due to choledochal cyst. It can be due to paucity of interlobular bile ducts, that can be syndromic, as Alagille syndrome, or it can be non-syndromic, or sometimes it can be seen due to biliary sludge. It can be parenchymal with infectious causes, certain metabolic causes, certain enzymatic disorders, mitochondriopathy, and it can be due to defect in the transport of bile, which is a separate group, that is progressive familial intrahepatic cholestasis, which is further divided into 5 subtypes. And then idiopathic neonatal hepatitis. So previously the chunk of idiopathic neonatal hepatitis was large, but with the availability of better tests and genetic tests, this fraction of idiopathic cases are decreasing. Now, what is the importance of neonatal cholestasis? So what we have seen and what other countries, even Western countries, have seen, that the diagnosis of neonatal cholestasis is often delayed, and average age at diagnosis of biliary atresia in the Western countries is around 60 days. In India, it is somewhere more than somewhere around 60 to 90 days. And for these reasons, the fraction bilirubin must be determined in any infant presenting with prolonged jaundice, which is lasting longer than 14 days of age for term and 21 days for preterm infants, with or without depigmented stool. So any jaundice which has prolonged for more than 2 weeks in a neonate, first test to be done is fractionated bilirubin, and to check which type of bilirubin is this, whether it's a direct bilirubin or an indirect bilirubin. So once conjugated hyperbilirubinemia is identified, then a systematic approach is to a rapid diagnosis is done, which we will discuss. So what is neonatal cholestasis? A conjugated bilirubin of more than 1 milligram per deciliter in combination with a total, if the total bilirubin is less than 5, then if a conjugated bilirubin is more than 1, it indicates cholestatic jaundice. And if the total bilirubin is more than 5, then a fraction of more than 20% of conjugated bilirubin indicates neonatal cholestasis. So there are certain clues to the diagnosis of cholestasis, which might include hepatomegaly, diarrhea, poor weight gain, hypopigmented or acholic stools, and dark urine that may stain the diaper. So one should always try to look for these pointers. So why the approach for neonatal cholestasis is important? So the principal diagnostic concerns are to differentiate the hepatocellular, that is the parenchymal disease, from the anatomical disorders, that is the obstructive disorders, because these obstructive disorders are then managed surgically, while the parenchymal disorders are managed medically. So it's always important to distinguish between these two. And there is no single laboratory or imaging test which differentiates between biliary obstruction and other causes of neonatal cholestasis. So a set of tests and a variety of tests are generally done in these kids. So as stated earlier, one of the most important initial investigation is to first establish cholestasis. So whenever a neonate or an infant comes to us with the jaundice, so it's always best to first check what is the total bilirubin and what is the differential bilirubin. So this is the diagnostic algorithm for, there are many diagnostic algorithms available for management of neonatal cholestasis, but this was published in 2014 in Indian Pediatrics. So this is a fairly lucid and important algorithm to approach a case of neonatal cholestasis. So whenever you are sure that there is neonatal cholestasis, first is always better to differentiate whether the neonate or an infant is sick or versus non-sick. So if the infant is sick, then mostly the child will either it's a sepsis, or it can be some torch infection or underlying metabolic disorders. So whenever a neonate with neonatal cholestasis is sick, then generally the diagnosis narrows down to sepsis or infection, other viral infections or metabolic disorders. So if there is proven sepsis, if the sepsis screen is positive, then you treat sepsis as per the protocol, and you should always look for underlying galactosemia, because neonates with galactosemia have a very high incidence of sepsis. So whenever you are encountering a kid with sepsis and neonate and cholestasis, you should always rule out underlying galactosemia. If the sepsis screen is negative, you should look for other causes of infection, like the torch infection, specifically CMV, herpes, and simultaneously you should look for underlying metabolic disorders like tyrosinemia and neonatal hemochromatosis. If the infant is not sick, then always as a clinician, you should try to see 2 or 3 samples of stool and try to distinguish if there is pale stools or pigmented stool. If there is pale stool and the child is otherwise well, there are very high chances that the child is having biliary atresia. So you order a fasting ultrasound, and as per the fasting ultrasound report, if it shows a small gallbladder or an absent gallbladder, then there are very high chances of biliary atresia. And if it shows the dilatation of intrahepatic or extrahepatic biliary system, that is choledochal cyst, then you can straight away take the child for surgery. And if an infant is not sick but has pigmented stools, and you are definitely sure that the infant has pigmented stools on repeated occasions, then along with fasting ultrasound, you should the child should undergo certain other tests to rule out other disorders like some metabolic diseases, and the child should undergo liver biopsy if needed as per the case basis. So GGT, this is not GCT, this is a GGT. So GGT is very important in such conditions, because if there is abnormally low GGT in neonatal cholestasis, if it strongly indicates a condition, progressive familial intrahepatic cholestasis. So GGT plays a very important role in classification of such kids. So severity of liver dysfunction can be measured by estimating the INR and albumin. INR and albumin are the two most important indicators for severity of liver dysfunction. SGOT and SGPT are not a very good indicator of the severity of liver dysfunction. They are sensitive indicators of hepatocellular injury, but they lack specificity and prognostic value. High alkaline phosphatase levels can be seen in biliary obstruction, but it has a very low specificity, and generally we don't take it as a very good indicator. So in contrast, gamma GT is, as discussed, gamma GT is a better marker of biliary obstruction and is elevated in most of the cholestatic disorders. But paradoxically, low or normal gamma GT levels are found in patients with progressive familial intrahepatic cholestasis and disorders of bile acid synthesis. So whenever we are ordering LFT, we should always incorporate gamma GT, because some labs, they don't do gamma GT in LFT. So we should always look for gamma GT while evaluating such kids. Now the sensitivity, specificity and positive predictive value of pale stools for the detection of biliary atresia is the sensitivity and specificity is decent, around 90%, but it has a poor positive predictive value in diagnosing biliary atresia. So you can't rely on pale stools alone for the detection of biliary atresia. Now, as discussed, although cholestasis is known to occur in babies with early onset sepsis, sepsis is a predisposing factor for cholestasis, but those kids should always be looked for galactosemia, because galactosemia is a easily treatable cause, and it can be the kids with galactosemia are prone for gram-negative sepsis. Whenever we are treating sepsis and non-normalization of liver function test, even after treatment with appropriate antibiotic, it is a pointer towards, again, an underlying metabolic cause for sepsis. And again, babies with tyrosinemia, herpes infection, and congenital hemochromatosis may present in a sick state early in life, and their recognition and treatment needs to be incorporated. So whenever a sick neonate is not responding to the medical management and not responding to antibiotics, so we should always look for any underlying metabolic disorders in such kids. So if you are strongly suspecting biliary atresia, that is, the baby is not sick, he has pale stools, or if you are not sure whether the stools are pale or slightly pigmented, as in most of the cases, and you have ordered an ultrasound and it is showing a small and absent gallbladder on fasting ultrasound. So this algorithm helps you to manage the case of biliary atresia. So if the baby is too young, baby is less than 6 weeks, then you have time, you can order a HIDA scan. HIDA has not much role in diagnosing biliary atresia. Even after you do a HIDA, whether it's excretory or non-excretory, eventually you have to undergo a liver biopsy. But if the baby is less than 6 weeks, you have some time, so you can order an IDA and then you can plan your liver biopsy. But if the baby is more than 6 weeks, then you should not waste time, because you have to offer Kasai surgery as soon as possible. So if the baby is presented to you more than 6 weeks, it's better than you directly go for a liver biopsy without wasting time on HIDA. So if the liver biopsy is suggestive of biliary atresia, you have to the child undergo the surgery. If the liver biopsy is inconclusive, again, it's always better to do a intraoperative cholangiogram, because that is the gold standard for biliary atresia. And if the liver biopsy is sure that there is no biliary atresia, then as per the condition, you have to treat. If the child with suspected biliary atresia comes to you with more than 90 days or with decompensation or more than 20 days, it's always better to refer the child to a transplant center, because you cannot offer Kasai surgery. Now, babies with biliary atresia appear well and they have normal growth and development in spite of their jaundice. And this leads to parents and physicians underestimating the seriousness of problem. And many healthcare professionals also have this misconception that all babies with icterus have physiological jaundice, which is unconjugated. So that should not be the case. And as discussed, whenever the jaundice is getting prolonged, it's always better to check the fraction of bilirubin, whether it's unconjugated or a conjugated. In India, the average age of presentation to tertiary care centers have shown a little change in last decade, despite in so much of intensive teaching. So what is the role of abdominal ultrasonography in the neonatal cholestasis? So ultrasound may provide findings suggestive of biliary atresia, but we should not rely on ultrasound alone to diagnose biliary atresia, and liver biopsy is the gold standard for diagnosing biliary atresia. Ultrasound may diagnose some other conditions like choledochal cyst, inspissated bile syndrome, and choledocholithiasis. So it is a very helpful investigation during the early phase. So there are certain findings in biliary atresia like triangular cord sign, abnormal gallbladder morphology, that is, if the gallbladder is not visualized or if the length of gallbladder is too short, and if there is no contraction of gallbladder after the feeding, and if there is non-visualized common bile duct. So a distended gallbladder alone does not rule out biliary atresia. It is the contractility of gallbladder after feed which is more important, as in contrast to the absolute dimensions of gallbladder. So whenever we are ordering ultrasound in a suspected biliary atresia, it's always recommended to do a fasting ultrasound, that is for 3 to 4 hours fasting. And second is a postprandial ultrasound, that is just after feeds, to check the gallbladder contraction. Now, HIDA scan has a very limited role in evaluation of neonatal cholestasis, especially if the baby has clearly documented pale or pigmented stools. So the time required, that is 3 to 5 days of priming with phenobarbital or UDCA before the scan, especially in patients who are referred late, is a limitation as shown in the algorithm. So if you have time, then you can go for a HIDA scan. But if you are running short of time, then it's you can skip HIDA and you can directly go for a liver biopsy. Good quality HIDA scans may not be available everywhere in the country, so that is also a challenging. So therefore, delaying the liver biopsy for a HIDA is not justified. Performing a HIDA scan is optional, and as discussed, one may go for a liver biopsy straight away. HIDA is useful in certain scenarios, like if you are suspecting spontaneous perforation of bile duct, then you can rely on HIDA. Now, liver biopsy is one of the most important investigation while evaluating a child of neonatal cholestasis. So there are certain important findings like bile ductular proliferation, bile plugs in bile fibrosis, and lymphocytic infiltrates in the portal tract for biliary atresia. And the sensitivity, specificity is quite good. It's around 90 to 95%. So you can rely on liver biopsy for the diagnosis of biliary atresia. In experienced hands, it is a very safe procedure. And one caution is that biopsy must be interpreted by an experienced pathologist who has a very good experience in documenting the pediatric hepatology biopsies. So that is a very important thing, that it should be interpreted by a experienced pathologist. Whenever you are in doubt, a second opinion should always be sought. So as a pediatric hepatologist, there are certain things. The most important medical management is nutrition and feeding in a child with cholestasis. Then certain diseases like Ella-Gili have significant pruritus. So you have to manage pruritus, and then there are certain associated complications. If present, then you have to treat it. So nutrition and feeding is the most important aspect of medical management in children with infantile cholestasis. Most infants with cholestasis are underweight, and they will need a continuous nutritional support, even pre-operative and post-operative. The goal is to provide adequate calories to compensate for steatorrhea and to prevent and to treat malnutrition. So the ideal calorie requirement is around 125% of the recommended RDA based on the ideal body weight. So as per the ideal body weight, one should target 125% calorie requirement. And protein requirement should be 2 to 3 grams per kilogram. That is recommended. So if a child is exclusive breastfeed, then breastfeeding should be encouraged, and medium chain triglyceride oil should be administered in express breast milk to increase the calorie content. And medium chain triglycerides are directly absorbed in the portal circulation without needing bile acids for their absorption. So MCT oil is always preferred in children with cholestasis. Older infants can have a milk cereal mix fortified with MCT, and adding puffed rice powder and MCT to milk can make feeds energy dense. And so sometimes these kids have significant anorexia, and they have palatability issues with the modified formulas. So if the child is not accepting there is lack of good oral intake, then you can take the help of nasogastric tube or gastrostomy tube, depending upon the condition, to meet their calorie needs. So this chart indicates the daily vitamin and mineral requirements in infant with cholestasis. So fat soluble vitamins like A, D, E, and K are supplemented in a very high dose as per the chart. Water soluble vitamins again are supplemented twice the RDA, and certain minerals like calcium, phosphorus, zinc, magnesium, and iron is also to be supplemented as per the guidelines. So the feeding and nutrition part is the most important part in management of these kids. Now, certain diseases like Ella-Gili syndrome, they have significant pruritus. So management of pruritus is sometimes challenging in these kids. So therapies aiming at decreasing the total bile acid load are typically effective for pruritus, but there are certain other mechanisms also for underlying pruritus. So there are variety of drugs available. So just a short, just a single slide. First line drugs for management of pruritus are ursodeoxycholic acid and cholestyramine. Ursodeoxycholic acid is a very safe drug, and it is always used as in the management of neonatal cholestasis. There are very few minor side effects, and most of the kids respond to UDCA, but if they do not respond to UDCA, the pruritus is not responding, you can add cholestyramine, which is a bile salt binding agent, and with a fairly good side effect profile. And if the child is again not responding, then you can add on a second line drug like rifampin, which helps in bile acid hydroxylation. Sometimes kids with choledochal cysts have concomitant pancreatitis and cholangitis. So, and they can, the pancreatitis and cholangitis can be a presenting feature in these present patients. So you should always look for concomitant disorders. And if present, then you have to treat accordingly. So to conclude, neonatal cholestasis constitutes almost 1/3 of the children with chronic liver disease in major hospitals in India. And early identification of cause is essential for a favorable outcome, and this requires specific biochemical test, imaging studies, and interpretation of histopathology by experienced personnel. Ultrasound, isotope scan, and liver biopsy interpretation in experienced hands are effective in ruling out surgical causes in majority of cases. Malnutrition adversely affects the outcome in infants with cholestasis, and nutritional support and vitamin and mineral supplementation is recommended in all babies with pneumonia. Dr. Naresh?
Over to Dr. Prashant for surgical management of cholestatic jaundice. Dr. Prashant is the current director of pediatric surgery in BLK Center for Child Health. Dr. Prashant?
May I make a few comments before proceeding? Hello?
Yeah, yes, sir. Yes, sir.
Now, it was a very lucid presentation. I agree that now Hypersensitivity has got a limited role since the children are referred to us quite late. But nowadays, with increasing awareness with the pediatricians and neonatologists, we are seeing the referrals of the children with cholestatic jaundice at even 30 days of age, as early as 30 days of age. So then we have enough time to wait for a HIDA scan. And second, to investigate for the conditions which are potentially amenable to medical treatment, like tyrosinemia, galactosemia, sepsis, and like things like that. Because they are potentially treatable because we have the access to metabolic tests also, like we never had before. And there are simple tests like urinary sextile stone for tyrosinemia, which can give us a definitive diagnosis, and we can proceed on to treatment without even going for a surgical opinion. Second thing is there are some fallacy of the HIDA scan. The most common being a non-excreting HIDA scan, ultimately on T2 cholangiogram coming out to be positive intrahepatic bile ducts. So while a excreting HIDA scan will virtually, I will use the word virtually, not 100%, will virtually rule out extrahepatic biliary atresia. It may not rule out conditions like positive intrahepatic bile ducts. And even sometimes, even it is non-excreting, on T-tube cholangiogram, we may see the contrast reaching even the distal bile ducts, only the number of bile ducts are low. So it is important. I have seen many pathologists reporting on the biopsy, not commenting on the number of portal tracts included and the number of bile ducts seen. So it's important for us to realize that the number of bile ducts to the portal tract should be at least 0.8. Like for every 10 portal tracts, we should be seeing at least in 8, we should be seeing some bile ducts. If it is less than that, then the possibility of positive intrahepatic bile ducts is to be considered, which these children, they may do better only with Kasai or even without Kasai. Though many of them will ultimately lead on to, go on for a hepatic transplant. And now with the availability of hepatic transplant, we should not label the children with who are seen apparently fibrotic as non-treatable. We should refer them to the centers which have the facility for hepatic transplant. Thank you.
So what I can say, what HIDA, if it is excretory, then you are certain that it's not a biliary atresia. But if HIDA is non-excretory, then you cannot say anything, and you have to go for a liver biopsy. So yeah, that is the case.
Because these children, many of these children are sick. We don't have even time for reporting of the liver biopsy, because even liver biopsy is going to take some time. So many times in these children, getting a consent for T-tube cholangiogram is easier than getting a consent for liver biopsy.
So the HIDA is important only if the child is non-sick, because then you are suspecting biliary atresia. If a child is sick, then you are not suspecting biliary atresia.
You must also see that getting consent for liver biopsy is much difficult rather than getting consent for surgery. But it may be an individual experience also. Yeah, please, Dr. Prashant, please.
Dr. Yogesh wants to say something.
Yeah, my views about HIDA scan and few other things are probably a little different from many others. If the patient has achlorotic stools, it just actually interprets your HIDA scan. If it is a non-excretory HIDA scan, you have to operate this child. There is no question about it. And when we go on talking about intraoperative cholangiogram being the gold standard, we must also believe and know that majority of these patients of biliary atresia would have no gallbladder that can be intubated for a intracholangiogram. These patients eventually would need Kasai if you think Kasai is required. Biliary hypoplasia, I've been in Maulana Azad, I was a head for 22 years and I've got about 30 years of experience after pediatric surgery training. I have seen one or two a year maybe, but they are not even, say, 5% of the biliary atresia that come. Now, we must talk about the yellow alert that was actually discussed more than 20 years back. A big conference had happened in SGPJ, Lucknow. But very unfortunately, even in the major teaching institutes, majority of the patients who may have come within first 60 days are referred to pediatric surgery departments after 3 months or so. Average duration of the period when the patient was being investigated by pediatric medicine time, in my experience of so many decades, has been more than 6 weeks. I mean, that's something which I call plain and absolute stupid. If a patient is suspected to have biliary atresia, we must have a very early pediatric surgery consultation and let the man decide whether he wants to do the Kasai or not. I'm very happy that the previous speaker mentioned that above 90 days, go for transplant. There is anecdotal reports that, somebody has operated at 120, 150. But those anecdotal reports, somebody says, in 40 years in my AIMS experience, I've seen one patient who did well after 120 days of surgery. It does not make any sense. Worldwide, enough literature is available. More than 90 days, no point kind of doing Kasai's procedure. Kasai's procedure makes the liver transplant much more difficult. But one more thing which I wanted the previous speaker to speak is that although transplant facilities are now available in many corporate sector, but the minimum expenses that will go into it is about 20 lakhs. People talk about insurance and getting money from the government, etc., but it doesn't happen. So if a patient comes, say, at 4 months of age, majority of my patients are to be sent back home. And they will live for another 16 months or so and have very bad, outcome. They will have upper GI bleeds, they will have ascites, whatnot. And there should be some kind of palliative treatment that needs to be offered to these patients. Rest I will talk after Prashant's talk, please.
So next talk is by Dr. Prashant Jain. He's the Director of Pediatric Surgery at BLK Center for Child Health. So over to you, sir. Dr. Prashant.
Very good morning, everyone. After a brief presentation by Dr. Deepak regarding the evaluation of cholestatic jaundice, so I will be just focusing on the mainly surgical causes and their management of cholestatic jaundice. As Dr. Deepak has already described, there is a long list of the differential diagnosis when it comes to the evaluation of cholestatic jaundice. So truly speaking, it's really a Pandora box. And it's really very challenging for hepatologists and the surgeons to confirm the diagnosis in spite of a long list of investigations. The incidence is around 1 in 2,500 live births. And of these, the obstructive causes comprises around 19 to 55% of the infantile cholestatic jaundice. So when I'm talking about the obstructive causes, it means there is some sort of obstruction at the level of biliary ducts, which will require one or the other form of the surgical intervention. And if this is not treated in time, it will lead to the impairment of the liver functions. So very important is the early detection and the management so that the patient, we can give a optimal outcome to the patient. So in spite of increasing awareness and various screening programs, still there is a lot of delayed presentation. So various studies by the tertiary care centers in India, they have reported a presentation of an average around 3.5 months. And even in developed countries like Germany and US, the average age of presentation is around 60 days. So I will be focusing mainly on some common entities which leads to the cholestatic jaundice and needs the surgical intervention. And these are biliary atresia, choledochal cyst, inspissated bile syndrome, and the spontaneous perforation of bile duct. And very rarely seen is the paucity of the intrahepatic bile ducts. So as per the data published by the Indian Academy of Pediatrics, the hepatocellular causes are the most common, and obstructive causes are somewhere around 20 to 50%. And among these, the biliary atresia is one of the commonest cause of the obstructive cholestatic jaundice, which needs to be managed surgically. It's a rare disease, but yes, if not treated in time, it can be very devastating. It's basically a progressive inflammatory condition which leads to the fibrosis of the biliary tree, and so it's also called as the obliterative cholangiopathy. The geographical incidence has been variable in various countries, and it has been very commonly seen in the East Asian countries like Taiwan, Japan, and China, where the incidence is somewhere around 1 in 6,000. And that is the reason they're also using very aggressive screening program through stool card tests. Although with a lot of advancements and the better understanding of the pathophysiology of the disease, the modifications in the surgical techniques, the survival has definitely improved in the management of biliary atresia, but the attempt to cure still has failed. And so the management is palliative surgery or liver transplant. The classification which we commonly use is recommended by the Japanese Association of the Pediatric Surgeons, and they have classified biliary atresia into 3 types, depending on the extent of the fibrosis of the extrahepatic biliary apparatus. And the commonest type is type 3, which comprises almost more than 90%, in which you will see the atretic gallbladder, atretic common hepatic duct, and the common bile duct. And what you can find is just the patent microscopic ductules which are entering in at the area of the porta hepatis. So this is the most commonest type of the biliary atresia which you come across in our surgical practice. Etiology is still not clearly known, and most of the literature believes that it's mainly an autoimmune response which leads to the progressive damage of the biliary ducts. So other causes which have been hypothesized are aberrant early bile duct development, perinatal viral infections, and also the abnormalities of the bile acids, which can lead to the fibrosis of the biliary tract. So as Dr. Deepak has already mentioned, that it's mainly a disease of well-developed term infant who doesn't look sick, will have a normal birth weight. But yes, it's a very important clinical feature. And whenever this finding is present, then one should always have a strong suspicion of biliary atresia. They will have the findings of cholestatic jaundice, of acholic stools and high colored urine. Delayed presentations can have the features of liver failure and also portal hypertension. So when the child is referred to us referred to surgeon to rule out the possibilities of the surgical cause, our main aim is to detect and to find out the patency of the extrahepatic biliary tree. So there's a long list of investigations which needs to be reviewed, but none of the investigations are confirmatory. They can give you a lot of information and they can suggest about the possibility of the diagnosis, but none of the single investigation is diagnostic. Ultrasound, you should always look for the biliary tree pattern, the lack of gallbladder contraction after feeding, any cystic lesion. It can be a cystic variant of biliary atresia, or it can be a choledochal cyst. Echogenic cord sign is because of the fibrosis at the portal plate, condition of the liver. Associated anomalies can be seen in patients who are having a syndromic biliary atresia like polysplenia, situs inversus, which you can make out on ultrasound. But important is, even if your ultrasound findings are normal, it does not rule out the possibility of biliary atresia. Second investigation, as we had already discussed, is regarding the HIDA scan. So it has definitely a low specificity. Yes, definitely it wastes some of your time in the evaluation. Non-excreting scan can be seen in the cases of neonatal hepatitis. But if you find an excretory scan, it definitely rules out the possibility of biliary atresia. There are various other invasive and non-invasive investigations like MRCP, ERCP, and PTCC. A lot of studies have been done regarding their role in the evaluation, but invasive investigation definitely needs a lot of technical expertise, and they definitely has got a very limited role in the evaluation. Liver biopsy is definitely a cornerstone with a very high sensitivity and the accuracy rate, with some classical findings suggestive of biliary atresia, like bile duct proliferation, bile plugs, portal or perilobular fibrosis. But again, it is important to understand is that if biopsy is performed too early in the course of the disease, it may result in the false negative diagnosis. Another very important point, again, I would like to highlight here is that biopsy is something which has to be done by an experienced pathologist. So when all these investigations are suggestive of biliary atresia, or when you don't have conclusive evidence that it is a biliary atresia, one should always consider for the intraoperative cholangiogram, and so it's considered as the gold standard to diagnose the biliary atresia. And when you have a finding of non-visualization, or when you have the findings that the bile ducts are not patent, then one can proceed for the photoenterostomy. So this is intraoperative cholangiogram. Here, as you can see, that gallbladder looks very well distended, which is very unlikely of biliary atresia. And as Dr. Sareen has already commented, that in most of the cases, the gallbladder is so atretic that you may not even be able to cannulate the gallbladder. So as in this picture, the gallbladder is very well distended. We cannulated the gallbladder, and as you can make out that the contrast can be seen in going in the right and the left hepatic duct. And second picture shows that a very free flow of contrast in the duodenum. It rules out the possibility of biliary atresia. Normally, we also take the biopsy at the same time. And this intraoperative cholangiogram also can help us in knowing the paucity of the intrahepatic bile duct. But yes, if the gallbladder and the extrahepatic biliary system is atretic, one will proceed for the Kasai photoenterostomy, which is a very standard procedure described by Japanese surgeon Morio Kasai in the 1950s. And since then, there have been various modifications in the procedure. So when you see a child with biliary atresia, you normally will find a liver with a coarse ecotexture, a greenish liver, greenish liver, and as you can see in this picture, that is the fibrous core. So what we have to do is we have to excise the complete gallbladder, atretic extrahepatic biliary system, and the fibrous core. And this is the fibrous core. After excising this fibrous core, you have to anastomose the intestine with this fibrous core, which requires a very meticulous dissection so that the child can have a normal biliary flow after the procedure. So if you see regarding the prognosis and the outcome, in the cases of Kasai portoenterostomy, it is still considered as a palliative procedure and not curative, because it has been seen that establishment of the bile flow has been just observed in 2/3 of the cases. Those who are operated within 60 days of life. 50% of these 2/3 of cases, they still can have a progressive disease, and remaining 1/3 will land up with the liver failure within months. 70% ultimately will require liver transplant. So even if you are operating in time, sometimes the patients, they can have a progressive disease and they can ultimately land up with a liver transplant. They can still, after surgery, they can still have the problems of cholangitis and the portal hypertension, which are the commonly seen problems in these patients, along with the refractory ascites. So the age of treatment, extent of liver damage, and the surgery by experienced surgeons has been found to be the most important prognostic factors in the various studies. So the centers who are having a high volume of biliary atresia, those centers, they have been found to have the better results and better outcome as compared to the centers in which the number of cases are less. Some of the other prognostic factors which have been studied are the extent of fibrosis at the portal plate and also the size of bile duct tubes, which are important when we consider the prognosis in these patients. Now, another entity is the choledochal cyst. Again, it's common in Asian population with an incidence of around 1 in 13,000 and female predominance. It is basically a congenital dilatation of the biliary tree. And as per the commonly used classification, mainly the 5 types of cysts have been described. This cystic dilatation can just involve the extrahepatic biliary tree, or sometimes they might extend inside the liver also. And there can be a disease called as Caroli's disease, in which there can be a multiple intrahepatic cysts. So the presentation can be, it can even be diagnosed antenatally, and the patients can present with jaundice, abdominal pain, or sometimes lump in the right right hypochondrium. Cholangitis, perforation, malignancy is also commonly seen in these patients. So the presentation can be variable. Besides cholestatic jaundice, you can have pain and the presence of lump. Ultrasound and MRCP are very important and sensitive investigations for the diagnosis of the cystic lesions at the biliary tree. Ultrasound can give you a good idea about the dilatation of the biliary duct, also about the intrahepatic dilatation. MRCP will confirm your findings, and it will give you a very good delineation of very good anatomy regarding the extent of the dilatation, regarding the pancreatico-biliary communication, and also regarding the status of the intrahepatic biliary system. So normally when you suspect a choledochal cyst, you normally advise for the MRCP as the second investigation of the choice. Excision is the definitive management, and as you can see in this picture, this is a type 1 choledochal cyst with a fusiform dilatation. Sometimes they can be very huge, and the cystic dilatation of the common bile duct. And this is, you can see the tapering of the cyst at the level of the near the duodenum, and the complete excision of the cyst was done. Excision can sometimes be very tricky, especially in the patients who had multiple previous episodes of cholangitis. And then in those cases, you can have very dense pericystic adhesions, and the dissection can be very, very challenging for the surgeons. So after the excision, it requires the anastomosis of the gut at the level of the common hepatic duct, called as the hepatic jejunostomy. Overall, prognosis is good in these patients, but they can have the complications like anastomotic leak or pancreatitis. Delayed complications are biliary cirrhosis, stricture, cholangitis, and malignancies. And Long-term follow-up is very, very important in these patients. They can end up with biliary cirrhosis. And also it has been seen that there's a high risk of biliary carcinoma in these patients, even after the complete excision. So a malignancy of around 40% has been reported in these patients, even after resection. So very important is one surgeon should ensure that the complete excision is done, and these patient needs to be followed for a longer period of time. Although rare, but a commonly seen cause is an inspissated bile syndrome, which we see mainly in the neonatal cholestatic jaundice. And it is a result of the impaction of the thick bile. Risk factors are parenteral nutrition, dehydration, sepsis, cystic fibrosis, etc. Ultrasound will help us in making a diagnosis when you find an ecogenic material along with the proximal dilatation of the bile ducts. Spontaneous resolution is common, but if doesn't get resolved, then it might require some form of intervention, either ultrasound guided or open surgical intervention to irrigate the blocked hepatic ducts, blocked bile ducts. Spontaneous perforation of bile duct is a very, very rare, and it is mainly proposed that it's because of the congenital weakness of the biliary wall or anomalous pancreatico-biliary myelinion. This child presented to us with the biliary peritonitis, and we had to explore the child immediately, and we found that there was a choledochal cyst and there was a leak at the area at the junction of the cystic duct with the choledochal cyst. The management initially, if time permits, then the child can undergo MRCP and the HIDA scan to confirm the diagnosis. Operative intervention is required in the form of laparotomy and the biliary decompression and drainage, with sometimes may require a later reconstruction when there is a choledochal cyst. Non-operative management can be done by the percutaneous drainage or by the ERCP.
Dr. Prashant, 5 more minutes.
Yeah. So I will just conclude my presentation with this algorithm which we normally follow in our institution, that whenever we suspect the surgical cause of neonatal cholestasis, we review the ultrasound findings. When we suspect biliary atresia, we perform a liver biopsy, and if time permits, HIDA scan. Otherwise, we straightforward advise for the intraoperative cholangiogram. And if the ducts are atretic, then the Kasai's photointerostomy is performed. Cystic lesion, MRCP is the investigation of choice, and you rule out the possibility of choledochal cyst or cystic biliary atresia, and then the definitive treatment is offered to the patient. So to conclude, outcome is good if these patients are intervened in time, and you can offer optimal outcome and avoid the liver damage. One should not misinterpret these cases with the physiological jaundice. Awareness is very, very important, so that the patient can be referred timely to the surgeons. A close teamwork with hepatologists is again important for the optimal outcome in these patients. Thank you so much.
Dr. Yogesh wants to ask a question. Sir, please go ahead.
No. Beautiful presentations by both the speakers. I just need to add a few comments which I thought were not covered. The mistake that I may have made in my long career. One is that in patients of biliary atresias also, the patient may present with a cystic structure at the hilum, which may give an appearance of a choledochal cyst, not only on ultrasound, but intraoperatively also. I have once, very early in my career, made a mistake and done, drainage procedure into that cyst, and later to realize that actually it was a case of biliary atresia. Basically, in very small infants, the presentation of both biliary atresia and choledochal is very similar. So that's why this very important to know this identity that may happen. More than that, one more thing I must add, which I've written often and I'm quoted and cited often for, is formifrostic choledochal cyst. Formifrostic choledochal cyst is basically a choledochal cyst where the dimensions of the duct system is normal, but if you do a MRCP, an abnormal junction of biliary pancreatic is seen, and they clinically behave like a choledochal cyst. And these are the patients which eventually would need surgery, something very similar to choledochal cyst, although the duct system is near normal. Now, minimally dilated duct systems, when we talk about adults, we talk about, some stone may have come down, slipped down, and be at the sphincter or foci and causing dilatation. Usually in children, even if the sludge is there, that usually will not cause that kind of dilatation to give rise to formifrostae or that that minimally dilated choledochal cyst. So whenever you suspect choledochal cyst, kindly get an MRCP done at a good center where they can focus on the biliary pancreatic junction, because that would clinch the diagnosis. And once again, I request all of you to refer the patients suspected of biliary atresia as early as possible to pediatric surgeons. Otherwise, the results are bad. If I have to tell, I have hardly been able to save, I can't even count on my fingertips. I mean, there are so many little, I'm being very frank and I'm very, very honest, man. That's why I'm saying I don't know many Kasai's patients of mine who have survived it. Thank you so much.
Thank you, sir. Thank you for your comments. I truly agree with you. Sometimes we do see some older children who presents with pain abdomen, and when you do ultrasound or MRCP, you find that the duct is dilated and probably sometimes there's a stone is there in the lower end of the CVD. And then the situation becomes confusing. Either the dilatation is because of the stone or because of the choledochal cyst. So this is sometimes a very tricky situation. And recently, there was a child who had a stone at the lower end of CVD. We did ERCP, we removed the stone, but child continued to have the symptoms and dilated CVD, and finally required the excision of the CVD.
Most of the times, it is the stone is secondary to choledochal cyst in young kids.
Yes.
Most of the time. So.
Thank you, sir. Thank you so much.
There are, I think, almost all the questions has been answered. There's one question by Dr. Pankaj Garg. The utility of stool cart for the parents. Dr. Deepak or Dr. Prashant can answer.
I think yes, if we can make a protocol and if we can give a stool card to every parent whose child has been born, I think we can pick more of biliary atresias at early age. It will definitely help, I think.
Yes.
Because parents will be aware that my child is passing a pale. Although sometimes it's very hard to tell that whether it's a slightly pigmented or a pale stool. But yes, definitely the parents will go to their practitioner early, and it will help in picking up the cases early.
And so, what is the sensitivity of ultrasound to pick dissipated bile syndrome?
Ultrasound, actually, it's difficult to say about the sensitivity, but yes, ultrasound is a good modality because on ultrasound, you can see the thick bile, impacted bile inside the bile duct. And because of that, there can be a proximal dilatation of the bile ducts. So when you get these two findings, you should strongly suggest that it could be inspissated bile.
So, Dr. Manish wants to know what is the cost of Kasai for the patient.
So if in our institution like BLK, we operate Kasai child who is relatively stable and not very complicated, then it will roughly cost around 2.5 lakhs with a stay of around 8 to 10 days.
Mostly 2 to 3 lakhs in most of the centers, somewhere between 2 to 3 lakhs.
But yes, sometimes these patients can have a prolonged stay because of the various issues. If the liver is not in good condition, they can have post-operative issues of ascites, refractory ascites. So those cases, that stay might get prolonged.
One last question. Do we do intraoperative cholangiogram in all the cases?
Yeah, see, if you are suspecting biliary atresia, we do intraoperative cholangiogram. But as we have already discussed, that sometimes performing intraoperative cholangiogram can be difficult because the gallbladder is already very, very atretic, and you may not be able to put a needle inside the gallbladder. So it is that atretic and fibrotic that you may not be able to put a needle inside, and you may not be able to perform the study.
One last question.
One more
how
thing.
common are
Common are gallstones in toddler?
How common are gallstones in the toddler, and what is the workup required for them?
So I would say incidentally detected gallstones are not very uncommon in children. So we encounter I would say it is not very common, but it's fairly common. And most of the times they are silent. And if you follow them closely, and if they are small, if you follow them closely, most of the gallstones, they eventually disappear or they are washed away. And any extra workup required, one should look for any underlying hemolytic anemia. And if there is no hemolytic anemia, and if the liver functions are okay, I think no extra workup is.
Thank you.
We often see a lot of gallstones. May I?
Sorry,
Naresh, may I make a comment?
Yes, sir. Yes, sir. Then we are just short of time.
We often see a lot of gallstones reported on ultrasound. In my younger days, I used to be quite aggressive and do cholestectomy. The youngest cholestectomy I've done is actually a child who was hardly about 40 days old. But over the years, we realized that whatever has been reported on ultrasound, when you actually remove the gallbladder and see that inside, there's nothing more than a sludge, and the sludge really won't cause a problem. So doing a cholecystectomy on a small child, think twice. You know, I don't think it's really fair. And one more thing which I wish to say is that in case intraocular angiogram is done and the patient is supposed to have a picture of biliary atresia, please do not dissect around the CBD, because once you dissect around the CBD, the peri-CBD fibrosis will occur. Eventually, the picture will become from hypoplasia to biliary atresia, and the need of liver transplant for these patients, which otherwise would take longer years in hypoplasia, would take much lesser time now. So if it is hypoplasia, just leave them alone and do conservative management. I know some papers are there where even Kasai has been suggested of hypoplasia, but that's not a uniformly accepted advice. Thank you so much.
Thank you, sir. Thank you, sir. So we'll go on to the next talk. So our next session is about approach to a child with the pneumonia in COVID time. And this will be, the speaker is Dr. Ankit Parekh. He's a consultant pediatric pulmonology and allergy and sleep specialist in BLK Super Specialty Hospital. He has a lot of degrees, like the European Diplomat of Pediatric Respiratory Medicine, the sleep fellow from Gosh, and he was also an RCPH fellow in London, UK. And he was a formerly assistant professor in Kalavati Southern Children's Hospital in New Delhi. He has many publications. To chair the session, we have Dr. Anurag Agarwal. He was the Associate Director, Department of Pediatrics in Maulana Azad Medical College and Loknaik Hospital. He was formerly the head of department in the pediatrics in Maharishi Balmiki Hospital, Delhi. And he has been an expert in framing guidelines for management of dog bites and snake bite. And previously, he was the president of IAP North Delhi in 2018 and secretary IAP Delhi 2016, secretary IAP North Delhi in 2015. Along with him, we have Dr. Manish Gupta. He's a senior pediatrician and neonatologist in Jaipur Golden Hospital. He's the general secretary of IAP Delhi and was treasurer of IAP Delhi 2020. He was a past president of IAP North Delhi in 2016. And we have Dr. Shikha Mahajan with us. She's the Associate Director of Pediatrics in BLK. She's also the National PALS Coordinator and Facilitator for Adolescent Health. And we have Dr. Rachna Sharma with us. She's a Senior Consultant and in charge of Pediatric ICU at BLK Center for Child Health. And she's the Director of the Fellowship Program here and also of the Nursing Critical Care Nursing Program. She was a secretary of Delhi IAP Intensive Care Chapter, She's also associated with the PEDISAR simulation and is a member of ECMO Society. And she's also a facility nodal officer for under 5 death. So over to Dr. Ankit for starting the session.
Good morning, everyone. Am I audible now?
Yes, sir.
Yeah. For this panel, we'll be taking a few case scenarios which we encounter in the daily practice, and especially in the COVID times, and how do we go about it. Well, we all know that it is a coronavirus infection, and we used to have normal coronavirus, which was there causing respiratory infections, but definitely the COVID-19 has been slightly different. Although it has affected adults to a larger extent and children to a less extent, but definitely children have been involved in many ways. Right, so we'll go on to the first case, and this is a known case of asthma who was under our follow-up, was well controlled on budesonide 200 micrograms. So this 8 years old boy now develops fever and cough, does not have breathing difficulty. The family is COVID RT-PCR positive. So a very common scenario which you will encounter in day-to-day practice. The weight is fine, the vitals are stable, the SpO2 on room air is 98%, and the chest is clear. Right, so now the questions are, I would ask Dr. Mahajan that, do you think you will test this child for COVID-19, or there's no need?
Good morning, everyone. In fact, it's good afternoon almost. Yes, Dr. Ankit, since the entire family is COVID positive, I would definitely like to test this child for COVID RT-PCR COVID-19. And we would see the report after that, what it comes.
Okay, so this child also comes to be RT-PCR positive. Now, there's a lot of panic with the family, and would you do any additional investigations? Would you like to do some blood samples, some inflammatory markers? Would you like to do an X-ray? Do you think a CT scan would be more helpful than an X-ray?
Look, the clinical scenario is very important. If the child is all right, if the child is just having, a mild fever of say 100, 100.5, is active, playful, having occasional cough, little bit of coryza, 1 or 2 loose stools, I don't think I would like to do any investigations, and would just keep the child at home with the parents and tell them to just give crocin or paracetamol as and when needed. Give lots of liquids and watch for any alarming signs, which could be any increase in breathing difficulty or persistent vomitings or anything that's alarming, that's a little beyond not normal of a viral fever. So most of the COVIDs have behaved and would behave like a normal viral fever. And most of the viral fevers, we do not need to do much except keep them well hydrated, give paracetamol as and when needed, and tell the parents to keep a close watch on their jaundice status.
Right. So at the moment, we agree that we do not need many investigations to be done. An X-ray or CT may not be helpful at this point of time. It might be required depending on the clinical situation. Okay. So how would you treat this child, ma'am? The parents want to get admitted. Do you think antivirals would help? Do you think steroids would help?
As I said earlier, Dr. Ankit, that if this child is stable means he's having low-grade fever, he's accepting reasonably well, he's not vomiting, he's not having any difficulty in breathing, he's having occasional cough, like any normal viral, I would like to keep this child at home with the parents or with the caregiver. Give the usual treatment that we give for a viral fever, give paracetamol, give lots of liquids, advise rest to the child, and watch for any signs which are alarming to the parents or to us. So we'll explain those alarming signs to the parents, that in case your child is running high grade fever of 103, 104 for persistent 3 to 4 days, if the child is having any difficulty in breathing, if the child is not accepting orally well, if the child is vomiting, the usual alarming signs that we tell to all parents for any illness. Those signs we would tell, and I would like to keep the child at home. No, I would not start any antivirals, and there is no role of any steroids at this point of time.
Yeah. So I think we would all agree with that this child is COVID RT-PCR positive, but is stable, does not have any respiratory distress. Radiological investigations really not warranted at this point of time. The child should be at home with parents. No antivirals and no steroids, right? So just supportive management, but the parents, the family should be in contact with you, so that if at any point of time there is worsening, this child can be taken to the hospital and can be cared for, right? So Dr. Manish, the parents are worried that the child has asthma. So are kids with asthma at a higher risk of COVID infection? That is one, and at a higher risk of complications, right? So that is something which is worrying to parents. The other part of the question with asthma is that can COVID itself lead to an exacerbation? And what would you actually do to the long-term controllers, right? So there are three parts to the question, Dr. Manish. And if you can answer these, it would be great.
Thank you, Dr. Ankit. First, we must congratulate BL Kapoor for an excellent selection of mixing topics for this CME. And regarding asthma patients, so this was exactly the time, 12 months, 365 days back, then it was the peak lockdown and it all started. And in fact, this was the time when our clinics was also closed. And with asthma patients, whatever we all doctors, we had this fear that with the chronic inflammation looming in child's lungs, what would be the exacerbation and all this, and whether they will be having more severe presentation of asthma, more risk, and what will happen. But surprisingly, we all know that in last 12 months, our asthma patient actually did not have more exacerbation or risk of infection. In fact, they did better only, because in those 3 months, 4 months, the pollution levels was very down in all the urban cities, and probably that helped. So they did not have increased risk of complication or infections. And even in the comorbidity, you see the list, the asthma is not there in high risk factor for COVID infection. Regarding COVID infection lead to exacerbation of asthma in children, again, that has not been seen in patients. Whoever has been diagnosed with COVID infection in the asthma patient, they did not have very much increased controller requirements in such patients. And for the long-term controller need, it again has to be decided on case-to-case basis. If the patient are doing fine on the current dose of controllers, then you should not increase, in fact, the dose of controllers, and you have to monitor them as per their asthma control test questionnaire or whatever presentation, symptom exacerbation are there or not. They just have to continue their dose of controllers, what they are taking.
Very rightly said, Dr. Manish. So I think the data world over has been almost similar, that asthmatic children did not develop an aggressive form of COVID-19 infection independent of the asthma severity and control over the previous year. So that has been something good for kids. The symptoms related to COVID-19 were always mild, even in children with asthma. And there are studies which have shown that during the COVID pandemic, actually there was a 75% reduction in the asthma admission from the pre-COVID era. Now, why this has happened is a bit complex. This is a paper from Pediatric Pulmonology, which talks about what are the factors which were exacerbating and what were the factors which were actually ameliorating the asthma control and exacerbation. So the factors which were possibly increasing were a lack of physical activity, indoor air and allergens. So there's increased exposure to dust mites, the animal dander. There was more exposure to COVID-19 contacts, and there were actually reduced visits to the OPD, and hence the follow-up was poor. There are factors which are actually reducing the incidence of asthma. So there are no school visits, and hence the viral exposures were less. They were not exposed to outdoor air. And as Dr. Manish also talked about, that the AQI was quite better during a particular time, and that helped. There were patients who were still in contact with us with telemedicine, and that might be helping. And because the parents were at home, it might be leading to an improved adherence. But it is definitely a bit complex to understand. But overall, the situations was not worse, and most of the patients were doing well. The GINA guidelines last year said that you should continue your controllers, do not taper them during the pandemic time. This is what we were doing, but now with the pandemic waning and the children remaining well, possibly we can reduce the inhaled corticosteroids depending on a case-to-case basis. Right, so this child was managed at home, remained afebrile, was given salbutamol in addition to controllers, the cough resolved, and continued on the same preventer. Right. So let's go on to the next case. So this is a previously well child, an older child, 16 years old girl, had cough and fever for 5 days, but now has breathing difficulty for a day. Right. So an older child with breathing difficulty, the father is COVID RT-PCR positive. On examination, she's a bit obese. The respiratory rates are high. The SpO2 is just borderline, so 92% in room air, and the chest is clear. Right, so slightly different scenario in this case. So again, we have a set of questions. Well, obviously you would get a COVID-19 RT-PCR, no one would say no. So this child was actually positive. So again, additional investigations, how do we categorize these patients and how do we treat? So let's take them one by one. So, so Dr. Manish, can you summarize for us how does pediatric COVID presents, and do we have any data from world over and from developing countries?
Right, Dr. Ankit. See, I would categorize, there are 3-4 categories how the pediatric COVID presented to us at hospital, clinic, and various settings. One category was a family was diagnosed with COVID, and they also tested the kids in the family. Those were again coming positive. Other was like patient presenting. The most common presentation what we see is fever, cough in the patient. Very few patients in diarrhea, and very important presentation was asymptomatic too. They didn't turn out to be almost 15%. This data is showing, and even other data have shown even 20-25% asymptomatic. So major presentation was fever, cough, persistent sputum protection, and that is how they presented. They may have vomiting, diarrhea, all this. So this was even UK data, a big study of 4,000 children from China, US data, all have shown similar data. This is what they were presenting. In newborns, mostly born to the mother positive were mostly non-positive, in fact. Few infants presented with diarrhea. So that is how they presented.
Yeah. So usually mild, and as summarized in the meta-analysis and talked about by Dr. Manish, these are the common symptoms with which the children have been presenting. Right. So Dr. Rachna, you are the intensivist in BLK hospital, and we would like to ask you that how would you classify severity of a pediatric COVID infection?
So talking about COVID in pediatrics, fortunately we have less incidence in pediatric patients. However, talking about severity, we did find few children who were being severely affected by COVID. I think there is some echo. So who were being severely affected by COVID.
Dr. Rachna, echo comes if you are logged in from 2 instruments in the same room.
So is it okay now?
Yeah.
Is it okay now?
Yes, yeah, better.
Okay, can you hear me?
Yeah, audible.
Dr. Ankit, can you hear me?
Yeah, you are audible, ma'am. Please go on.
Hello?
Yeah, ma'am, please go on, ma'am.
Can you hear me?
Yes,
I can hear you. There was a lot of echo earlier, but now it's better. Dr. Rachna, we can hear you. Please carry on.
I think something is wrong with Dr. Rachna's device. Maybe Dr. Ankit, you'll have to take over, I think.
Dr. Ankur?
Dr. Ankit?
Okay, so basically I thought that nobody can hear me, so I just stopped. I'm sorry for the interruption. So what I was saying is that whenever we are talking about the severity of COVID in the children, it was fortunately very less. However, there were some factors which were seen to be contributing in the severity of the illness. The severity was more seen in the age group between 10 to 18. Then the other important factors which were noticed that if the children have some underlying illness, like in the form of congenital heart disease, congenital pulmonary syndrome, or nephrotic syndrome, or on immunosuppressive therapy, these were the children who were likely to be more affected. Then the other important factor which was noticed, that even the infants, like lately there was a multicentric study from Europe which showed that the infants less than 1 year were also found to have some severe illness. However, the mortality which was seen in the pediatric age group basically belonged to the age group between 13 to 18 years. And the other interesting fact was that there was some severity was also seen in children who have associated viral infections. Like the child with COVID may be positive for many other viruses. So if the child is positive for COVID as well as other viruses, then yes, there is a likelihood that the child may develop severe illness. Then I would also like to comment here that despite of all these odds or all these underlying illnesses, it appeared that children with cancer were not affected with severity of COVID. So that was something which we can't explain right now. And on the other spectra, obesity was seen to be a very important underlying factor for the severity of COVID in children. Now with that, probably I would go, Dr. Ankit?
Yeah, ma'am. And do you have any data on severe COVID infection in children and adolescents?
Okay. Hello?
So any data on children and adolescents with severe infections?
So that's what I was talking about. This was the multicentric trial, which was done in Europe. I think total there were around 10 studies, out of which 8 were from China and 2 were from other centers. Then this was the first multinational multicentric study which was published from Europe. And it said that what they found was, again, the fact that it was more common in children between 10 to 18. However, infants less than 1 month have predilection for it, and any child who has underlying disease has predilection for it. And lastly, as I said, that male also had a PE pontin somehow. Then the children on immunosuppressive therapy or on any immunodeficiency have a predilection for severity of COVID.
Yeah. So thank you. And so there were children who required oxygen support. There were children who required CPAP. There were few children requiring ventilation. One required ECMO and many required inotrope. So it is not that we are totally without a COVID disease in children and adolescents. It does happen. The chances are less, but children can get sick. So Well, what are the radiological findings? Dr. Anurag, can you summarize for us for the COVID-19 infection?
Yeah, good afternoon, friends. Being in Loknayak Hospital, which was the largest COVID hospital in the country, we had hundreds of patients reporting to us initially with COVID positive reports, especially when the guidelines from the government were that all COVID positives had to be admitted. And we initially thought that what to do with these patients. They simply had a URI, maybe no symptoms at all. The parents got, so the large chunk of children who had mild to moderate symptoms, they had nothing in their x-rays. Maybe the ones who were a bit sicker, those who were on the verge of requiring oxygen or had some amount of saturation falling or had prolonged fever, even then in those also x-rays were normal. Rarely we saw GGOs. So GGOs are ground glass opacities. So till a year ago, nobody in pediatrics had heard of GGOs as a short form. Now it's become a standard short form, especially in adult medicine. So this was rarely seen in pediatrics earlier because they are usually found in interstitial lung disease, which is not very common or not seen by most of the pediatricians across the country. We have 4 or 5 patients being a tertiary referral center. So GGOs were seen in this 35%. I'll have to see what kind of percentaging this means. Basically, what was the cohort of the patients. But yes, GGOs were seen. Some patients. Here again, I have to add that a lot of these patients were having comorbidities who landed up with issues of saturation and the X-rays showing consolidation and pneumonic infiltrates. We found a lot of them had tuberculosis, in fact. So maybe that was the added issue with them. Uncommon findings were halo sign. Now, what is a halo sign? Halo sign is simply ground glass opacity, which is surrounding a radio opaque shadow like a nodule or a mass. It represents hemorrhage. Interstitial abnormalities and interlobular septal thickening was seen in a very few patients, 0.7%. Bronchiovascular bundle thickening, again, very few patients. Crazy paving pattern, these are radiological terms. Crazy paving pattern is simply a track with GGOs around it. So this track could be because of thickening of the, septa or interlobular lines. Again, seen in pulmonary hemorrhage, usually found in pulmonary alveolar proteinosis, lipoid pneumonia, in fact, not common in pediatrics, usually seen in adults in bronchoalveolar carcinomas. Lymphadenopathy, very small number, 0.5%. Pleural effusion, again, not very common, but was seen in a few patients here and there. Bronchiectasis was not seen. Air bronchogram, again, not seen. And pericardial effusion also was not seen commonly. So these are the findings which were seen in various CTs and X-rays.
Yeah. So thank you, sir. Yeah. So these are the X-rays and CTs of this child. So an older child, X-ray showing some ground glassing, but not much on the X-ray. If you look at the CT, then this is the right and this is the left lung, and the left lower lobe shows a lot of ground glassing areas of consolidation, which are seen. Right. So Dr. Ashna, can you briefly summarize the treatment as we are getting a bit short of time?
Talking about treatment, basically we will have cases who will be quite mild, who will basically present as upper respiratory illness. Then in those cases, as rightly said by Dr. Shikha, that we should always, give them supportive management and tell them about the warning signs. Now there will be children who have moderate disease where the children may have hypoxemia or may not have hypoxemia. These will be the children who will have subclinical CT or radiological findings, however the symptoms would vary. So if the children do not have hypoxemia, then again the supportive management, these children should be hospitalized and kept under observation. However, the children who have hypoxemia, that is, they are saturating somewhere less than 92%, clinically have tachypnea, then such children should be given a trial of steroids. Now, then comes the severe or the critical children who have developed opacities, who who have landed in ARDS with multi-organ failure. In all such patients, those patients should be taken care in the ICU areas, and there they should receive support along with all the supportive management. They should receive steroids, as well as we should also think of giving antiviral therapy, and that is a debatable debatable, but still remdesivir is something which has been recommended in last 10 months as one of the antiviral which can be used on the compassionate grounds. And basically remdesivir has been approved for children above 12 years, and for all the children who are less than 12 years, then it can be used under the heading of EUA, that is emergency usage authorization, for children who are more than 3.5 kg. And yes, we had a dedicated pediatric ICU beds in the COVID areas, and where we did treat I think 3-4 kids who had a very severe ARDS kind of a presentation of COVID.
Right. So the child was treated with fluids and other supportive care. Remdesivir had to be given and steroids were given. The child improved in 3 days and was discharged after 5 days. So COVID pneumonia is seen more in older children and adolescents. That is something which everyone has seen. The presentation can be quite similar to other viral illnesses in children. The radiological findings are slightly different as compared to the other viral pneumonias. The mainstay of treatment has been supportive. Severe cases would require steroids. Remdesivir, we all do understand, we do not have a very clear role which has been proven in literature, and it has been mainly used on compassionate grounds. Right. So with this, let's look at 2 more cases who presented to us during COVID times, was appearing like COVID. So this 14 years old girl had 10 days fever, but did not have any other significant cough, cold, chest pain, hemoptysis, was COVID RT-PCR negative. Now, because of the fever, the child was treated as an enteric fever. The parents had fever 1 month back, but they were not worked up for anything and were actually well. Currently, the aunt was running fever and was COVID positive, right? And this child came to us at the peak of the pandemic somewhere in May. So at 10 days of illness, she started developing dyspnea, right? The saturations went down, so something like 86% on room air. The CBCs were fine, the platelets were slightly low, the CRPs were high. So this child was given a dose of steroid, thinking in terms of a COVID infection and lung involvement, and was referred to us at BLK hospital, and a CT chest was also done, and I'll just show you that in the next slide. So this is the CT chest of this child. These on the left are the mediastinal windows for the non-contrast CT, and you can look at pleural effusions on both sides, which are seen. These are the axial cuts, lung windows, and you can look at significant amount of ground glassing and nodular opacity, which are present throughout the lung fields. So the question is, what were we dealing with? What is the possible differential diagnosis? What are you going to do about it? So when this child was admitted with us in the PICU, the saturations were low. The child was given oxygen. With that, the child started improving. Steroids were continued. At that time, because it was the peak of the pandemic and it was looking like a possible COVID with involvement of the lung, enoxaparin was started. Azithromycin was added because we were thinking in terms of alternate diagnosis, as I'll show you in the next slide. The further investigations, the platelet counts were dipping down. The CRPs were 47, the tropi were normal, the ferritins were high, the D-dimers were also high. So there was inflammatory markers which were present, but despite this looking like a COVID, the COVID investigations were all negative. So 3 RT-PCRs negative and a COVID antibody was also negative. So what's going on? So we thought that we might be dealing with something else.
Dr. Ankit, 5 more minutes.
Yeah, so I'll try and finish. There was some technical issue in between, so I think we lost a bit of time. So we'll try and finish, Naresh, soon. So what we were thinking was a differential diagnosis of infections like unrecognized viruses and mycoplasma. Non-infectious conditions like MISC, which is a complication of COVID, or subacute interstitial lung disease like hypersensitivity pneumonitis. So we had this differential diagnosis in mind when we were evaluating this child. So Dr. Anurag, can you briefly summarize what is this MISC all about and a small bit of experience on MISC? Dr. Anurag, are you around?
Yeah, I was muted actually. So, okay. MISC is a combination of typical and atypical Kawasaki disease, toxic shock syndrome, macrophage activation syndrome, hemophagocytic lymphocytosis, with prominent involvement of mucocutaneous systems, GI systems, cardiovascular and neurological systems. So most of these patients were presenting with shock and needed inotropic support. So initially we were having a lot of cytokine storm as we thought, as we found in the adults also. Ultimately CDC and WHO gave us some definitions. Both are nearly similar and we have been using them. So the definition was that there should be a fever of at least more than 24 hours along with a laboratory evidence of inflammation like elevated CRP, ESR, fibrinogen, procal, D-dimer, ferritins, LDH, or IL-6. Of course, the values are there. Some of them have to be more than 5 times normal to be considered as elevated. Then elevated neutrophils, reduced lymphocytes, and low albumins. So along with that, evidence of clinically severe illness requiring hospitalization with multisystem, that is more than 2 organ involvement. Again, the organs were cardiac, renal, respiratory, hematological, gastrointestinal, dermatologic, or neurological. And along with that, you should have a positive report of a recent or a present SARS-CoV-2 infection, that is by RT-PCR, or maybe a rapid kit also, serology or antigen test. So these two words are so important, serology test, because initially what happened was when we got our initial 2 or 3 patients, we tried to work up for RT-PCR. They came out to be negative. We said, okay, this is not MISC because of COVID. Later on, around a week or 15 days, we applied our heads and we thought, why not get an antibody test done? And when we got an antibody serology done, because kits were also not easily available at that time, we got them to be positive. This was around June. So then we found, okay, so this is a different presentation and we'll have a serology positive, especially in those patients who were presenting after 15 to 20 days. And this MISC normally presents after 5 to 7 days. That is from second week onwards. By that time, the virus load is low. And so there is a huge chance that RT-PCR will come to be negative. So these criteria have to be met. WHO also talks about the same thing, that children and adolescents should be having 0 to 19 years of age, along with, maybe I should not read all of them. It is just the same thing. So we have a shortage of time. But another thing which we have to keep in mind is that we had a lot of over-enthusiastic diagnosis of MISC made. Later on, we found that a lot of our patients turned out to be disseminated tuberculosis. And one of them turned out to be tubercular meningitis, another had disseminated coughs, one had miliary TB. So all those things have to be kept in mind along with the MISC diagnosis. Thank you. Next slide.
Yeah. So there were pulmonary involvement in MISC as well. Right. So with a repeated COVID test negative, we thought we are dealing with something else. Possibly it was not fitting into a classical MISC, although this child was started on steroids. So we were thinking in terms of a mycoplasma as well. There was a discussion that whether mycoplasma can present like this. Can it present with as a diffuse parenchymal lung disease? Can it present with hypoxemia? Can it present with high inflammatory markers and thrombocytopenias, right? And is there a justification of continuing this child on steroids? Well, mycoplasma can present with high fever, cough, dyspnea, hypoxia, and respiratory failure. So well described in literature. A severe mycoplasma can have bilateral infiltrates. It can have diffuse interstitial patterns like reticular, nodular, linear. Diffuse alveolar pattern with air bronchograms is also described. A mixed pattern is also described, and pleural effusions are also described. So the clinical picture, yes, can be explained with mycoplasma as well. And there are entities like a macrolide resistant mycoplasma. There are entities like a refractory mycoplasma. So if a child is not responding, but is proven to be a mycoplasma, you might be dealing with a resistance to azithromycin, which can be tested either with a drug susceptibility or with a PCR. And there is something known as a refractory mycoplasma, where despite appropriate antibiotics, the child doesn't improve, is related to a cytokine storm, and LDH is severely high. Right. So we were working on this child, and as I said, the respiratory biofire was already sent. That was negative. We sent a investigation for mycoplasma, that is the serology, because it was already late into the illness. That is why a PCR wasn't sent. We sent a panel for a hypersensitivity pneumonitis. So the child improved, the hypoxia improved, the child remained afebrile, there was no respiratory distress. The child was shifted to ward on steroids and azithromycin. Now, in the follow-up, the child, when the child came in the follow-up, the IgMs were high. The IgGs were normal at that time. The panel for the hypersensitivity pneumonitis was negative. Steroids were gradually tapered and stopped. The child was followed up clinically and with a lung function, which was normal at 6 weeks and 3 months. So at the end, we in association with the clinical, radiological, and the serology and the follow-up, the conclusion was this was a Mycoplasma pneumonia. There are algorithms which have been described for Mycoplasma pneumonia. So if you have a highly suggestive Mycoplasma pneumonia, so clinical features in association with an IgM which is positive, or an antibody titer which is increasing, or a positive PCR, use first-line antibiotics as shown. If the child does not improve or deteriorates, you can consider a resistant mycoplasma and add doxycycline or ciprofloxacin. If the child still does not improve, you might be dealing with a cytokine storm. Consider a refractory mycoplasma if the LDH are high. Add steroids. If the child is still not improving, methylprednisolone the dose can be increased. And Dr. Anurag might be remembering that he had referred a child to me, admitted in some other hospital, had a severe or a refractory mycoplasma, where I had pulsed the child with methylprednisolone after a bronchoscopy, and the child still remains in follow-up. So this is very well known, but still not very clearly described amongst the group, right? So
can I say something?
Yes, ma'am.
So basically, when you consider Mycoplasma as one of the causative organisms, then usually it is a very mild illness and nobody's bothered. But it is the genetic configuration of the Mycoplasma itself which is responsible for some kind of a severe disease. And this usually happens by a toxin which is released by few mycoplasmas, which is called as CARDS, community acquired respiratory distress syndrome toxin. And this is responsible for this kind of a manifestation, which can manifest like vasculitis and thrombosis. So I think it is very important that one should keep in mind that Mycoplasma can also present as thrombocytopenia with all increase in inflammatory markers. And this was a beautiful case which came across in our unit, and we all were like, doing COVID, and this turns out to be Mycoplasma. So as he's going to conclude, Dr. Ankit is going to conclude that how it can mislead us, and we should always keep Mycoplasma as one of the entity, especially if you have pulmonary involvement along with the neurological manifestation, because neurological manifestation is again a very important extrapulmonary manifestation of Mycoplasma.
Yeah, so we had a child, I think last year with Dr. Basin sir, where the child actually had pneumonia. We thought it is Mycoplasma. We were trying to investigate, and during that time in the hospital in front of us, the child developed an infarct, right, and developed an hemiplegia. So all these things are very well described with Mycoplasma, and I think people are now getting more aware about the atypical pneumonia. So every pneumonia is not COVID pneumonia, especially in children. Mycoplasma is a walking pneumonia. where there's a disparity between clinical and radiological findings. But severe mycoplasma pneumonia is more of an immunological response due to the cytokine storm. Right, so we'll just...
Dr. Ankit, what has happened is some of the mycoplasma pneumonias were treated during COVID as COVID because azithromycin was given and a good amount of steroids were given. So
yeah, true, sir.
Components were managed.
Yeah, true, sir. I totally agree. But when this sort of a pandemic happens, then some things are difficult to to control. I totally agree with that. So I think we are going really short of time, and I'll just summarize the last case. This is a 13-year-old boy, had breathing difficulty for 2 months, gradually progressive, started on exertion, but now on rest. There was no fever, cough, hemoptysis, and no significant past history. So an older child and subacute symptoms. That is what we are looking at, gradually progressive symptoms. Now admitted outside, X-ray showing diffuse ground glassing, CT chest will show you similar findings, severe pulmonary artery hypertension and COVID negative, right? Now, this child was referred to me and in December last year. The weight was fine, hypoxic, very dyspneic, and chest clear on examination, right? So diffuse ground glassing on the X-ray, which you can see. So this X-ray is more whiter than the normal X-rays which you would see. So we are talking about subacute symptoms, gradually progressive, now leading to hypoxia and diffuse alveolar infiltrate, right? So with this combination, what can be the possible differential? You can have a long list, but what commonly is seen can be sometimes miliary tuberculosis. We've seen a few eosinophilic pneumonias, interstitial pneumonias, diffuse alveolar hemorrhage is something which should be kept in mind, and a subacute form of hypersensitivity pneumonitis. So this is the CT, and you can see the diffuse amount of ground glassing which is seen, air bronchograms which are seen, and you can see here that this is the aorta and this is the pulmonary trunk, and the pulmonary trunk is larger than the aorta, signifying a severe form of pulmonary artery hypertension as well. So we went ahead, did a bronchoscopy to rule out infections. The aerobic cultures were normal. The gene expert was traced, which was not significant. The grams and the KOH stains were negative. So we immediately pulsed this child with methylprednisolone for 3 days. The child improved, was discharged. We added hydroxychloroquine because we were thinking that the infections are not there. It was not eosinophilic. It was not like an interstitial disease. It was more like a subacute hypersensitivity pneumonitis. Now, during follow-up, as we can see, the hypersensitivity pneumonitis panel came back, and you can see that the pigeon serum dropping feathers and droppings were significantly high. So the child was finally diagnosed as a subacute hypersensitivity pneumonitis, secondly to pigeon droppings. Right, so think of a subacute form of an ILD, or you can have a chronic presentation of hypersensitivity pneumonitis with peripheral sparing and soft nodular shadows throughout the lung. So this is something which is not as common, but definitely any pulmonology group would be seeing 2 or 3 patients a year who present to us like this. So with this, I would end the panel. Thank all the panelists for a great discussion, and thank you all the audience for being with us and a patient listening. If we have any times, we would take the questions if Naresh allows.
Thank you, Dr. Anurag and Dr. Lakshmi.
So Naresh had said no, so we can't do anything about it. Very sorry. If you have any questions, do contact us. We'll be happy to answer them.
You have answered most of the questions in your talk, sir.
Yes, Bob.
Excellent talk. And I don't see any questions there. Regarding few questions about MIC is there. For Dr. Rachna, is antibody required for diagnosing of MIC?
I think, and see, what is the issue is that initially we were doing RT-PCR negative, we said कि ये तो COVID नहीं है. Later on we thought कि because by day 7 or 8 the virus disappears, so we'll do antibody titer. So if you're able to do IgM, most of them come positive. But still, if you have a strong suspicion, you have a close contact with a COVID patient, and the picture is like MIS. See, ultimately, what is it? It is a hyperimmune reaction to some virus or some bacteria, and we will all be giving antibiotics to a sick patient. So if you look at it, if you give a good amount of steroid along with an antibiotic cover, most of your other conditions are also covered. So that is the practical way of looking at it. Yes, to have a strong diagnosis, you need RT-PCR positive or antibody positive. Or you can send the hypersensitivity panels and all that, maybe you'll get something out of it, but the patient has to be managed meanwhile. So if you understand what I'm trying to say is that you manage the the immunological reaction along with an antibiotic cover, most of the things will be covered. Thank you.
I just had one query at this point that even we may not get a history positive because, the pandemic is that the child may have been exposed sometime, somewhere to somebody unknowingly.
Yes,
because there were a lot of asymptomatic carriers every time. So, Dr. Rachna, would you say that we definitely need to have a history antibody positive or RT-PCR positive to label it as MIC?
No, I don't think the most important aspect is to exclude the other microbial presence. That is, when you are making a diagnosis of MISC, there can be evidence of RT-PCR positive, there can be evidence of serology positive, there can be evidence of exposure, or even a patient coming from a hot zones or hot areas.
Containment zone.
There you can take it as evidence of COVID, but mindfully, one should exclude like not having any other microbial infection, because all these inflammatory markers can be positive in other microbial infections. So one should not be in haste in making the diagnosis of MIC. And as very rightly told by Dr. Anurag, that we were quite over enthusiastic to make this diagnosis. So I think we had few cases where we had COVID antibody positive, child was running fever, but child was asymptomatic, we didn't do anything. Then there was a kid who turned out to have fungal infection. Then there were kids whom we treated aggressively because they had cardiac involvement. So I think whenever you have some evidence of COVID, even there were kids who didn't have antibodies positive, RT-PCR positive, but all the other parameters were there. And we didn't wait for the cultures. We just started them on antimicrobials and treated them aggressively because they had a lot of cardiac involvement. And
luckily, we had a lot of tuberculosis coming. So my thesis got completed because of this. Tuberculosis presented with hypoxia, and of course, because they were coming from COVID areas, they were COVID positive, and the kid was also being positive. So it's a very mixed kind of a picture. Now you label that patient as MISC because see, two organs are involved. Lung is involved, and maybe you have a lymph node or some kind of involvement in the CNS or abdominal involvement. So they were basically COX with COVID positive. You can label them whatever you feel like, but they needed ATT, and all of them did well on anti-tubercular medicines.
Dr. Ankit, one question.
I just read one comment here. As Dr. Anurag said that they all were hypoxic. So classically, what I have seen in many of our patients that respiratory system would be the least affected system. So the hypoxia won't be a big issue in these kids. Mainly the hemodynamic instability, cardiac involvement, and the fever which won't be going, and of course rash and conjunctival congestion. All those features, they were the pinpoint. They were pointing us towards the MIC. So respiratory, I won't say a very big part of MIC. Respiratory was primarily involved in a COVID, acute COVID. But for MIC, I would put respiratory system quite down.
Yes. Yeah, so I think we need to end the panel discussion here. I hope with this panel discussion, the COVID ends. Let's not talk about COVID. Let's go on, and we'll have a physical meeting from now on. So thank you very much. The COVID ends.
So thank you to the organizers. Thank you, Dr. Naresh, Dr. Ankit, Dr. Rachna, and all the team of BLK for having this wonderful session and having me here. Thank you.
Thank you, Dr. Anurag. Thank you, everyone. Thank you.
Thank you, Dr. Ankit, Dr. Rachna, and Dr. Shrikant. So we'll move on to the next talk.
So just a moment, I'll just take 10 seconds. So this is a beautiful t-shirt, and I want all of you to be present on Sunday.
Anurag, please show the logo. Logo is not seen.
Not visible.
Back part. Yeah.
Yeah. So I invite Dr. Manish also to be there. Although Dr. Manish has made the t-shirt, it is his program and we are all a part of it. So all of you, we have talked about the lung a lot and we want your lungs to be strong. Please be there on Sunday morning, Nehru Park. Please register. Thank you so much.
Thank you, sir. This will move on to the next talk. So the next session is on fluid and electrolytes. Next session is on fluid and electrolytes in the infant. The speaker is Dr. Vipin Vasudevan. He is the associate consultant in pediatric ICU at BLK Super Specialty Hospital. And to chair the sessions, we have Dr. Shekhar Biswas. He's a consultant in Department of Pediatrics and Neonatology at Jaipur Golden Hospital. He's the secretary of IEP in North Delhi 2021. He's executive member of Central IEP, and he has a special interest in field of immunization, nutrition, neonatology, and intensive care. He's also the trainer of IEP NRP program, and he was also the executive member of North Delhi IEP 2019-20. Our second guest is Dr. Dheeraj Bahl. He is a professor and head of the Department of Pediatrics in RML Hospital, New Delhi, and he's the president Delhi IEP currently. And he's also the member of IIP and NLF. And next esteemed chairperson is Dr. Pankaj Kar. He's a secretary-elect IIP Delhi and also on the IIP executive board member. He's a senior consultant in the Department of Neonatology in Gangaram Hospital. And he's also a neonatology and DMP pediatrics teacher. And he was also the North Delhi president in 2019. So over to Dr. Vipin. You can start the session.
Thank you, Dr. Naresh. Good morning, everyone. We are, I think, around 1 hour lagging behind the session. So we'll try to finish off this session as quickly as possible. I request all the questions to be put up in the chat box so that it can be answered along the presentation is going on. So today's talk is basically on fluid and electrolytes, and we are mainly focusing on children in this aspect. So before we start the presentation, we need to understand what the total body water is. Basically, the entire mass of the total body, it is composed of 50 to 65% of the total body is composed of water, in which 2/3 is present inside the cells, which includes the mainly lean tissue that includes muscle and the organ tissue. And only 1/3 is in the extracellular compartment, and of which 25% is in the intravascular space. So overall, there is 8% of the total body where water comprises the intravascular space. Now, as we all know, as a fetus, the body contains 90% of the body contains the water. As the fetus grows and becomes a child, around 60 to 70% of the body comprises of the water, and eventually when we become adults, 60% of the total body weight comprise of the water. So why are we having this session? Why the infants are more vulnerable, and why are we more talking about these fluids in infants? The main reasons being this: there is a physiological inability in the infants to concentrate the urine. There is a high metabolic rate because, and they have a large surface area, as we all know. And unlike adults, these infants, they cannot express their thirst, and there is a large turnover. So when there is a loss of body water, whether it can be an acute condition or a chronic condition, there are a range of problems can happen from mild lightheadedness to even mortality. So going on to the electrolyte composition in the body. So as I told, we are dividing the body into plasma and the extravascular, intravascular space. As we all know that sodium, which is a predominant cation in the plasma in the extravascular space, and when we move on to the intravascular space, we have potassium as the predominant cation. So there are multiple organs which obviously almost all our organs are dependent on the electrolyte stability, and electrolytes play a very major role in this, like in lungs, in intestines, heart muscles. We know sodium, potassium, calcium play a major role. For nerve conduction, we know the electrolytes like sodium, potassium are extremely useful. Now, what happens when, how is a normal fluid electrolyte balance maintained in the body? So we all know that homeostasis is achieved when there is a normal sodium concentration in the extracellular fluid. Sodium is a very important electrolyte for that purpose. So when there is the homeostasis is disrupted due to XYZ reason, what happens is there is increased sodium concentration in the extracellular fluid. This triggers the osmoreceptors to be stimulated, which increases the antidiuretic hormone release, which increases the thirst, and subsequently the urinary water loss is decreased, leads to increased water gain, and this dilutes the extracellular fluid and the volume is increased. Subsequently, the homeostasis is restored. Let's move on to a case now. We have a 10-month-old child who comes with a weight of 10 kgs, presents with fever since 2 days, vomiting 2 episodes, and poor oral intake since morning. It's a very common scenario which is seen in most of our OPD practice and also maybe sometimes in emergency. So these children on examination, this child was febrile with severe, high-grade fever of 103 degree Fahrenheit, was lethargic, however, was hemodynamically stable. So as in most cases, because due to poor oral intake, child was admitted and IV fluids were started. Now, how do I start the IV fluid in such a child? The maintenance fluid calculations are done by Holliday-Segar formula, which we are all aware of. This was formulated on normal infants in children, and based on the on the weight of the child, caloric expenditure was calculated with the formula which we all know. Based on this caloric expenditure, the fluid rate was calculated, and as we all know, on the basis of the weight, we calculate the daily maintenance fluid and it gets started for our children. Apart from this, we also need to focus on the electrolytes. So sodium requirement is 3 milligram per kg per day, potassium requirement is 2 milligram per kg per day. Now, based on this formula, when we calculate, we get for a child of 10 kg, we have a volume of 1000 ml which is required. Sodium, potassium is this requirement. So when we look at these electrolytes, we know we get a calculation of fluid, that is isolate P, which probably is the ideal fluid at this point of time. So this child was apparently started on isolate P as maintenance fluids, but what happened? After 16 hours of admission, child had a generalized tonic-clonic seizure. So at this point of time, what is our most likely explanation? A relatively stable child, not a very critical child, gets admitted, gets IV fluids maintenance, and throws a seizure. At this point of time, what all we should consider? Because there was fever, we need to keep meningitis in mind. We have to consider a possibility of intracranial event that happened in the child, electrolyte abnormality, and medications. Now here, I would mainly weigh towards checking on the electrolytes, because that is the most easiest thing also to do. So when I checked the electrolytes, the sodium was 117 milligrammes per liter. What was the admission sodium? It was 126 milligrammes per liter, which was overlooked, and which most of the situations we all tend to overlook and not give much of importance to the situation. So what happened here is iatrogenic hyponatremia, which is a tip of an iceberg situation and most commonly overlooked situation in our day-to-day practice. So is isolate P an appropriate fluid in a critical illness situation? Like when we are calculating the fluid requirement and the electrolyte requirement, isolate P, is it actually fulfilling all the requirements of the patient? The answer comes no. And why is it no? Because when there is a critical illness, high levels of antidiuretic hormone is released. It can be, the stimulus can be anything. It can be a physiological stimuli or a non-physiological stimuli. So what happens? This leads to an inability to excrete a solute-free water. So there is a lot of solute-free water which which gets accumulated in the body. And as we all know, hyponatremia can cause not only because of sodium loss, it also can cause because of a increased free water. So there is a SIADH situation which gets created in children of this condition. So if you look at the common IV fluids, we know that there are hypotonic fluids and isotonic fluids. So here the recommendations comes that we need to focus on administering isotonic or near isotonic fluids because they have a sodium concentration which is relatively on the normal side. As we all know, and the osmolarity in these fluids are also close to the human plasma concentration. Now, sodium and potassium, So this created the American Academy of Pediatrics to pass on a key action statement in 2008, which states that patients between 28 days to 18 years, they require maintenance IV fluids should receive isotonic fluids with appropriate potassium and dextrose, which can significantly decrease the risk of developing hyponatremia. So when we talk about adding maintenance electrolytes, we need to have an adequate chloride. Glucose needs to be administered. What we normally give in DNS and half DNS is 5% dextrose, which provides approximately 17 kilocalories per 100 ml, which is close to 20% of the daily needs. And this is enough just to prevent ketone production and minimize the protein degradation. So it is not a substitute to have a complete nutrition for the child. So we cannot give maintenance fluids for a longer duration because invariably children will lose weight if they are put on just maintenance fluids for a longer duration. So even in National Patient Safety Agency in UK also recommended the same thing and withdrew the use of isolate P in 2008. They recommend that to use sodium chloride, that is normal saline, with dextrose or RL according to the patient needs. And if at all we are using isolate P, we need to have a properly justified documentation. So in this patient, how do we correct the sodium? By using this formula, we calculate the sodium deficit. The rate of correction should not exceed 0.5 milliequivalents per liter per hour. That amounts to around 12 milliequivalents per day. The rapid correction should be avoided because it can lead to central pontine myelinolysis. Acute symptomatic hyponatremia, we need to manage by using 3% saline, which can be given at 5 ml per kg just to have a rapid rise of the potassium. In this child also, a 3% saline was given and subsequently sodium was concentration was increased and sodium monitoring was done. Going on to the second case, a 10-month-old child with loose stools, multiple episodes, large watery since 3 days. Parents were giving ORS at home. Again, a common scenario, came in with decreased urine output, anxious, irritable, dovey feel skin, and there is no obvious signs of dehydration. When we checked the child, the sodium was 164 milliequivalents per liter. So we have a hypernatremic dehydration here. So what are the types of dehydration we are aware of? It can be isonatremic or isotonic, hyponatremic or hypernatremic. So isotonic or isonatremic dehydration is the most common scenario here. The serum osmolarity is 270 to 300. Sodiums are normal range. 70 to 80% of the cases are isotonic dehydrations. In hyponatremia, we have a low serum osmolarity. In hypernatremia, we have a high serum osmolarity, and which is commonly seen with during the illness and incorrectly prepared high concentrated oral electrolyte solution, which is being administered. It's not a very uncommon scenario in our day-to-day practice. So hypernatremic dehydration is the most dangerous form. Why? Because the movement of water from the intracellular space to extracellular space protects the intravascular volume, and child often tend to appear less ill. The urine output may be preserved for longer duration and the tachycardia may be on the lower side. So while thinking about management of these patients, if the child is in shock, we need to resuscitate with normal saline first, irrespective of the sodium concentration. After that, sodium concentration needs to be managed as per the details given below. That depending on the sodium value, we can plan the duration of sodium correction. So fluid should be administered at constant rate, and typically more or less 1.5 times the maintenance of the fluids of 1/4 or 1/2 of normal saline can be used. The most important thing here is we need to have a sodium concentration being monitored very closely. So if there are signs of depletion, we need to bolus with normal saline. If we catch the sodium falling down too rapidly, we need to address that situation by giving 3% saline boluses. And if whenever there is a ongoing losses, it has to be replaced. These things needs to be kept in our mind. Moving on to the next case, child with the hemolytic uremic syndrome was planned to start on peritoneal dialysis. We get a call from the lab saying that potassium is 7.1. They also mentioned that the blood was not hemolyzed. What do we do now? So here we have to send a repeat potassium sample immediately from the free-flowing sample. But the therapy should not wait till the report. Initially, we have to stop all the potassium-containing fluids. Calcium needs to be administered. This is basically not to decrease potassium level, but to have a cardiac protection. So there are two ways of managing hyperkalemia, mainly by shifting the potassium inwards into the cell or by removing the potassium. So shifting happens by using beta-2 agonist nebulizations, glucose insulin drip. Soda bicarb can be used only if there is a hyperchloremic metabolic acidosis. Now, potassium can be removed by using K-oxalate, which we are aware of, using 1 to 2 gram. We can give it orally or by a retention enema. Furosemide, that Lasix, can be used in most of the patients. Dialysis is the modality which is used if the hyperkalemia persists beyond the initial management. Moving on to the fourth case, infant who was recovering from septic shock. Initially, since admission, child received around 150 ml per kg fluid boluses in the first 24 hours time. Because the child had received so many fluid boluses and was having NSRCA, child was started on furosemide infusion after stabilization, but complaints of developing limb weakness and poor respiratory efforts. The ECG showed unifocal premature ventricular beats. What is the diagnosis and what test would you order as of now? So the diagnosis mostly depends on the report which we obtained that potassium is 2.4 milligallons per liter. There is hypokalemia. So when you look at the ECG changes in hyperkalemia and hypokalemia, I would like to draw your attention to the T waveform and U waveforms. In hyperkalemia, we get a tall T wave here. However, the T wave is shallow in a hypokalemia. When in a hypokalemia, you have a U waveform which is not seen in hyperkalemia. More or less, both have a prolonged PR interval. And what are the clinical manifestations when hypokalemia? It is a electrolyte which is most often missed. Hypokalemia is not addressed significantly, and this leads to patients having a long-term consequences, like especially neuromuscular weaknesses and hypoventilation. Arrhythmias are known. Constipation paralytic ileus is also a very well-known entity. And when we look at endocrinal condition, metabolic alkalosis is something which persists in children. So how do we treat? When you want to treat, oral is the safest method, but it may cause diarrhea in most cases. IV, we can plan our correction based on the peripheral line or a central line. Peripheral line, we try not to exceed beyond 40 to 50 milligrams per liter, and make sure you do not give any rapid boluses. Central line can be given with 0.5 to 1 milligram per kg over 1 to 3 hours. Now going on to the last case, 11-month-old child with a history of acute onset of fever, rash, and altered sensorium. Sick child presents to ER in shock. Septic shock diagnosis was made. Child was managed with multiple fluid boluses and started on inotropic support. He was ventilated and intubated and invasively ventilated. Now, after 4 hours, child actually becomes clinically better. Hemodynamics improved. But when I repeat a blood gas, it showed a worsening metabolic acidosis. What is happening here? So when an electrolyte study was done, it shows that the chloride was significantly on the higher side of 123. Now, this condition is an entity which needs to be addressed in most of the sick children. Hyperchloremic acidosis, which is defined by looking at the strong ion apparent difference. So we take the positive cations and then take a difference in positive and negative cations. So as I want to point out here, when there is hyperchloremia consequent to saline infusions, there is a decrease in strong ion difference, which leads to metabolic acidosis. So hyperchloremia can cause renal vasoconstriction and the reduction in GFR, subsequently leading to reduction in urine output. So the question needs to be addressed here is the normal saline really normal? So what happens here when you look at the normal saline and the balanced fluid solutions like plasma, light, and ringer lactate, what we see here is the chloride content, which is on the close to the normal range. And as an alternative chloride, these solutions like ringer lactate and plasma light, which are called as balanced fluid solutions, they contain lactate, acetate, gluconate, and malate. Now, in the observation studies, balanced fluids have shown to cause less renal injury. Need for renal replacement therapy in post-operative and ICU patients are less. They are relatively hypotonic fluids, relatively hypotonic. They are also isotonic, but relatively hypotonic. So needs to be cautious in administering in neurological illnesses. Excess administration, it is associated with metabolic alkalosis also. So few studies have been done on plasma light, as this study which was published on DKA, comparing the use of plasma light and normal saline, showed that lower serum chloride concentrations and higher serum bicarbonate concentration was achieved with plasma light use initially in DKA patients, and made for some benefit in time of recovery, improved mean arterial pressure, urine output in DKA patients. There was a large multicentric study which was published in January 2021, done on 708 patients, where a balanced crystalloid was compared with the saline for initial fluid resuscitation in children with septic shock. It showed that the mortality was similar in both these groups. However, there was significant reduction in the risk of acute kidney injury and the significant reduction in the use of renal replacement therapy in children who were used balanced crystalloids for initial fluid resuscitation. So fluid therapy, is it always good? No, it can be a double-edged sword, because fluid administration is one of the most frequently used things. More adverse events are reported from fluid administration than any other drug. It is also a drug, so it should be used very cautiously. Up to 20% of the patients receiving IV fluid subject to inappropriate fluid therapy, so it's never innocuous and can be very harmful. So to summarize, routine assessment of the hydration status is critical in patient care. Restoration therapy is important for faster recovery. Isotonic or near isotonic fluids are ideal. Electrolyte monitoring and replenishing at the appropriate time is essential, and ensure a adequate calorie supplementation also. So that is something which needs to be always looked at, that calorie adequate supplementation needs to be done. Otherwise, children can end up being deficient in the calorie level. Thank you.
Thank you, Dr. Vipin. We are open to questions. Chairpersons, Dr. Dheeraj, Dr. Pankaj, Dr. Shekhar. Perhaps have a few comments.
Am I audible?
Yes, sir.
Yeah, it was a very nice presentation, very compact, and all the issues were addressed too. But just for the sake of knowledge, I would like to ask one question. What are the fluid and electrolyte status in the CHF and the raised ICT? Because the fluid and electrolytes need to be modified. So please comment on the CHF and raised ICT and fluid and electrolytes.
In cardiac failure, we need to initially, what needs to be followed when the child comes in with seizures in the emergency. What we address is mainly on giving fluid boluses. That has to be completely monitored, and a mini bolus of 5 ml per kg can be given. Subsequent fluid boluses needs to be given only based on the fluid status or fluid status of the child after being assessed. In our center, we have ultrasound machine in the emergency, and our residents and fellows actually look at the fluid status of the patients in the cardiac patient, then only the further fluid boluses are given. As far as the neurological or CNS patients are concerned, the sodium is something which needs to be kept in mind as far as electrolyte is concerned. A higher sodium is actually brain, helpful for the brain. So we need to target on keeping sodiums on the higher side. It can even go up to 150 to 160 milligrams per liter of sodium is not harmful in any child with CNS infection. So in fact, in such patients, we give 3% saline boluses and keep them on 3% saline infusions to maintain a higher sodium to be neuroprotective.
Yeah, thank you.
Thank you, Dr. Bivin. I think it was a very good and lucid talk on fluid electrolyte, which has been an enigma, be it our MBBS days, be our MD days, be our residency, and so on. So these things are very basic and should always be known to the person who is starting the fluids. But it is always important in any sick patient who is in pediatric ICU or in neonatal ICU to have the electrolytes, and accordingly the fluid should be changed. It should be a dynamic process rather than a monotonous sort of. Thank you.
Dr. Pankaj wants to add something.
Thank you, Dr. Vipin. I think fluid electrolyte therapy is always a challenge. It's easy to lay down rules, but once you do that on day-to-day patient, you need a lot of variations. So all of us have burnt our fingers by giving more fluids in dengue syndromes initially when the dengue first came in '96. Similarly, in a newborn with hypernatremic dehydration, baby comes to you with weight loss of 30%, 50%. So you have to be very cautious in not giving a lot of fluids, taking care of the electrode imbalances like hypernatremia, hyperkalemia can be really challenging at times. So I understand that summarizing such a difficult, elaborate topic in half an hour is a challenge, but you have done that very well. And I'm sure all of us, all intensivists, have to really master fluid electrolyte therapy for better outcomes. With these words, I thank you again and thank you BLK team for giving us this opportunity. Thank you.
Thank you, sir. So as rightly said, fluid is a drug. We have to use it very conservatively in all the patients. So it can improve your patient and it can kill your patients. So always have a bedside monitoring equipment before you go on for giving fluids. So with that, we'll proceed on to the next talk. So the next talk is on an update on atopic dermatitis. The speaker is Dr. Tanvi. She's a dermatologist at BL Kapoor Hospital, and she also has her own clinic. And she's also an eminent speaker on the same. For chairing this session, we have Dr. Alok Bhandari. He's the head of the neonatology and pediatric department at Kukreja Hospital, and also a consultant neonatologist at Seizure Southern Hospital. He's a Secretary General of NNF, also an executive board member of IAP, and Vice President of DMA. He's also the State Secretary of DMA. And next eminent speaker is Dr. Piyush Jain. He has done his graduation from MMC and post-graduation from Safdarjung. He is the former president of IAP East Delhi, former president of IMA also East Delhi, and also the chairman of Genesis Neurogen, Neuro Rehabilitation Center for the Special Needs. So let's hand over to Dr. Tanvi. Madam, you can start.
Yeah. Thank you, Naresh. Good afternoon, everybody. We'll be starting a talk on update on atopic dermatitis.
Madam, please unmute. Madam.
I am unmuted.
Please unmute, ma'am.
Yes, she is very much audible. Go ahead, Tanvi, go ahead.
Yeah.
Okay.
As we all know, atopic dermatitis is a chronic relapsing dermatitis with intense pruritus. Intense pruritus is the hallmark of the disease. It can be distributed between various stages like infantile, childhood, and adult forms. 85% of atopic dermatitis presents by the age of 5 years. And in that, around 70% remits by adolescence. The leftover is those who persist in adulthood, and there can be a difficulty in managing them. Coming to the pathogenesis of atopic dermatitis, it's basically a product of complex interactions where there is susceptible genes. So we have seen that around 10% of the family history can be associated with atopic dermatitis. There is dysregulation of the immune system. There is a play of Th1 and Th2 cells. There is a skin barrier dysfunction. And the most important factor is the environmental factors. We have seen that aeroallergens like house dust mites, pollens, animal dander, molds do lead to increase in the atopicity of a child. Food allergens, especially cow's milk, nuts, especially peanuts, eggs, soya, wheat, seafood, shellfish. There is an important hypothesis, which is the hygiene hypothesis, which is very much, you can say, prevalent in developed countries. There is an immaturity of the immune system because of excessive hygiene habits which we follow. So we have seen the immune system doesn't get exposed to the antigens, and so it leads to increased atopicity in children of developed countries as compared to underdeveloped or poor countries. Coming to the diagnostic criteria, the essential features is pruritus. If there's no itching, we cannot make a diagnosis of atopic dermatitis. Second is eczematous changes, especially the face, neck, extensor involvement in infants.
current or prior flexural involvement in elderly children, and sparing of groin and axillary folds. And the third important is the chronic or relapsing folds. As we have discussed that around 80% children maximum at the age of 5 years have all these things. Other important features is early age of onset, personal or family history of atopy in the form of hay fever, allergic rhinitis, dry skin, or atopic dermatitis in parents or in other family members. Lastly is xerosis or dryness of skin. Like in this picture, you can see there is involvement of the cheeks, there is little bit on the chest, and the extensor involvement. The elbows and the knees are involved in this child. This is what we need to see. So there is erythema, which is the redness of the areas, edema, which is swelling of the affected area, small water-filled vesicles or vesicles which are formed, and there is eczematous spitting. This is an infantile atopic with the headlight sign, that is involvement of the cheeks, the forehead, acute oozing, mainly the extensors. Similar picture of infantile atopic dermatitis. This is a childhood atopic dermatitis, which is more chronic, more lignified, which is more thickening of the skin, and it's more flexural. It's more of cubital and popliteal fossa which are involved. There are other associated features of atopic dermatitis, commonly something like keratosis pilaris. So like in this picture, you can see these small rough papules which are mainly present on the upper aspect of the arms and thighs. So the child is not itchy, but they're like dry skin thing. This is ichthyosis or the fish-like scales. Then there can be perifollicular accentuations, ocular and ocular folds or the Denny Morgan folds because of excessive itching in the eyes and outer areas, which can lead to thickening of the skin periorbitally. There is pityriasis alba or dry skin or the white patches we see in a child. Coming to the clinical examination and history, the most important thing is to differentiate atopic dermatitis from other differential. So in a child around the age of 3 to 4 months, he can either present with atopic or he can either present with seborrheic dermatitis. How to differentiate between an atopic or a seborrheic case? So this is a patient who presents, he's around 3 to 4 months of age. He presented with little yellowish greasy scales on the scalp, on the edge of the eyebrows. So, but the child is relatively, there is absence of itching in the child. So these scales, no absence of the absence of itching, there approximately involvement of the diaper area. So this is a case of seborrheic dermatitis. They tend to appear early, around 2 to 3 months of age, and by maximum 6 to 12 months, they settle down. So the only thing which differentiates atopic from seborrheic is the absence of pruritus and also involvement of the groins, which is absent in atopic dermatitis. Second is contact dermatitis, which is generally milder. It is less pruritic, it's less oozing and eczematous as compared to atopic, and it gets resolved on identification and removal of the cause. So like in this case is the use of this locket, which has led to a kind of contact dermatitis in this child. Very important, but very prevalent in India is scabies. So there is intense itching. There is intense itching. There is characteristic distribution of the lesions, especially the finger webs, the axillary folds, all the areas which are hidden are involved. History of infestation in family members. So scabies has to be ruled out. So we need to take a history very seriously in all family members or anybody visiting with history of itching, especially at night or maybe when they are more relaxed, which can lead to the diagnosis of scabies. Pneumonitis dermatitis, which we very commonly see in change of season or in winter seasons, is a point-shaped lesions of around 1 centimeter or more in diameter. They're characterized by discrete erythematous round plaques, and like I said, it's more in winter months on dry skin. It's not very itchy. Now coming to the treatment of atopic dermatitis, it's very important to educate the parents or the caregivers. We have to tell the pathophysiology of the disease. We have to tell the course of the disease. So like I normally tell my parents or my caregivers that see, the child has started atopic around 6 months of age. So by 5 years, the atopicity will continue. So there will be phases, there will be peaks and plateaus, but by maximum by 5. And if not by 5, then by puberty. So that is around 10 to 12 in females, and by 13, 14 in boys, the disease will start getting better. We have to tell about the trigger factors. We have to ask the mothers or the parents that what is triggering the child. So we have to take care of those areas. There are a lot of myths about atopic dermatitis. There are these nani, dadis, or who keep coming up with questions about atopic. So we have to basically teach them this is basically just a passing phase in a child's life, which he or she will get over with. Dietary assessment has to be discussed, because they said we will not give him this food, we'll stop the food because maybe that's the reason. So we have to take a very good food history from the parents and then discuss that if or not which food to be avoided, or if they are suspecting anything, then we have to go in for tests. And demonstration of topical cream. So I'll be coming to how to tell them how to use a steroid cream. So these are few of the subheadings which we'll be talking about the treatment. So coming to first is to reduce the contact irritants. So we have to avoid overheating. So we have to use lukewarm baths. They should be 100% cotton clothes. Keep bedding to minimum, or maybe we can use dust mite free beddings. Avoid direct skin contact with rough fibers, particularly wool, and limit or eliminate detergents. Avoid dusty conditions, low humidity. Especially in adolescent girls, we have to avoid cosmetics, especially makeups and perfumes, and avoid soap and use soap substitute. So in winter months, I normally tell my parents that they can use best to avoid heaters or blowers, but if the conditions are too cold, so they can probably use an oil heater with a humidifier or maybe half a bucket of water in the room so that the air doesn't go dry. We have to reduce the exposure to allergens. So we have to keep homes, especially bedrooms, free of dust. As the child can have house dust mite allergies, molds, grass pollens, animal dander. To avoid smoking cigarettes in home. And if food allergy exists, it has to be diagnostically eliminated from the diet for 4 to 6 weeks. And if the severity of atopic gets better with elimination, then an oral food challenge should be done along with an allergist. So this is the only criteria. So oral food challenge is the only criteria which we can do if a parent or if we suspect a food allergy. So multiple dietary restriction and long-term dietary avoidance should only be undertaken if there is a documented or clinically relevant food allergies. Otherwise, they can lead to weight loss, poor growth, calcium deficiencies, hypovitaminosis, and kwashiorkor. Proper medical supervision, nutritional counseling from a dietitian and supplementation should be done. Bathing should be limited to maximum 10 minutes. They should avoid too hot water, showers, or bubble baths. We should use mild soaps with a pH lower than 5.5 or use soapless cleansers. In children with recurrent, so we have seen they are predisposed to a lot of staph and streptococcal infections. So if they have a recurrent staphylococcal infection, so we advise to dilute sodium hypochlorite baths. So approximately half a cup of 5 to 6% bleach in full tub of water can lead to reduce staphylococcal infections. Coming to the most important or the mainstay of treatment for both atopic as well as cirrhosis is moisturizers. So moisturizer basically steroid sparing, restore and maintain skin hydration. They should be applied within 3 to 5 minutes of bath. Twice daily application should be preferred. The thicker, the greasier the emollient, the better and effective it is. So I would say ointment is better than a cream, than a lotion, but like in conditions like Delhi, which is there is too much of hot weather as compared to cold weather. So we can we can tell the parents that maybe in summers they can prefer a lotion, whereas in winters they can prefer an ointment or a cream. Because in these conditions, they can be ointments can be little greasy and can lead to folliculitis and sweat retention. So as we all know, ointments contain high concentration of lipids and are generally more effective than creams and lotions. Patients should use a dye-free, fragrance-free moisturizer, and it, like I said, it has to be applied twice per day subsequent to any topical pharmacological therapy. Now, coming to the another most important mainstay of treatment is the topical corticosteroids. In children or in adolescents, we basically use medium to low potency steroids for the treatment of atopic dermatitis. So that is from class 4 downwards. So that is 4, 5, 6, 7 is what we normally use. So we normally avoid use of very potent steroids, moderate potency steroids to only use for short term, that is 10 to 14 days. Do not use on face and genital area, maybe a class 7 on face and genital, and diaper area acts as exclusive. So hence absorption is more, the side effects are more. Now coming to this important entity, which is one fingertip unit. So it is the amount of topical corticosteroids expressed from the tube with a 5 millimeter diameter nozzle applied from the distal skin crease to tip of palmar aspect of the index finger. So this is the amount which is one fingertip unit. So that's around 0.5 gram approximately, and that should cover 2 palm areas of an average adult. So the affected skin area on a child. So if we are using one fingertip unit, so that should cover this much amount of affected body surface area. So this I normally tell I usually or specifically give a very detailed explanation to the parent, because they don't know how to use and they get scared, or they don't want to use a steroid, or sometimes they overuse it to just get better sooner. So it's very important for all of us to tell how to use a steroid cream. There are others, so topical corticosteroids, as we all know, there are side effects. So we have to tell the parents, we have to assure the parents that if they use it properly, these side effects will not be there. So like local cutaneous is atrophy, striae, hypopigmentation, telangiectasias, acne. Systemic could be hypothalamic pituitary adrenal axis suppression. Another entity which was found in 2001 was calcineurin inhibitors. So they are basically tacrolimus and pimecrolimus. They are non-steroidal anti-inflammatory. It's an alternative treatment in AD for above 2 years of age. They are non-atrophogenic and can be used on face, neck, groin. So basically, this is a maintenance cream for me. So what I tell my patients is they can start with the topical corticosteroid, use it for 10 days, twice a day, then reduce it to once a day, and we introduce the calcineurin inhibitor, normally tacrolimus or pimecrolimus, at night, and then later the steroids are stopped and we continue with the tacrolimus, and then we can go in for a weekend therapy. So the weekend therapy is what we tell the parents to do it. So there are areas which get affected every time there is a change in season or there is a flare up. So those areas to be applied the cream every weekend, so the flare up is less and the child is much more under control. So there was a black box warning. So the American Academy of Dermatology and other associations had found no evidence for the black box warning. So it's safe to use calcineurin emitters for a long time. Antihistaminics. So we have seen that sedating antihistaminics like hydroxine or diphenhydramine are helpful in improving sleep. So we have seen that basically it's important to have a good sleep for the child, because that also leads to increase in the histamine production, and which leads to itching and can aggravate the disease. In some adolescents, sometimes a tricyclic antidepressant can also be used with anxiolytic effects reserved for severe atopic. As we said that bacterial infections, especially staph and strep, are very common. So mupirocin and fusidic acid is what we normally use. Mupirocin resistant strain, rabatamelin is a new drug in the block which we can use for mupirocin resistant strain. For staph carrier, intranasal mupirocin twice a day for 5 days a month for 3 to 18 months can be used to reduce and eliminate the staph carrier in the patient. Molluscum contagiosum is more at sites of active dermatitis, and also there can be eczema herpeticum, so which can be treated like we can remove the molluscums in all the in the children. Now coming to the systemic therapy. So if there is more than 10% body surface area involvement in atopic child, then we have to go for a systemic therapy. Oral prednisolone is the only FDA approved drug since 2001 which can be used for atopic dermatitis in the dose of 1 to 2 milligram per kg body weight. There are other immunosuppressants like cyclosporine, azathioprine, mycophenolate mofetil, and methotrexate, which have been tried. These are the off-label indications for atopic. But the disadvantages is it's late onset of action, except oral prednisolone and cyclosporine. In a child, we have to do too much of blood work. We have to get the normal CBC, LFT, KFT. So that's not a very feasible option in children. And especially since 2020, there is a caution in the current scenario for COVID. So I haven't prescribed any immunosuppressants since last 1 year, especially to my atopics, because we don't know how the child will take in the current scenario of COVID. But there are good news. So there are new FDA approved drugs which have been in 2017, they have been launched, which is the dupilumab, which is an IL-4 and IL-13 inhibitors. It's a fully monoclonal antibody. Subcutaneous injection is given, and it is approved for more than 6 years of age. The advantages, it's an early onset of action, decrease the itch within 2 days in adults and 5 days in children. Then there is Breeze 81 and Breeze 82 trials, which is going on, especially the JAK and the JAK2 inhibitors, baricitinib and abrocitinib, which we have seen that improvement in sleep, itch and skin improvement, and they are much safer. Crisaborole is a topical non-steroidal phosphodiesterase 4 inhibitors, which can be used to mild to moderate AD. Still not available in India, but we are hoping soon. Recently, a pharma company said that they are coming up with JAK inhibitors. So let's hope there are new drugs which we can use for atopic. Thank you.
Thank you, ma'am. It was a great talk. Dr. Alok and Dr. Piyush can comment.
Dr. Tanvi,
yes, sir.
Congratulations on a very informative and very lucid talk, and with a special emphasis on the basics and the newer drugs which are coming for the atopic dermatitis. I would like to add, as you have already emphasized, as it is a chronic disease, patient education is a must. Because the most of the time patient comes to us and he expects that some relief will be there in 3 to 4 weeks or 6 weeks. So we have to again and again emphasize and educate the patient. It's a chronic disease and it will take a time. And for poor patients, I feel one of the homemade best emollient is coconut oil. That can be used, but the only problem with coconut oil is the effect is very short lasting, less than 1 hour. So it has to be used repeatedly. Thank you.
Yes, sir. Yes, sir. I have a lot of patients probably who come, so there is doctor shopping because they think the disease will get better. So they keep going to different physicians and say they're not getting better. So we have to teach them, see, this is a disease which will take a while to go. So stop going, we have to stick to somebody because it is a disease which will be there for maybe for a few years before it gets better.
Dr. Tanvi, Dr. Pankaj wants to know, is there any soap with pH less than 5.5?
I think somebody had answered it, Sebamed 5.5.
Already lots and lots of emphasis on less than pH 5.5. I don't.
Sir, everybody is coming with less than pH 5.5 now.
Alkalinity is like they're more focusing on alkalinity, alkaline water and alkaline soaps.
Yes.
New trend.
Yes, I think we are getting quite late and much behind schedule. So yeah, I think that has very nicely covered everything what comes to mind about atopic dermatitis, and it's a nice, refreshing knowledge about the topic. And hand over to Naresh for next proceedings.
Thank you, sir.
One question I want to ask, Dr. Bhandari, if I can interrupt you for a minute.
Sure, sir.
What is the absolute indication कि यहाँ पे हमें tacrolimus देना है? I have seen dermatologists saying कि अब you use a moderate steroid, then they say कि इसको tacrolimus लगा दो, and how long we can use the pediatric preparation? When do you think I should use tacrolimus?
The tacrolimus, if there is an acute flare-up of the disease, that will not be taken care by the tacrolimus. So for that, we start with a steroid, a topical steroid. After 10 to 14 days, depending how the child is doing, then we switch to tacrolimus because that's safer. There is less side effects as compared to the steroids, because we have to tell the patient that tacrolimus is a safer option which we can use for months. There is no harm in using tacrolimus. Steroid, because once we say that you can use it, so they keep using steroids because it's a Ramban, and then they come up with all the side effects. So what my take is, after 14 to 20 days, I tell the patients to switch to a tacrolimus. In between flare-up, if it's there, then use a steroid. Otherwise, stick to a tacrolimus for months. There is no harm in using a tacrolimus for months.
So till the remission takes place, you can continue tacrolimus.
Yes,
okay.
Thank you, Dr. Tanvi. So with this, we'll proceed to the next talk, last talk of the day. So the last talk is on recent updates in immunization schedule. The speaker is Dr. J.S. Basim. He's the director and HOD pediatrics in BLK Super Specialty Center for Child Health, and he was a past president of IIP Delhi. And chairing the session will be Dr. Dr. Lalit Mendirata. He's a consultant pediatrician and neonatologist in Child Clinic Janakpuri. He's the president of IIP Delhi currently, and he's also the trainer and faculty in IIP BLS and ALS courses. And he's also the IIP award winner for the welfare of underprivileged children. He was also the ex-president of IIP West Delhi and vice president of IIP Delhi. And he was also the president-elect IIP Delhi 2020. And along with him, we have Dr. R.K. Alwadi. He is a senior consultant in pediatrics, BLK Specialty Hospital. He's also the IIP certified trainer in pediatric infectious diseases, rational antibiotic use, and RTA GEM modules. And we have Dr. Amit Tyagi. He's also a consultant pediatrician in BLK Hospital. And Dr. Vipul Baveja is also a consultant pediatrician in BLK Hospital. So over to Dr. Basim. Thank you.
Thank you, Dr. Naresh. Screen aa gaya?
Yes, sir.
Okay, ji. So, a very warm welcome to my panelists. I hope we have all the panelists online, and this is something which we usually keep for the last because we don't know for how long this discussion goes. When we were initially trying to do a rough run up, instead of 50 minutes, we ended up doing for 3 hours. Vaccination, as you know, is in the current scenario, most of what we as practitioners are doing. Given the COVID restrictions in travel and the closure of the schools for the safety of the children, we have seen a dramatic drop in the pediatric infectious diseases. And this drop has been across Delhi. I have observed it in my hospital where the admissions have really gone down. All the cases which we were getting initially throughout the year, and we used to think that only the winters are the lean season. Now, from March to this February, it is almost a year. And I'm sure you have all experienced a dramatic drop in the pediatric sick patients. We all know that vaccination is the most cost-effective method, but this has made us realize that besides vaccination, it is the overcrowding and the cross-infection in our country and the poor hygienic conditions which has led to such a high incidence of the infective disorders. I am sure you must have been exhausted after the 4 hours or so which you have already been through. But I'm sure what we are going to discuss is not the run-of-the-mill vaccine updates which you have every day. Sometime about which are usually industry sponsored, and sometime about pneumococcal, sometime about rotavirus, sometime about your typhoid vaccines or your acellular vaccines. What we want to discuss is something which is of practical utility, which our Indian Academy of Pediatrics is recommending for the use by all the members of Indian Academy of Pediatrics. So I will pose a few questions to my esteemed panel, which, as you've already known, is Dr. Lalit Mendirata, Dr. Raman Alwadi, Dr. Amit Tyagi, and Dr. Vipul Baveja. All of them are very senior and experienced and are using vaccination every day in their practice for more than, say, 2 decades now. Just to briefly introduce the topic, we know that we as a country accommodate the maximum number of children in the world, but unfortunately, we also contribute to a large percentage of almost 20% of the world child deaths under 5. Approximately 1.73 million children die annually before completing their 5th birthday. And of these, vaccine preventable disorders are responsible for almost 5 lakhs deaths annually. As we have seen during the COVID lockdown and these children staying at home, with the avoidance of intermixing, avoidance of overcrowding, slum improvement in the nutrition and the standards of living, the infectious disorders have really come down. But we do know once the things get back to normal, immunization is one of the most cost-effective public health interventions. Immunization is easy, secure, and an efficient process of protecting individuals. And India is a leading producer and exporter of vaccines. Of late, we have gained a lot of recognition for exporting the COVID vaccine to the world over, and even developed countries have requested us to send them the vaccines. But we also remain, unfortunately, 1/3 of our own population of children is unimmunized. So in 2007, when we had about till 2007, we had 6 diseases which we were universally vaccinating as a part of our national immunization program. The 7th one, hepatitis B, was added. But in spite of all the efforts, the immunization rates were not picking up, and Mission Indradhanush was added in 2014 with the objective of improving this percentage from the prevalent 65% in 2013 with the aim of going up to 90% over the next 5 years, that is still about 2020, so that the incidence of these infective disorders came down. Unfortunately, 2020 brought COVID, and with that, instead of improving whatever success we had achieved, it deteriorated, and the vaccination rates have drastically reduced. Even in the private sector, where we send reminders, we call the patients, I think almost 30 to 40% reduction in the vaccination rates have decreased. And in the government sector, where some of you colleagues are working or your spouses are working, my wife works in a maternity and child health center, and she has seen a drop of almost 50% in the vaccination rates. So almost touching 90% in 2019, we are back to worse than the position we were in 2013. Fortunately, we are not getting these diseases because children are at home and secure. But once the scenario opens and things become normalized, I don't know what to call normalized, whether this is the new normal or what will be the new normal, we will definitely see an increase in the infective disorders. Besides those vaccines covered by the national schedule, there are certain vaccines we as pediatricians use in our private practice. We will try and cover some of these given the time: hepatitis A, varicella, Japanese encephalitis, rabies, influenza, meningococcal, and HPV. What we want to talk about is the current vaccines in use, their storage and mode of administration, their schedules, whether it is the same for our country and for Western countries, because a lot of us see patients who are traveling either to the foreign countries or are traveling back from the foreign countries, whether there are any travel requirements, and if more than one particular vaccine is available in a sector, what is the best vaccine in the terms of safety, effectiveness, ease of administration, and cost. Now, I want this to be an informal discussion, so that since it is an online presentation, we cannot have everyone trying to speak. So for an informal discussion, I have made this distribution that these particular panelists will talk about this. Of course, everyone is available, is an expert, and can chip in with their suggestions. But while the talk is on, if there are any questions from the audience in the chat box, I would request those who have been allotted these particular vaccines to kindly try and answer the questions while we are going along. So this is what we plan to discuss, the practical aspects, what we do every day, what we need to do, and how to take it forward. The most important is in your clinics, how you keep the vaccines. You are all experienced pediatricians who are using these vaccines. You all know that the optimal temperature in your clinics is 2 to 8 degrees, which is what the refrigerator maintains. We all know that we are worried about the light going off, which is less frequent now that it has been privatized. Initially, we used to be very worried about the temperature rising. Now you have to worry about temperature going too cold and causing the freezing. So please distribute the vaccines in a way that the DPT containing vaccines are as far away from the freezer as possible. No vaccines in the door of the fridge, all within the refrigerator. The freeze dries vaccines closer to the freezer if you have such apartments. And for unfortunate shutdowns, keep extra ice packs or water-filled bottles in your freezers, in your fridge. As far as the administration is concerned, as far as the administration is concerned, you all know what to do. Just to go through it again, among the intradermal vaccines, we have just BCG, the IPV in the government sector where they give a fractional dose, and influenza can be given intradermal. Your MMR, measles, MR, and varicella are given subcutaneous. Rest all can be given intramuscular. You all know that you should avoid the gluteal region. Deltoid and the anterior lateral thigh are the best place to vaccinate. So now, this was basically to summarize so that I do not waste time about asking about these particular questions to each of the panelists. So we will start with what we usually start in our practice or in our institutions. The first vaccine which is supposed to be given at birth is BCG, which is usually given at birth or at the first visit if it is not an institutional delivery. And we have Dr. R.K. Alwadi who will enlighten us with the BCG vaccine which is available at present, what it protects against, and what is the schedule to be followed. Dr. Alwadi, please.
Thank you, sir. So BCG protects against tuberculosis, and BCG is ideally supposed to be given at birth. That is the ideal time. And if for any reason we have not been able to give BCG at birth, then at the first contact, preferably within 6 weeks, at the first contact, we should give BCG. It's a live attenuated bacterial vaccine given intradermally. And the main role of giving BCG is protecting against the severe form of disease, which in our country is common. And protection against severe disease goes up to as high as 80%. Thank you, sir.
So the protection which we know, Dr. Alwadi, is mainly against your severe and miliary tuberculosis or CNS tuberculosis. We have BCG as a routine vaccination, and yet tuberculosis doesn't seem to be going anywhere. These few days we heard a lot of about BCG helping in COVID cases also. Though we did not get any definite answer, but incidence of COVID definitely is much better in countries like ours where BCG is used as a routine. The exact correlation definitely has not been fully investigated, but there was some talk initially about giving BCG to those who want some protection till a COVID specific vaccine is not available.
So that is all the more reason to give BCG at birth.
Yeah.
So that we do take care of this, and if there is any possible benefit in COVID, so that is always useful.
So we don't know about so many reasons why India has had a excellent track record, I would say, given our population and overcrowding as far as COVID is concerned. This could be one of the reasons besides the so many others which are being suggested. So what is the normal precaution which you would take, and what is the advice which Dr. Alvadi, when you give to someone whom you administer the BCG vaccine, what to look out for, and what is the commonest problem with which they come to you after a BCG vaccine?
So BCG is the only vaccine that is going to give a visible reaction. There is going to be a normal reaction expected of a papule formation around 6 weeks, leading on to a fluctuant kind of swelling that ultimately ulcerates, healing with a scar between 2 to 5 months of age. So this is a normal BCG reaction, and does tell us that the BCG has been taken up. It's a visible sign. However, only 90% of recipients would show up this scar, and up to 10% of patients may not show any reaction. However, and that is qualified as if there is no reaction up to 3 months after giving BCG. If there is no reaction, it is assumed that the child has not shown a reaction, but in no way is that the child is not protected. So no scar does not mean that we have to repeat it. But yes, we will look for a normal reaction, which will heal in 2 to 5 months.
So, Dr. Alvadi, you would agree that a lot of us, as pediatricians, we see preterm babies also. So especially those who are attached to centers where you have preterm deliveries or who are in tertiary care hospitals. There, the BCG is not given at birth. Usually they give BCG just before discharge. That might be, say, 2 weeks or 4 weeks or 6 weeks, or by the time the baby is fit enough for discharge. That is the time when they administer BCG. And you must have seen so many patients parents coming back with enlarged lymph nodes in the axilla after BCG administration. So what is the recommendation? Because some of the Western countries, they advise treatment for these enlarged lymph nodes. So what is our, say, viewpoint or the practice which we follow in India for a child who develops axillary lymphadenopathy after BCG?
Right. So BCG adenitis is a well-known entity and has an incidence of about 6 in 1,000 cases. So out of 1,000 children administered BCG vaccine, up to 6 can have a BCG associated lymph node, especially in the left axilla. And if it's a firm swelling, wait and watch is the usual policy. And the idea is that we keep a close watch on that. And if it gets fluctuant and then going into evacuation or bursting, then careful aspiration and even surgical drainage may be indicated in occasional case. As per current guidelines, no anti-tubercular therapy is indicated in an immunocompetent child who develops BCG adenitis, and it is supposed to heal on its own, maybe with some help in the form of aspiration or drainage, but it heals by itself. No ATT is indicated.
So besides, I think, congenital immune deficiencies, is there any contraindication for BCG, Dr. Raman?
So immunocompromised state is the main, and of course, even in HIV, they say if child is asymptomatic, you give BCG, and that is the only contraindication because previous reaction to dose does not apply for BCG. It is given at birth itself.
We know that a lot of Western countries, they require a person traveling from a place like India with endemic tuberculosis with a fairly high incidence of tuberculosis. Is there any travel requirement for people traveling out of India for BCG or Mantoux, or for people who want to come to India? Should they take BCG after they have attained a particular age? Suppose you have a 6-7-year-old child, should they be given BCG or anything like that?
So as far as travel out of India is concerned, we simply follow the guidelines as per the prescribed by the specific country. Like they will usually need a Montoux, and if Montoux is negative and X-ray is normal, they accept that the child does not suffer from tuberculosis and they take him. For the person who is traveling to India, and if he has to stay for a reasonable length of time, it is prudent to get the BCG vaccine as soon as they arrive in India, and if they get it there, it is perfectly fine.
But is there any age limit usually beyond
5 years? 5 years is the usual age that we can state of give BCG.
Thank you, Dr. Raman. I think that sums up about BCG. We have only one particular BCG vaccine, which is very safe. Though it doesn't give protection against all forms of tuberculosis, it does protect against severe forms. And the only complication which the parents are really worried about just needs counseling and rarely anti-dependent aspiration with a white bore needle.
I have a point here to make, sir.
Yes, Dr. Vipul.
5 years is relevant in case of Indian children who are in India and are exposed to the prevalence of tuberculosis here. But if a say 7-year-old is coming to the India for the first time and the parents ask me, should we get a BCG, what should I decide? Now he has never been exposed in our setup. He was born and brought up in, maybe Dr. Alwadi can guide us.
So I would suggest that it's an individualized situation, and a simple process beyond 5 years is to, I would believe, is to get a Mantux done. If Mantux is negative, we can go ahead with BCG at any age in childhood.
If he's likely to stay regularly in India for a long time, if he's visiting, then
Yes.
I think we need to give a BCG vaccine. So the next vaccine, which almost all the babies or which should be given, is polio vaccine. So Dr. Vipul, while you are with us, so why don't you tell us about what is the current oral polio vaccine which is being administered and what are the other polio vaccines, and tell us a bit about the schedule which is followed as far as the national immunization schedule is concerned, and about how it is different from the IAP recommendations. Dr. Vipul, please.
So currently we are using all over India the bivalent oral polio vaccine, which is given at birth, which has type 1 and 3. And after the initial vaccination, the UIP, that is the Government of India, they do little differently from what our Indian Academy of Pediatrics advocates. The government schedule is following OPV at 6, 10, and 14 weeks, along with a fractional IPV dose at 6 and 14 weeks. While if you are able to give a full dose IPV at every visit with DPT, OPV is not recommended. So these are the two parallel schedules going on using the oral polio vaccine, as far as oral polio vaccine is concerned, the bivalent oral polio vaccine.
So, you know, Dr. Vipul, that in a country like ours, it is the government sector which vaccinates almost 70 to 80%, depending upon the city or the town you are living in. And most of the children are following the government vaccination schedule or are being treated at the government, vaccinated at the government centers. So those who have already been vaccinated at the government centers or who now come to your city and they want enhanced protection, or parents, once they come to Delhi, they learn about the vaccination schedules in the private sector, which are different from those which are being followed in the government sector. So what do you advise them? Do you advise them any extra dose of injectable polio? Till recently, injectable polio, as you know, since the government started vaccinating, it had disappeared from the market and was not available as a standalone vaccine for us. Now it is available. And as you have rightly said, the Indian Academy of Pediatrics suggests that the injectable polio 3 doses is the best way to go forward and provides both long-standing and complete protection. The advantage, of course, of giving OPV at birth is to give the mucosal immunity till the protection for seroprotection is available. So do you suggest that we should give them any extra dose of injectable polio now that you have injectable polio available?
Definitely, sir. Now, even it is more of a case to offer them injectable polio, because initially it was only a combination vaccine and cost was a constraint. Now we can offer it at a economical, which is comfortable to the pockets of the patient in private sector, and we should offer them injectable polio depending on what age they are presenting to us. And it is desirable, even if they are at the third visit, at least one dose of injectable polio at 14 weeks, if given in combination to oral polio, will be given. But yes, if the child is already such a child who is coming late, we expect that he must have received one dose of fractional IPV also. So there is a lot of overlap, because the government sector is giving 2 doses and we are giving 1 dose. But whatever opportunity, if a child is coming, we should offer them IPV.
Very rightly said, Dr. Vipul.
Rather, now the latest recommendations by Indian Academy also says that, so much so that you should promote IPV, that you should refer them to a government center if they are not affording for a combination vaccine. This was a statement just few weeks before, when IPV separately was not available. To the extent it was that you refer them so that at least they get fractional IPV. So when we are talking about the other way around, that they have not taken fractional IPV and coming to us, there is no reason that we should not encourage them to take injectable polio vaccine.
Very rightly said, Dr. Vipul. I would even go a step further, and the government doesn't give the IPV at 1.5 years, which the Indian Academy of Pediatric does recommend that at the booster at 16 to 18 months, you give injectable polio.
Yes.
So those who can afford and those who have, irrespective of their initial immunization status, they should receive the injectable polio vaccine at the first booster. And now there is talk in the Indian Academy of Pediatrics of giving a second preschool booster of injectable polio if possible.
Right.
And that is the latest guidelines. Dr. Vipul, you must be getting a lot of queries, and all of you. What do you advise when the parents whose children you have vaccinated, they ask you about the pulse polio or the, say, national immunization polio, oral polio administration? Because most of them, they turn away the vaccinators or they are not willing to take the vaccine. So as a nation or as an individual, what should be the practice which should be followed?
Both as a nation also and as individual, what I have been following, we proactively tell them to go for pulse polio drops. At the very first visit, I try to counsel them that is pulse polio drops, and what I am giving you is polio vaccination. So they get into their minds this is separate from vaccination, and I encourage them. We should encourage them to participate in the drive. And as such, when this is for our own, we don't counsel them on this, that we know when we are giving them injectable polio, so they are even spared from that minutest risk of 1 in 2 million of vaccine-derived polio when they are injectable polio. But that should not be the part of counseling that unnecessarily raises the anxieties in the minds of people. We simply tell them that I tell them that it is a nation's drive, and it is, as a dutiful citizen, you should provide your contribution in the fight against polio and try to get your child to the polio center. And if by chance you forget and they visit, do not discourage it. Get it.
Very right, Dr. Vipul. I think it is our responsibility to not only keep our own households clean, but also our neighborhood clean. So unless that is there, you will not have a Swachh Bharat. And I think it is just the lack of the political will that we have not included injectable polio vaccine at a full scale, the complete dosage. We have observed when COVID was, COVID entered this nation, how the whole nation went into a lockdown at the risk of 26% drop in the GDP. When adults are affected, the policies are entirely different. When it is the children of our nation, the future of our nation, I don't know why we cannot spare the money to vaccinate all the children with the best possible way, that is the injectable polio. So if anyone wants to add anything, or we go on to the related combination vaccine, which contains DPT, IPV, hepatitis B, and your Hib. So Dr. Raman, would you like to tell us about the DPT vaccination combinations which are available, and how the national schedule is different from what is the recommendation by the IAP, and what is the best possible schedule which you feel we should practice?
So it is quite clear that we need to give the combination vaccines because we want to cover against so many diseases with minimum pricks, and combination vaccines are freely available. Pentavac or DPT, Hib, hepatitis B is available in the government schedule. And the standard schedule being followed is 6, 10, 14 weeks, followed by a booster at 1.5 years, where the recommendation is to give DPT and Hib. And as far as the efficacy is concerned, the whole cell vaccine is as effective, or rather the protection given by whole cell vaccine, which is available in the government setup, which covers 91% of the children in India, is good. Protection lasts for 6 to 12 years, and combination vaccine is strongly encouraged. The hepatitis B immunogenicity is also good in these combination vaccines, and the combination vaccine schedule is supposed to be protective. In private setup, we do have the availability of acellular pertussis vaccine, which again is a combination, which covers IPV as well. So we have the hexavalent vaccine. Now, as far as the private thing is concerned, we have the option of giving the whole cell or the acellular. The IAP guidelines still recommend that the whole cell vaccine is probably the effect lasts for a longer duration as compared to the acellular pertussis, which requires frequent boosters. So in the primary series, preferably whole cell vaccine. The acellular vaccine is also acceptable if the parents are not willing to accept the increased reactogenicity or increased reactogenicity. We can use the acellular one as well.
Very right, Dr. Raman. The advantage of giving the combination vaccines is lesser pricks and better compliance, which is what we need to achieve to attain enough immunity to reduce or eliminate these diseases. And about hepatitis B, I would like you to tell us something more, because this is one vaccine which is given at birth also.
Right. So hepatitis,
yeah.
Hepatitis B should be given at birth, ideally as soon as possible. And especially if the mother is HBsAg positive, then positively we have to give hepatitis B vaccine, the monovalent vaccine, along with hepatitis B immunoglobulin within 12 hours of birth. Now here, the schedule is that it has to be given within 12 hours, and then it is to be followed by the routine combination vaccine at 6, 10, and 14 weeks. The additional dose, so 4 doses are recommended if as possible, and this is supposed to have a protection up to 85 to 95%. Now, in case hepatitis B immunoglobulin is not available at birth, it can be given up to 7 days, even after giving the monovalent vaccine at birth. And there is also the possibility that if vaccine is not, the immunoglobulin is not available or not affordable for some reason, we are not able to give, then a schedule is followed of 0, 1, 2, and 9 to 12 months. So this schedule is recommended, though this schedule will provide protection only up to 75%, whereas with immunoglobulin, this increases to 85 to 95%. So birth dose is very important, and it should be given.
So birth dose helps in the prevention of the vertical transmission?
Absolutely. Perinatal transmission reduces by 15 to 30% simply by the birth dose.
And if you can give immunoglobulin in a mother who's positive, that should be given.
That is the recommended schedule. In case we are not able to follow it, then 0, 1, 2, and 12. This is the schedule. And if the mother is HBsAg positive, whenever we complete the schedule 1 month after it, we are supposed to check the anti-HBs level and the carrier status. So if the anti-HBs level is more than 10 milli international units per ml, it is supposed to be protective. However, if it is not there and the HBsAg is also negative, which means child has not responded, but the child is not carrier as well, then we are supposed to revaccinate the child with a 3-dose schedule, and significant number will, almost everyone would respond.
Dr. Raman, can you tell us about certain conditions where the increased dose or an enhanced rapid immunization is required, or a higher dose is required, especially for hepatitis B?
So again, there are 3 important conditions. One is the immunocompromised state, one is the elderly, and the third is the chronic renal failure. So in these 3 conditions, double dose is recommended, and the schedule again is 0, 1, 2, and 12. And then we have to check for the protective titers, because the immunogenicity is supposed to be less. So we have to first give double dose 0, 1, 2, and 12, and then we have to check titers 1 month post-vaccination after the last dose.
But routinely, we do not give any boosters. They are not recommended anymore.
Yes, routinely boosters are not recommended. They have followed up to 22 years, and the protective titers are supposed to retain, even with a standard 3-dose schedule, which is 0, 1, and 6. However, the schedule of 0, 6, 14 or 6, 10, 14 or 0, 6, 10, 14, all these schedules are acceptable and tend to provide long-term protection.
So we all know that the hepatitis B vaccine available, whatever be the brand, is all recombinant vaccine, which is very safe to administer, hardly had any adverse effects, and there is no contraindication even in the immunocompromised, because it is not a live vaccine, doesn't cause any.
So we just need to look at the immunogenicity, because in immunocompromised, the uptake might not be that. So we may double the dose.
Higher dose.
So severe reaction to a previous dose, that remains the theoretical contraindication.
But I have not experienced anyone as of now. Maybe if anyone else has, they can add to the discussion. While we are at this combination vaccine, Dr. Raman, would you like to tell us about the DPT vaccination, second boosters and the third booster, which are now suggested by the IAP and internationally, which are being followed, to cover for the lack of prolonged immunity after a acellular pertussis vaccine?
So standardly, it has been seen previously, the national schedule had DT vaccine only at 4.5 to 5 years, but it was seen that the pertussis is the one for which the immunity wanes faster, and that duration can be 6 to 12 years for a whole cell vaccine, and that can be 4 to 12 years for an acellular vaccine. So once we have given the first booster at 18 months of age, whole cell or acellular, we are supposed to follow it up with a booster around 5 years of age. The range is 4 to 6. And the preferred vaccine is either the whole cell pertussis vaccine or the acellular vaccine. DPAT can be given, or DTWP, the both can be given at between 4 to 6 years. Beyond 7 years of age, we need the next vax booster, which comes around 10 years of age. And standardly, that should also have pertussis regardless of the previous vaccines given. And Tdap is the vaccine where you give the normal dose of tetanus, the low dose of diphtheria, and acellular pertussis. So beyond 7 years, whole cell vaccine is not recommended because of reactogenicity. And low dose diphtheria and acellular pertussis. Tdap vaccine is recommended at 10 years. A standard single dose Tdap is recommended. Thereafter, any further boosters at an interval of 5 or 10 years, depending on the schedule, has to be TDVAC. So if there is an injury, we are supposed to follow it up within 5 years. Otherwise, standard boosters are 10 years.
So in the private sector, those who have received the acellular vaccine, after the second booster, they need a rebooster in their beyond 10 years or early adolescence. Whereas in the government sector, small t small d, and dual antigen is given at 10 years and beyond, that should be followed, whether they are able to afford the acellular pertussis along with that.
The ideal vaccine at 10 years remains Tdap, even if we have given the whole previous series as whole cell. Because even with the whole cell, the pertussis, the effectiveness does go down beyond 6 to 12 years. So if available and if affording, Tdap is the recommended vaccine by IAP at 10 years, even if we had followed the whole cell series previously.
So, Dr. Raman, during the last 1 year, I have seen a lot of my patients are not able to come for the vaccination. Same has happened in the government sectors. So, how do you catch up, or for these children, what is the schedule you recommend for those who have missed out in the last 1 year regarding these particular vaccines?
They have completely missed up their schedule. The standard schedule is 0, 1, and 6. For DPT, the schedule is 0, 1, and 6. And if that booster is given beyond the 4 years, then the second booster is to be skipped. But 0, 1, and 6 is the standard catch-up schedule. Right. And if it is beyond 7 years, then of course the diphtheria component goes down. The first will become Tdap and subsequent 2 will be TTVAC.
But in the government sector, up to 5 years, you can give DPT, the regular triple.
Absolutely, DPT 0, 1, and 6.
Yeah.
0, 1, and 6. And if that last dose is beyond 4 years of age, then the second booster is not required.
So another vaccine which we give along with this regular schedule is the rotavirus vaccine. And I would ask Dr. Lalit.
Hello.
Dr. Lalit is our current IAP president and has been recently involved in a lot of, vaccination seminars. And I would like him to enlighten us about the various rotavirus vaccines available and which is the schedule which is recommended by the IAP and which is being followed by some of the states in the government sector, and which is the vaccine which is being used there. So Dr. Lalit, please enlighten.
Thank you, Dr. Bhasin, for first of all inviting all our Delhi IAP team and BLK Hospital for having a wonderful CME with IAP Delhi. I really thanks for everything. Since morning, BLK is totally involved and committed with IAP Delhi and all its members. Thank you very much, sir. As far as this panel discussion goes, as far as rotavirus is concerned, sir, in rotavirus, we have the common vaccine which we have is one is the monovalent Rotarix. That contains the monovalent serotype Z1PV8. Second is the Rotatec, it is the pentavalent rotavirus vaccine with the live resortment and bovine rotavirus strains G1, G2, G3, and P8. And the third is the Indian one, the Rotavac and Rotasure G9P11 strain, the 116E strain, the Indian-made rotavirus. And then we have a Rotasil, which is containing pentavalent G1, G2, G3, G4, and G9. So these are the four. That is also bovine and human resortment combination heat stable vaccine. So these are the four vaccine schedule vaccine which are available with us. As far as Rotavac is concerned, nowadays they have a 5D preparation in which it is in the form of a pre-filled syringe. It is given in the form of drops. Basically, the drops are there, 5 drops, and the dose is given. As far as schedule is concerned, the schedule recommended is 6 weeks, 10 weeks, and 14 weeks. The first dose should not be later than 15 weeks, and the last dose should be completed by 32 weeks. The Rotarix has 2 doses only. Again, the same. The first should not be delayed by 15 weeks, and the second dose should not be maximally completed by 32 weeks. It has no contraindication with breastfeeding and oral polio vaccine, and these are the various vaccines and the schedule which we follow. The monovalent 2 doses, and rest are given 3 doses.
Dr. Lalit, again, I would like to address the same question of delay or missing out during this COVID pandemic because of the travel restrictions or because of, say, fear of COVID. For person, how late? Because I think as far as the government vaccine is concerned, they have allowed some liberty as far as the age till which you can give the rotavirus vaccine.
As far as government goes, they have said that below 1 year you can give at least 1 dose of rotavirus. It can be given. You can give 1 dose. It can be given.
we can need not restrict ourselves to say 8 months. We can go up to 1 year.
Yes.
Because the advantage which we will be getting in covering rotavirus vaccination is going to be much more than the possible risk
of interception.
Adverse effect. So what is the adverse effect which we normally are so scared about and which we observe by rotavirus vaccine?
The commonest rotavirus side effects are mild. Vomiting is most of the time, which takes place. Some patients say complaint of fever only. These are the side effects. As far as interception goes, the risk is very, very low. That is the only risk of interception. That is very, very low. This is a major.
The Rotashield vaccine, which first came and which was discontinued because of the interception, came too early in the market and had to be discontinued. Was it launched sometime around this phase, that would have probably also been approved for use, because the risk of interception, I think, is too less for a country like ours, where diarrhea attributes to a significant number of under 5 deaths, that we should give rotavirus vaccine.
And as far as any contraindication is concerned, this is an absolutely safe vaccine. The only thing is the severe combined immune deficiency state. That is a very rare condition in which it is contraindicated. It can be given into HIV patient, or there is some there is an allergic to any component, which is very unlikely to oral rotavirus dose, and past history of interception. These are the contraindications.
One practical observation, Dr. Lalit, lot of babies, when given rotavirus, they spit it out. So is there any practical suggestion would you like to give to your parents regarding, say, breastfeeding or re-administration or feeding before or after the administration? How do you overcome this problem?
I usually don't face much of these issues, because as far as literature goes, there is no contraindication association with the whether breastfeeding can be given before or after, or with polio drops. You can give any time. If the child vomits, then there is nothing to worry about. You need not repeat the dose. The amount of volume, even 1 drop to 2 drops, which has gone inside, is sufficient enough. So don't worry about that. Just reassure the patient whatever the child has received is sufficient enough. And there are 3 doses to be given. Just reassure the patient.
So but we do observe that some of the babies, they do spit out, and the parents are really concerned that the vaccine which you have administered has gone waste. So any practical tips which you suggest to the parents regarding the feeding? Or Dr. Vipul, you had a very good suggestion about this. Dr. Vipul, you are mute.
Sir, this is just to reassure the patient, basically, sir. There is nothing.
I was replying to the chat in the between, so I missed on your exact point, sir. I'm so sorry.
Yeah, Doctor. Okay, I'll mention it on your behalf. A lot of mothers, if they feed the baby and then the baby cries, they tend to throw up more. Yes. So Dr. Vipul was suggesting that he asked the parents not to feed immediately before vaccination, give the rotavirus, and after that they give breastfeeding, less chances of vomiting he has observed. This is an observation which maybe more of us can try and observe in our clinics, because a lot of babies do bring out, some of them really love the sweet taste of rotavirus and lick on it, but some, because it is over sweet, tend to throw it out also. So if we give the rotavirus before the baby is breastfed, and then the mother takes the baby and is waiting in your clinic for about 20 minutes after the vaccination, during which time she can breastfeed. So it is not a contraindication, it would rather help in soothing the baby, and you can observe. So that is something which we have found, one of our consultants has found beneficial. Dr. Lalit, is there any, say, change in the schedule or recommendation as far as the preterm babies are concerned for rotavirus vaccination? Because a lot of pediatricians amongst our group are working with preterm babies, so they would definitely like to know that.
Sir, in preterm infant, it is given according to the chronological age only. It got nothing to do with this. The schedule will remain the same. It is according to the chronological age. You can give the same dose of rotavirus vaccine.
That's right.
Age is not different.
So while we are discussing rotavirus, another vaccine which is usually co-administered, at least in the private sector, and in some of the states, is the pneumococcal conjugate vaccine, which can be co-administered at the same time to save the visits and improve the compliance, or if the patient stays near you and is willing to take extra visits, you can give separately. So Dr. Lalit was involved in a marathon pneumococcal conjugate vaccine symposia recently. So I will stick with him to enlighten us about the various pneumococcal conjugate vaccines which we have in our country. A new one has been added to the armamentarium. What is the vaccination schedule, and what is the yeah, please, Dr. Lalit.
Thank you, sir. The PCV13, we used to have a polysaccharide vaccine with the name of PPSV23, which is still available and which is used for basically high risk, immunocompromised and high risk group of patients. The commonest, the conjugate vaccine, we have three basically. The older one was PCV13. Then came PCV10, and finally, recently, Pneumococcal is the Serum Institute of India launched the vaccine, which now launch of pneumococcal disease. Now, PCV13 is the oldest brand. It contains 13 serotypes: 1, 3, 5, 6A, 6B, 7F, 9B, 14, 18C, 19F, 19A, and 23F. And PCV10 does not contain 6A, 19A, and 3. And Pneumococcal does not contain 3, 4, and 18C, but it has added 6A and 19A. So basically, the Pneumococcal has two serotypes from PCV13, 6A and 19A, which were not there in PCV10. PCV10 people says that this is because they have the cross protection from the other antigens, so 6A and 19A are not required. Now, as far as the schedule goes, the PCV13, PCV10, and Pneumococcal, if we start with the primary immunization, it has 3 doses, both PCV13 and PCV10. Those 3 doses will be given at 6 weeks, 10 weeks, 14 weeks, and then there will be a booster at 12 to 15 months in both the cases. But if the schedule is between, child does not appear between below 6 months, it comes between 7 to 11 months, then PCV13 2 doses, and PCV10 again 2 doses at 4 weeks interval, followed by a second booster in the second year of life in both the cases. But the doses will be 2 and the gap will be 4 weeks. And in 12 to 23 months, PCV13 and PCV10, 2 doses at 8 weeks apart. And of course, there won't be any booster dose. But in 24 to 59 months, PCV13 only 1 dose will be given. And in PCV10, 2 doses will be given 8 weeks apart. Now, this is the schedule of PCV10 and PCV13. Now, as coming on to the Pneumococcal, which is recommended only for 3 doses as by Indian Academy of Pediatrics, 3 doses, 6 weeks, 10 weeks, 14 weeks, and 1 booster dose at 12 to 15 months. So this is the schedule of all the 3 vaccines, the difference of the various serotypes, and the commonest vaccine.
So the previous 2 vaccines, we are well aware, are both good vaccines. Both develop very good immune response, are efficacious. But you know, Dr. Lalit, that some of the say districts of the Bimaru states, 5 states, where the national immunization schedule has incorporated pneumococcal conjugate vaccine 13.
There is the schedule is different in national. There is 3 doses, 6 weeks, 14 weeks, and 9 months.
Yeah. So if
schedule, and only PCV13 has been used in various states, and because they have a multi-dose vial and it is really cost effective. So it's a very good vaccine when it is available in multi-dose vial, and it can be used in the national program.
So we would all aspire to the day when this is part of the national schedule all over our country. But till that time, we have a lot of migrant population coming in and out of Delhi, even on transfers or otherwise. So if a particular patient has taken a vaccine 1 or 2 doses and comes to you, what do you advise to continue the vaccination? Or this question, I think, relates both to pneumococcal as well as rotavirus. If you are not aware of the previous vaccinations, how do you advise the completion of the course, Dr. Lalit?
If you know the previous vaccine which brand was given, you can use in case of rotavirus, and in case of pneumonia, I think if you patient has missed out anything, then the schedule, as I highlighted below, 5 years, that can be used. And above 5 years, the PCV10 has not been recommended. You have to use PCV13 only. Remember that PCV13 is the only vaccine recommended above 5 years. Pneumococcal has just come. It is only recommended below 2 years. And PCV10 is only recommended below 5 years. So any patient coming late, so I will be using PCV13 only.
So while we are on the pneumococcal conjugate vaccine, there are certain conditions because some of our friends work in hospital institutions where they do see patients who are coming either after transplants or nephrectomies or splenectomies or with certain chronic disorders. So would you like to share with us what is the recommendation as far as pneumococcal conjugate vaccine is concerned in these particular patients? And
yes. So these are the various groups. One group is the immunocompetent group in patients with chronic heart disease, lung disease, diabetes mellitus, CSF leaks, cochlear implants. And the second group is asplenia group, which like sickle cell disease and other hemoglobinopathy. And the last is the immunocompromised like HIV, CRF, nephrotic syndrome patient and patient of immunodeficiency and on immunosuppressive drugs. In those patients, we have to make sure the child at least received a dose of PCV conjugate, this conjugate vaccine and followed by the dose of this polysaccharide vaccine every 5 years. The dosage between the difference between the two should be 8 weeks. So if the child comes at say 5 years and has not above 5 years and he's a high risk baby. So I will make sure he receives at least first dose of PCV13 and then after 8 weeks I will start this polysaccharide vaccine of 1 dose and then 5 years later I'll give the booster dose of PPSV23.
So it is better to prime the immune system with a conjugate vaccine initially before we switch on to a broader coverage with a 23 polysaccharide.
Yes, this is the best option. So this is one should always follow this.
So any adverse effects or between the vaccines to choose or contraindications you would like to share with us?
As such, there is no major contraindication. The side effects as far as concerns are basically seen more common with the one brand PCV10. We had fever, redness, pain, and in fact drowsiness has been reported with one of this PCV10, usually one brand. This pneumococcal has just recently come, so time will only tell. The side effects are, of course, maybe anything, but as such, there is no life-threatening side effect which has been reported with pneumococcal vaccine. And PCV13 we have been using over the years as such, apart from mild pain, and there is no major side effects.
Regarding travel abroad, I don't think there are any recommendations as far as pneumococcal vaccine or rotavirus is concerned, because anyone traveling in or out of the country, I have not seen any special request for these particular vaccines.
Yes, sir. Nothing like that.
So now coming to the first vaccine which is available, used during the epidemic of the swine flu for routine vaccination for enhanced protection, but which the Indian Academy of Pediatrics recommends that all babies should receive. So this is over to Dr. Amit Tyagi. If you would like to share with us about what are the current flu vaccines available and what is the recommended schedule. Dr. Amit, please.
Yes, sir. Thank you, sir. Currently, there are 3-4 vaccines available in Indian market of influenza. And that is all are quadrivalent influenza vaccine with which are inactivated vaccines basically. And these inactivated vaccines are also of two types. One is surface antigen inactivated influenza vaccine, which is quadrivalent, and another are split virion inactivated quadrivalent vaccine. Whatever vaccines are available at this time, they are all northern hemisphere strain, and their indication of giving is, as IAP says, that there is it is not practical to give routinely to everyone all these inactivated vaccines. So these vaccines in kids we give from 6 months onward till 5 years of age. Every year we give this inactivated doses of northern hemisphere, which is present right now, and in pregnant women and elderly and medical practitioners and persons who are at high risk. So these are the indications where we give these inactivated influenza vaccine right now.
So what are the dosage recommendations? You give 2 doses to all, or how often do you give them? Is there a difference, or would you like to tell us about the current vaccine, which is supposedly the northern hemisphere or southern hemisphere? What is the difference between these hemispherical vaccines, Dr. Amit?
Yes, sir. So basically, the WHO says that this vaccine is decided based on the primary influenza activity at that particular region. So we categorize all over world 2 types of categories. That one where the influenza activity starts April onwards, and another category is where the influenza activity starts after October. So where the primary influenza activity starts after April, that is matches with the northern hemisphere strain. And where the primary influenza activity starts after October, that matches with the northern hemisphere strain. So based on the reason, the WHO has decided that which particular region should have those vaccine. So right now, see, the WHO decides or convenes 2 meetings in a year. That is one in February, and then second meeting in September month. And then they decide based on the previous data received from WHO GISRS, which is called Global Influenza Surveillance Research System. And from that GIRS, the WHO receives the data that which particular strain they have to decide. So like right now in February, they are deciding for the next strain which will be available in the for the next year northern hemisphere strain. And when they meet in September, then they decide for the strain that is available in the southern hemisphere. In India, basically, the WHO has put India into the southern hemisphere because most of the southern part of India, it comes near the tropical region, but the northern part, that is around Jammu Kashmir region, it is the basically the northern hemisphere strain which prevails. So India has a mixed type of seasonal influenza activity. So based on that particular reason, one should give the influenza vaccine, and whatever vaccine at that time is available should be given, whether it is northern hemisphere or southern hemisphere. Regarding the dose of the vaccine is for there are different 3 types of vaccines available. So out of these 2 vaccines, that is the Influvac Tetra and Fluarix. DCGI, that is Drug Controller General of India, has advised universal dose of 0.5 ml to everyone. But in case of flu quadri, the DCGI has not approved the universal dose, that is 0.5 ml. So children from 6 months to 9 years of age, we give 2 doses if they come first time, and after 9 years, we give, if required, we give a single dose of, we start with single dose of this influenza vaccine.
Very rightly said, Dr. Amit. Now we have only a standard 0.5 ml dose for beyond 6 months. Initially, we were using 0.25 ml up to 3 years. And this northern hemisphere and southern hemisphere vaccines till about 2 years back were practically the same. They remained the same for almost 2 years. Now for the last 2 years, every 6 months, we are finding a change in the prevalent strains. And that is how we have to now decide about which particular vaccine to use. The current vaccine, I think, as you rightly said, is the southern hemisphere vaccine, which we are using. And the work for the northern hemisphere vaccine has already started. And by February, they decide about the strains. They take about 6 months to make enough doses. And then what is the right season if you have a choice in a country like India when you should vaccinate? Ideally, it is say before the set of winter in the Western countries, because they have a very extreme and prolonged winters. But for a country like India, which is the best time, leave alone the babies who are born and you have to give them for the first time, for the subsequent doses, which is the best time you would like to vaccinate them?
So, as I said, sir, India is basically the WHO has put India in a southern hemisphere zone. But if you see in northern hemisphere, like in northern part of India, it is the northern seasonal flu which prevails. In the central and southern part of the India, it is basically the southern hemisphere strain, which most of the time is endemic. And mostly there are two peaks in the northern part of the India. The peaks are during the monsoon season, and then again there is another peak during the winter season. Wherein the southern part of India, mostly the peak season is during or after the monsoon. So if a baby, whatever vaccine at that particular time is available, you should give it. But suppose if the baby is from the South India, so you should give preferably the southern hemisphere vaccine when it is available.
Time of the year when you would best like to give the vaccine.
So time is before starting of that particular season. Suppose now the new vaccine, that is southern hemisphere vaccine, will be available in April or May. So you have to give 2 to 4 weeks earlier before that particular season of the influenza activity starts in that region.
So, Dr. Amit, you do get some post-transplant patients also, and some other conditions where you are immunocompromised patients. So, and even during pregnancy. So, do you recommend flu vaccine for all those patients also?
Yeah. Yes, sir. We recommend, as I said, the high-risk cases and pregnant women, we should give these vaccines. High-risk cases means cases who have chronic condition, kidney condition, or the diabetes, cardiovascular condition, or immunocompromised. We can give this inactivated flu vaccine, which is available right now.
So the intranasal live vaccine is no more available currently.
Yes. Again, this Nasovac, which earlier used to come, the Nasovac, which was the live vaccine, is earlier was available, but it is not available right now. Yeah. But Serum Institute, which comes with name of Nasovac, they are manufacturing it for the overseas use.
For the overseas use. So till last year, I think overseas use was allowed for intranasal vaccines, but not in India.
Not in India.
So another vaccine which is given around this year's and which is very important as far as Indian subcontinent is concerned, the vaccine which covers against measles. There has been a lot of confusion and various schedules are in vogue. I mean, we were initially giving measles and then MMR at 15 months and then 4 to 6 years. Then we made a change and we started giving MMR at 9 months and then MMR at 15 months. So Dr. Lalit, would you like to enlighten us what is the current position about the MMR vaccine or the measles containing other vaccines as far as our country goes?
And sir, nowadays in the government launched a program on this MMR immunization. They put the vaccine as MR. The MR vaccine was started. Earlier it was planned, and then gradually with the vaccine hesitancy, and then this program was dropped out. And now the vaccine available within private sector we have is the MMR vaccine, which is usually one comes with Tresivac. It is coming with a pre-filled syringe now, and the another is a Priorix vaccine. The difference is basically in the antigen component. The Tresivac contains 3 antigens: measles, mumps, and rubella, EZ strain, LZ strain, and rubella RA27/3 strain. As far as the other Priorix, the one another company, I'm naming the name because that's the commonest one, which contains measles vaccine. The strain is short strain, right? And the mumps strain is the RIT4385 strain. The rubella strain is the same. Now, as far as the efficacy goes, the immunogenicity of measles titers are quite higher in the Priorix strain, and they have also reported that they have not reported any case of aseptic meningitis with those vaccine. As far as the schedule goes, the schedule has been the same: 9 months, 15 months, and 4 to 5 years of age, and it is a live vaccine. And it is given by the subcutaneous route, and the storage is 2 to 8 degrees. And these are the 3 things.
As far as the MR vaccine campaign, I don't think it has been shelved, Dr. Lalit. It is running all over.
In government setup, it is going on.
It is, and that is responsible for maximum coverage. in Delhi, there were concerns of some of the parents and institutions that how you can give MMR vaccine to children up to 15 years without their consent of the parents. So it was taken up legally and stay was there. So the current vaccine which is being used in the government sector in the state of Delhi is MR vaccine and not MMR vaccine, be it at 9 months and 15 months. So if you have say a child who comes in close contact or is otherwise prone to exposed to measles, what is the recommendation if he is less than 9 months? What would you do, doctor?
Then you can give an extra dose of this 1 dose of that vaccine, but that won't be counted as the routine immunization. Suppose 6 to 9 months of age, there is a measles outbreak, then 1 dose can be given of that vaccine. But that the routine schedule of 9 months, 15 months, and 4.5 years, that will remain unchanged. It can be given in an outbreak. Below 6 months, you have to give immunoglobulin. You cannot use the measles vaccine.
So up to 6 months, we feel the antibodies in the breast milk will not provide adequate protection. In the Western world, it is after 1 year or more that this particular vaccine, measles containing vaccine is given. But in our country, since the incidence of measles is fairly high, less than 1 year, we like to vaccinate as soon as possible. And in case of an unfortunate possible exposure or contact, we can give it anytime after 6 months also. But then, as you have rightly said, we need to give extra dose and we have to ignore that this particular vaccine was given, hoping that this will provide some protection. The recommendation as far as the MR vaccine is concerned was basically, besides measles, to reduce the incidence of congenital rubella syndrome, which, though we do not have statistics, almost 15% of the mothers which are investigated, they are rubella antibody positive. And again, we do not have incidence of the congenital rubella syndrome. So how many of them do give birth to babies with congenital defects? This was what was to be targeted, and this was the aim of the WHO, and India was one of the signatories to this MR campaign to reduce the incidence of rubella along with measles. And to that end, we had to achieve a vaccination target of more than 80%. Unfortunately, COVID has upset all the plans, even the states where it was given, was supposedly to be given to all the children. I don't know what is the current status. We don't have anyone from the government sector to update us, but we need to update the Delhi state body about this, and I hope you will look into this.
Definitely.
So are there any serious adverse effects that why everyone was so concerned about MMR vaccine, Dr. Lalit? And is there any, after you answer this, I'll put on the next question about certain restrictions on use of MMR vaccine about children who have been sick or who have administered blood products.
Right. Sir, there was actually the only issue was it was a routine vaccination was given otherwise in the schedule. So they had asked ki MR should be given to anyone, whether it is received or not. There were no clear-cut guidelines. MR has to be given. So parents are objecting ki whether our child has received MMR, then why should we go for MR vaccine? But the guidelines came that you have to vaccinate any child for get the MR vaccine, and that was also a part of this thing. And as far as the side effect goes, the side effect, otherwise when we are giving measles, mild side effects after 4 to 5 days, maybe in the form of a low-grade fever or a mild rash. In the case of rubella, the antigen, it can be just mild lymph node enlargement, which may go unnoticed. And in case of mumps, there can be a mild, parotid gland enlargement or low-grade fever. So in fact, the side effects appear after 4 to 5 days. So as I said, there was no major issue, but I think this was another issue than the legal, you said the legal obstacle was there. As far as the side effect goes, these are the minor side effects. As such, there is no major, because it's a subcutaneous vaccine, there's no major pain and this thing also. And the effects appear only after 4 to 5 days.
So, Dr. Lalit, I'm sure you will also agree with this, that there was a lot of, adverse comments about MMR use and its association with autism, though that has been long withdrawn. But we again need to reiterate it again and again to our parents that it has no association with autism and even SSP. There is no direct, say, diagnostic link of measles with SSP. So the side effects with MMR, whatever they are, be it local or systemic mild if side effects, they do not warrant discontinuation of the schedule. And in a country like ours, where measles, which interferes with the whole immune system of the patient, and with the falling incidence of, say, breastfeeding, this is one vaccine which we need to take forward. And the government is very serious about eliminating measles in the years to come. But there are certain conditions when we cannot give MMR, either if the patient has received some blood products or has received some immunoglobulins. You had requested me to share the slides. So these are the slides. You can go through this, or if a patient has received intramuscular immunoglobulins, either against tetanus or hepatitis B, then you should not give measles containing vaccines for 3 months. If the patient has received rabies immunoglobulins, you should not give these measles containing vaccines for 4 months. And if the patient has received specific immunoglobulin for varicella or measles, you should delay the measles vaccines for 5 months. After IVIG, which we give at times in our intensive care units for ITP, for Kawasaki or other serious disorders, you need to delay the vaccination by 8 to 11 months. When you are using blood products, if you have used packed red blood cells, it is recommended that you delay the vaccination for about 5 months. And if you have received whole blood, you have to delay for about 6 months. So if you want to add anything, or we move on to the next vaccine, Dr. Lalit?
No, I think this is this chart we should always keep it with us, because this is very important. What should be the duration now in the case of Kawasaki, and basically so many times now we've seen post measles this COVID multisystemic inflammatory syndrome. Many patients have received IVIG, and in an atypical Kawasaki means they have received, many of them have received IVIG. So we should be very careful with the gap between MMR and other live vaccine. That is very important.
So this was as far as the routine vaccines. Now we will briefly go over, if the panel is willing and the audience is still around. Dr. Raman, around this age, there is another vaccine which has been introduced as far as the IAP schedule is concerned, that is typhoid vaccine. So this typhoid vaccine given in the government centers was the polysaccharide vaccine given at 2 years. Now we have a conjugate vaccine available. Would you like to tell us something about it, Dr. Raman?
Thank you. So standard government provides typhoid polysaccharide vaccine, where there is 2 problems with it. One, the efficacy is about 55%. And second, it can be given only to children above 2 years of age. The data shows that 30 to 40% of typhoid happens below 2 years. And as much as 10% of typhoid happens below 1 year. So that way a vaccine is required. So once this polysaccharide is conjugated to tetanus and it becomes a typhoid conjugate vaccine, we can give this 6 months plus. And this vaccine is now available for last 8 years and is being extensively used. The efficacy is supposed to be around 85%. And a single dose is supposed to provide protection for at least 5 years. So 1 dose is recommended in the IAP schedule currently, 6 months onwards. And WHO also has endorsed it. And polysaccharide vaccine, it is supposed that has more of a role now in an outbreak situation where we want to rapidly vaccinate a lot of people. But if cost concern is not there, we should offer typhoid conjugate vaccine 6 months onwards, single dose.
There was some confusion about the booster requirement. Could you tell us about that?
So when the vaccine had come, there was in the initial IAP schedule 2 doses, one at 9 months, the other at 2 years. And the insert still says that you may give a booster after 3 years. But as far as the guidelines are concerned, WHO IAP, single dose is at present recommended and booster is not recommended.
So as you all must have observed that during this COVID period, when children were at home and not eating outside or drinking outside, the incidence of waterborne diseases drastically fell down. So the best way to tackle these disorders, which are spread through contaminated water or food, is by having safe hygienic practices and safe drinking water. Another disease which is transmitted by contaminated water is hepatitis A. Dr. Vipul, can you briefly tell us about the hepatitis A vaccines available and the schedule?
The hepatitis A vaccine, we have two types of hepatitis A vaccine. One is the live attenuated and other is the inactivated vaccine. Both are approved for the age of 12 months plus. And the inactivated vaccine, it is recommended in a dose of 2 doses at least 6 months apart.
Hello.
Attenuated vaccine is given as subcutaneously, and it is a single dose which is being recommended, which gives a robust immunity. As far as their efficacy is concerned, studies have shown equally robust efficacy, and as the years are passing by, since the live attenuated vaccine is there, the data of efficacy is adding to its support. So both are recommended in the pediatric age group. So one can use anyone available.
Are there any guidelines, Dr. Vipul, for people traveling from abroad to India about hepatitis A vaccine?
Certain countries have. India does not have that guideline. Certain countries recommend as a guideline to their people, especially the Western countries who are traveling here and are going to stay for more than few weeks. They ask them to take at least 2 weeks, preferably 4 weeks before their planned travel.
So since this is a disease with a very long incubation period, even if they have to, if they have forgotten to take it earlier, even if they take it before traveling, it will provide them some protection. So this is what the recommendation as far as people coming to India from the Western world is concerned.
Rather, from that point of view, even if they land here and get the vaccine, because getting a hepatitis A vaccine in the Western world would be a challenge for them, since it is recommended even to close contacts of an active case. So even if they are in the endemic and as soon as they land up, they can take a vaccine, it will offer some protection. And then the second dose can be given if they are planning to stay longer.
Now, Dr. Naresh and Dr. Ankur are asking me to wind up. I have 4 more vaccines, but I can cover maximum 2. So, which ones would you like to cover? Rabies or Japanese encephalitis, meningococcal? Rabies?
Sir, rabies cover lete hain.
Rabies. Amit, can you tell us about the rabies vaccines available and what is the post-exposure and pre-exposure schedules?
Yes, sir. Basically, there are 2 types of vaccines, rabies vaccine. One is cell cultured vaccine and another is duck embryo vaccine. The cell cultured vaccines are again of 3 types. That is, one is varocell cultured vaccine, then chick embryo vaccine, and then human diploid cell vaccines. So all 4 vaccines are available in India. They are inactivated vaccines. They comes in 1 ml vial and then 0.5 ml vial. The varocell cultured vaccine comes in strength of 0.5 ml. You can use any of these vaccines. And regarding the dose, that is pre-exposure and post-exposure prophylaxis. Usually we use post-exposure, that is PEP prophylaxis, as the national schedule recommends that there are 5 doses, that is 0, 3, 7, 14 and 28 day. Single dose, either of these vaccines as a post-exposure prophylaxis. And some like WHO also recommend 4-dose schedule, but that you can use as alternate schedule 4 dose, that is on day 0, 3rd and 7 and on 14 to 28 day. So 4 dose schedule which is called as shortened SN schedule, and the 5-dose schedule is called as SN schedule. And in government setup where this rabies vaccine is given, they use the intradermal schedule, that is 8 doses on different days, that is 2 doses on each day intradermal in both deltoid region on day 0, 3rd, 7 and 28 day. So these are the schedule, but in our office practice we use this intramuscular schedule of 5-dose schedule.
So a lot of work has been done in rabies vaccine, and I remember the days when getting rabies vaccination was worse than getting bitten by a dog, and you had to take 14 neuro vaccines, which cause a lot of adverse effects. Now we have very safe vaccines, and I think this is the time when you should introduce pre-exposure vaccine to those who are at the risk of exposure. And keeping a pet in your home who is vaccinated against rabies still does not provide you adequate protection.
Yes.
Because the protective levels in the animals is not good enough after the vaccination in them. So what is the pre-exposure schedule recommended for those who would like to keep pets? And I think as pediatricians, we should recommend to all our parents who like to keep a pet as well as have small babies at home.
Yes, sir. Sir, India is a high risk for rabies, and every child less than 15 years of age, they are highly at the risk of animal bite. So indication as suggested for pre-exposure prophylaxis is who are on high risk, on like kids who or families who have a pet, they should go for, every member of the family should go for pre-exposure prophylaxis. Then persons who are in continuous exposure like veterinarians, doctors, or in lab persons, or persons who are working in zoo, or travelers who are going into the rabies endemic area, they should get this pre-exposure prophylaxis. So pre-exposure prophylaxis is, there are 3 doses that can be given intramuscular or intradermal. And these are given on day 0, 7 and 28 days. So there are 3 doses for pre-exposure prophylaxis. You can use intramuscular, or if in government setup, you can use intradermal. For intradermal doses, as recommended, only the varicella cultured or chick embryo vaccines are recommended for intradermal route. So this is for pre-exposure prophylaxis.
So though it is not enlisted as the people at high risk, but we often get our intensive care doctors worried when you have a patient who's unconscious and with doubtful history, or at times no available history of bite. I would like to suggest to my intensivist friends to take the pre-exposure rabies vaccine, which is safe and effective. And I think this is one of the vaccines which all people working in the intensive years should take them, because this is a near fatal disease. And if you are not sure, then they end up, once you diagnosis is established later on, then you end up taking immunoglobulin. So just a couple of words about the immunoglobulin administration and when to give it.
Yes, sir. So there are 2 types of passive immunization available. One is that immunoglobulin, another is monoclonal antibody. The immunoglobulin again are 2 types, that is human immunoglobulin, that is human rabies immunoglobulin, and another is equine rabies immunoglobulin. And the other is monoclonal antibodies, that is human monoclonal antibodies, and the second one is, which is recently introduced, is twin rev, which is murine, that is cocktail of 2 monoclonal antibodies. So whichever immunoglobulin or monoclonal antibodies are available, you should give it, but preferably in our private practice or office practice, we should use monoclonal antibodies, because they are cheaper also, and you can give them easily because their dose is less. And these the twin rev, which is recently introduced, is little bit costlier, but still very effective than the human monoclonal antibodies, and it should be given preferably.
So in rabies exposure, which category of bites would you like to give immunoglobulin in an unimmunized person?
Yes, sir. So there are, as you know, there are 3 categories, and in category 2 and 3, we after exposure we give this 5-dose schedule. But in immunocompromised patient, the category 2 or even category 3 and category 2, both cases, we give immunoglobulin plus this 5-dose schedule.
Dr. Amit, you were sharing with me a very interesting way of finding, because so many times you find a patient who comes to your clinic कि पेंट के ऊपर से काटा है, there is no bite mark, there is local erythema.
Yes,
and
sir.
you are in a confusion whether to decide which category to put this patient into. So
Yes, sir.
how would you recommend to solve this problem, whether to give immunoglobulin in those patients or not?
Okay, when there is a confusion, when that there is a category 2 or 3 bite is there or not, so we can do a simple sprit test, which is recommended. So you just apply over that area a little bit of sprit. So if it causes burning sensation, that means there is a breach in the skin. So that means that is the category 3 wound, and you should give immunoglobulin with the vaccines. So that is called a sprit test.
So this is a very simple test which everyone can do it in their clinic. And the parents will always be reluctant in taking those vaccines unless you explain to them. So let them take the responsibility of not taking the immunoglobulin, and you can just satisfy yourself whether there is a break in the skin or not by applying spirit locally. If it is burning sensation, there is a break in the skin, give immunoglobulin if it is unimmunized.
Sir, one more thing I will say, this will be present only if the patient comes, you reports you immediately. Patient reports after 2 days, then this test will apply.
Usually those who are scared will come to you immediately. If they come after 2 days, naturally it's very difficult to tell whether there was a breach in the skin or not.
Even
so if you want to play safe,
another one thing, confusion should not be there. If there is no bleeding and if there is a burning, we will go for grade 3?
Yes, if there is burning, that means there has been a break in the skin.
Okay.
That means the nerve
if there is bleeding, that is clear-cut break in the skin. If there is
any drop of blood makes it
bleeding.
Any drop of blood makes it category 3. So then we have to go by history.
Problem
if it's a wound wound,
local
we have to go by history.
No bleeding.
Any drop of blood.
No bleeding. I am saying no bleeding.
Then of course it's difficult.
So if a patient comes to you late, what I would advise is to counsel them properly. It is better if you are not sure and you are concerned to take the rabies immunoglobulin, monoclonal antibodies, which are safe and effective. If you don't want to take it, you prescribe it. At least you are safe.
Yes, definitely, sir.
Because in today's time, just treating and treating with protection and proper advice, both are very important. So, do we have the time for any more? Or I know we can go on for another 1 hour, but we would like to wind up, and I would like to thank my panel. Just if you can tell us in 4 sentences about the Japanese encephalitis virus, which is never discussed, but we are the neighboring states of 2 states where you have Japanese encephalitis as a routine, and a lot of us practice in the intensive care units where you have Japanese encephalitis admissions rarely transferred from other hospitals, from the neighboring states. So as brief as possible, Dr. Amit, if you can tell us about Japanese encephalitis vaccine, and then we wind up.
So this Japanese encephalitis is endemic in India. Many states and districts near Delhi, Punjab and Haryana is affected. So in a universal immunization program where the disease is endemic and government is giving this vaccine, the government is giving which is live attenuated vaccine, which is imported from the China Chengdu biologicals, which export the vaccine. So we give 2 doses in those under UIP, that is one at 9 months of age with MMR, and second dose at 15 to 18 months of age with DPT booster dose. In the office practice or private setup, the killed vaccine or inactivated vaccines are available, which comes with inactivated SA1414-2 strain, which is available. And there are 2 doses are recommended. If child is between 1 year to 3 year of age, then 2 doses, 0.25 ml. And if it is more than 3 years, then 0.5 ml, 2 doses. another vaccine which is called Kolar strain vaccine. And again, it is inactivated vaccine for which is Kolar strain. Again, this vaccine is given in 2 doses, which comes Genvac with the brand name of Genvac. And this is given above 1 year of age, 0.5 ml, 2 doses. The earlier inactivated vaccine, that is SA14-14-2 strain, comes with the brand name of G vaccine. So we give it as a we can give it where the this endemicity of Japanese encephalitis is there. Definitely, persons practitioner on PICU setup, person should get these vaccine also, 2 doses.
So with this, I'm forced to wind up. I know we could have gone on for a long, and vaccination sessions, they never end. Because this is always enriching. We would take any further queries which have come up in the chat box. We will try and answer them in the mail, or put the answers in our at our site. As final winding comments from all of you, Dr. Lalit, Dr. Raman, Dr. Vipul, would you like to add anything before we wind up?
Thank you, first of all, sir, and BLK. I have already saying it has been a wonderful thing. Had we met physically, I think it would have been just char chand lag jate. As always, BLK, we always enjoy those scientific updates. A Sunday program in February 3rd or 2nd week. We always meet each other. Now, this is a highly distinct. The situation is such that we have to meet virtually. Anyway, we had a good discussions on a few practical points which were discussed by everyone. And that was really nice, sir.
Thank you. Thank you.
So we can have another session someday on the vaccine.
Hopefully, our June meeting, if possible, we will do it in the physical mode.
Yes.
Our turn to hold the IAP meeting is in June. So if things improve and most of the health workers are vaccinated, we'll try and hold it in the dual mode, if not completely physical.
Yes. I'm praying that this should happen.
I know. Your presidency is also going the Dr. Naam's way.
Let's hope, sir. Things change, sir. Mutate something from this angle,
Sure. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, Raman, Dr.
Thank you, Dr. Lal, sir. Thank you, Dr. Naresh Lal. Nice to have you.
Thank you very much.
Thank you, sir.
Thank you everyone for staying so long. Thank you. Over to you, Naresh.
Yeah. Thank you, sir. I think we'll wind up the day. That was an excellent talk by you and Dr. Lalit. And I think exhaustive review. And all other topics went well. And though we had exceeded the time, I think, but it was in the greater good. So
Dr. Bhandari is still here with us. Dr. Bhandari wants to say.
Topics were nicely covered.
Dr. Bhandari
I would like senior people to comment. Dr. Alok is there.
Dr. Bhandari, sir.
I'll just say it was a Sunday well spent. I really enjoyed the sessions and it was really great. Great as usual for Team BLK under Dr. Bhasin and Dr. B.B. Agrawal and the Young Brigade. God bless you and God bless BLK and the pediatric fraternity. And let's tide over this COVID times, and shortly and surely we will be meeting soon. And Dr. Lalit's charge will be taking IAP Delhi very high. Definitely, sir.
Thanks for the blessing, sir. Thanks for the blessing.
Thank you, Dr. Alok. Alok is one of the most active pediatricians, and he's taken pediatrics to limelight. And I wish him all the best in his future endeavors. All the best. Alok, you are our flagship carrier.
Thank you, sir.
Very good, sir.
Thank
you, everyone. And over to you, Naresh, to wind up. Thanks to all.
Thank you, Dr. Raman and Dr. Vipul. Thank you very much. And Dr. Amit Tyagi, thank you.
Thank you, sir.
Thank you, everyone. So, till we meet again.
Okay, physically.
Yes, sir, definitely. Okay.